Buenos días.
Good morning. Hope you're good. Thank you for being here on a Saturday morning. So I hope you had a nice evening last night. I hope you enjoyed your time in Madrid. Yesterday we had a very complete day with many announcements, many interesting things. We presented for the first time a device that the company has been working on for a very long time, and we're all very proud of this device. We went through different clinical cases with some scientific and technical aspects. And today we're going to continue with 4 blocks, and we'll move into the shock waves, diamagnetic shock waves. So we're going to start today with Estefanía Torres and her paper on new physical and biological concepts about shock waves. Thank you.
Good morning, everyone. It's a bit hard to be the first one, and we're getting started, so please join me in this journey. So I'm going to speak about new concepts of physics and biology for the shock waves. And I thank Fisaudi and Paraiso, and obviously the University of Rosario, to which I am part of. So to get started about this, I'm going to give you some context on what a wave is. Well, a wave is a propagation that goes from one medium to another one, bringing energy, carrying energy, without carrying any material. But a shock wave is the same wave, but they're acoustic and they have high intensities, they generate some pressure, and they get out, creating some effects of mechanotransduction. So when we connect a shock wave, we generate a magnetic effect, like a shock, an acoustic effect that generates biological changes in the tissues. So there, in these ones, their characteristic is they have high pressures that will go through the sound barrier. So in these shock waves, they can be transmitted as the same as any other shock, any other wave. These are acoustic waves, and they generate very strong changes in the tissues they'll be working on. So it is defined as pressure waves that generate in supersonic speed. I want you to have a look at this picture so you can have a context of the different waves we have. We've got radial and focus waves. They're called radial focus waves, but that's a wrong name. They should be called pressure waves, because if it's a radial one, it would be through compressors in which they launch a reel and they shoot a transmitter, and then the transmitter is the one that sends that kind of impulse. So when we have this radial, we need to bear in mind that we'll be working in a superficial level. So we need to work in soft tissues. So we can all have some context. You can see that there will be some specific qualities, and it is that they have a very low intensity, so they don't travel that much. And the areas we can have is many of them. So you can have different techniques, and then have work in different places. And in the focal shock waves, you're going to see here, it has a positive pressure and then it goes down, it drops drastically. And I want you to really pay attention to this, because I'm going to show you the different changes that we have had. Thanks to this focal shock waves. So that's all an acoustic pressure, and it gets concentrated and it goes towards just one point. Here Usually the shock waves or the pressure waves, they generate pain, they create pain. But the new updates we've had have developed technology without generating that pain. In this case, it would be diamagnetic. So this focal shock wave, we can work from the soft tissue till the bones tissue. So we can even go to work 6-7 centimeters below that that tissue we have to work on the one specifically that we want. So here you can see the difference. So the focused shock wave is characterized because it goes up with its positive pressure. This is, we work it with pressure, with megapascals. The duration would be the point that you can see in here. And in this too, where it goes up, it generates the changes in tissue, then it goes back down and generates a negative pressure. On the other hand, the radial shock waves have the possibility of having a longer duration, so they're not as invasive. Here you can see that we've got many things to bear in mind. First of all is the frequency. That is the number of waves we have in a second. The intensity, there's the peak, the highest peak, that's measured in megapascals, and the duration, so in how long it will be done. The ways of producing the shock, well, there are many of them. They can be electric, electrohydraulic, electromagnetic, and diamagnetic. So we're going to see some of the concepts about shock waves. So as I was saying, we have a process of mechanotransmission. So there is a mechanic effect that will become into an effect that will create some effects. One of the great things of the shock waves is that this biological conversion becomes at a matrix, it changes in a matrix level. So we can do work in new ionic channels that can get to activate the nucleus. So we can generate angiogenesis, production of growth factors, generation of tissues through nitric oxide, and we can also have a proliferation of the cells. All of this takes us to this regeneration of tissue. So here, please have a look at this picture where we can see the effect that it has in the bones. So here we activate some processes. The morphogenetic protein, for example, it gets higher, the vascular factor, cell proliferation, and new vascularization. So all these hypotheses add up when you use a shock wave. So the tissues will be regenerated. So every time you put that shock wave, you will create generation of the tissues. We can work on the bones, we can work on the tendons, on the skin, in many different tissues. So here we'll work in the production of the diamagnetic shock waves. I've used many shock waves, of all of the ones we can have, but since I got to know the diamagnetic shock waves, I was fascinated about it. It's very impressive because this shock wave is generated through diamagnetic. So you can see this picture here, so you can see what's in the technology, and this is that they've got an electromagnetic bovine through which the magnetic field of high intensity just turns. So what's this high intensities? So to speak of the magnetic induction vector, because that vector is the one that's turning, then we could say that a Tesla, it's 1,000 gavas. So that's what generates this effect, and this is why the tissues then, these diamagnetic tissues get in touch with the magnetic field. Then they've got the option of rejecting that magnetic field. So then the bodies that are exposed to an induction, they have three alternatives, three options. The first one, be a tissue ferromagnetic, and then it will be attracted to the field. The other one, paramagnetic, it is then nothing happens, it just stays put. And the diamagnetic, that is the one that rejects this magnetic field. So then, who do you think we can use this on? Obviously, the human body, the water, some proteins. They have diamagnetic components. So the cell membrane, so when we speak about this membrane, we can work with it. We can work this function of rejecting these diamagnetic substances. So we can have a very good effect on the tissues. So when we speak about this induction magnetic field, then we use some discs that are the ones that you can see there in the picture. They have an alliation, a magnetic alliation. So when the magnetic field is being produced and then it finds this diamagnetic disc, then they reject one another. So whenever the field gets loaded up, that's when we get this impulse. So then I would ask, so much intensity, 2 Teslas in this bovine, isn't that going to destroy me? Well, of course not. I'm going to explain the different electromagnetic forces you can see. We use it when doing body rehab, laser, radio frequency, all of that. So we've got different parts. The ionizing radiation, the one that's breaking up tissues, and the characteristic is they have the frequency, the cycles are very high. And these are the cosmic ray, X-ray, but then if we go to the other part, to your left, then is the one that are non-ionizing. So those things that only generate stimulation at a cell level. So we're here in 7 Hz. So we're within the range of low frequencies. These ones are very much related to the stimulation. So it is very safe to use them. We use long length till 6,000 kilometers with 7 Hz. So it can be 2 Teslas of energy and we wouldn't be creating any damage, just some stimulation. So then these diamagnetic shockwaves, it's just fantastic because we've got the conventional shockwaves, but they can be used in different ways. Every time we have a magnetic cam and we connect it to a magnetic field, we use it because we are electricity at the end of the day. So we generate electrical charges in our bodies. So this diamagnetic technology is strong enough because they are 7 Hz of the magnetic field, but when it goes in the tissues of the human being, then this frequency gets adapted to the capacity, to the vibrating capacity of our tissues. So then we can get to work and stimulate many tissues, getting to that stimulation that we're looking for. So then, why do we want to have this shockwaves plus diamagnetism? Well, the first thing is to use it to move liquids from the inner part of the cell to the external part of the cells, but we can also work on endogenic biostimulation as well. So to help the cells to regenerate, we can also have control or modulation of the pain. How can we modulate the pain? Well, the shockwave itself works on the modulation of the substances. It also works to work on that pain. How does it work then? Well, stimulating through mechanoreceptors all the fibers A beta to get those ones, and the fibers E, the ones that are the ones carrying the pain. So then you can break that cycle. So because we will give oxygen to the area to create new blood vessels. So then, here the shock waves, you can see it has an impact. So this impact, as you can see, these kind of rings. So these rings are called, well, all of it comes from a theory of the Fresnel optica, and that is that convex lenses can have the same capacity and be more effective when they put the disc, when they put it just horizontal by creating other circle ones, so they can focus, they can concentrate the energy in an easier way. They can be more concentrated, this energy. So what you can see here is like some waves. There's the effect of the diamagnetic field, that it's usually wider. So you put the shockwave there, but you can also put the diamagnetic shockwave. So the shockwave will create the effect that I was talking before, and the diamagnetic wave will complete this treatment, making it painless. Something that's very important in the shockwaves is that we have a picture that you can imagine, the positive pressure, negative pressure. So the shockwaves are usually used when there are chronic pathologies, because for example, if it's a tendinopathy for a person that's had it for many years, this person has been in rehab, has been in surgery, but nothing changed. Then let's try this shockwave, because it creates a swelling effect that goes to the cascade, and then we can rehabilitate it from the beginning. So with these shockwaves, the magnetic shockwaves, we can regulate the front of the wave, so we can get to have the same intensity, but we can do it for longer, so the intensity won't be super peak, but we can just make this intensity to go softer, less impactful. So this front of the wave will be put in acute pathologies, so we can work a bit more from the beginning. And then we have some effects that we can use. It is reduction of local swelling. Obviously also about these blood vessels, because it releases nitric oxide, and that's why it gets you to generate a regeneration. So there are also reparation processes and restoring mobility in the joints. Here we've got the Fresnel lenses. These lenses have got their characteristics because they have rings, and these rings, when there are more rings, then it will be more superficial for the energy, but then you can work with 2, 3, 4, 5, 7 centimeters with diamagnetic. And here you've got the one that's not focused. The one that's not focused is like a radial one, and I wanted to see the picture. Imagine that whenever you're in a river, you throw a pebble. The pebble then creates these kind of waves, doesn't it? Well, this is what happens with the shock waves. This is why I like to complement treatments. I work, for example, plantar fasciitis, and I put the lens, and I put the one that's not focused to end all the contractures. It's so effective that we've got a patient who has very big muscles, who's got lots of crease, and this person had a tendinitis. So we worked on it with this diamagnetic shock waves, and it was just fantastic. I don't know if you listen to it. For example, the bad things. Whenever there is an iron in the area. Nowadays, the chirurgical material don't not have iron in general, but we need to be careful, because otherwise it could be just cancelled out. So if we cancel it out, then this diamagnetic shockwave, it will only be there to reject the disc, so just like a normal one. But whenever we want to have the diamagnetic one, the magnetic field will go out in order to penetrate. So it's much more effective. Then we can focus thanks to the lenses, and we're speaking about energy as we saw it in this evidence where we want to have 0.05 millijulion. Enough fasciitis, it needs to be 0.3. So it depends on what we want to work on. You can work in percentages that are equivalent to the millijulions that we can see. In the diamagnetic mode, we can work through edema, swelling, and here you can see this picture. So you can have some tips. I like to work on energy because obviously the energy is lower for soft tissues and bigger for bones, but then we can work on rise. So there could be peak moments, but then acute moments and under acute. So depending on if it's going to be very deep or bone tissue, soft tissue, and everything depends on the acoustic impedance. What's this impedance? This is this resistance to the magnetic field. So if there's less impedance here, then this is how it will work. Well, and then as you can see here, with the shock waves, with the diamagnetic shock waves, we can work on acute pathologies for very strong pain, if we want to drain, tendinitis. And I would just like to invite you to our second symposium for advances in biotechnology, dynamic biotechnology, that we'll do in Rosario this year in Bogota in Colombia, 6th and 7th October. It will be a fantastic symposium. We'll have brilliant speakers, and we really would be very happy if you could be with us. Last year we had the first symposium and it was just magnificent. So if you want to see what happened, we've got some records about it. And again, thank you very much.
Muchas gracias. Gracias, Estefanía Torres, por tu intervención. Ha sido de verdad muy didáctica y nos ayuda a entender.
Thank you so much, Estefanía Torres, for your paper. It was amazing to see that this is a very special shockwave that we get from this device. So before we move on, I'll just very briefly remind the colleagues that we need to stick to the time very strictly so that we are on time. So all the speakers have a screen here with the clock so that you can see how much time is left for your paper. And at the end of this block, at around 11 or 10 past 11, we'll have time for a coffee break. And after the three speakers, we'll have a round table with time for Q&A where you can ask your questions to our speakers. And now we're going to have a very interesting paper. We will be hearing how the special shock waves can work in acute pathologies. So please, Karen Cardenas. Good morning, everyone. I'm so happy to be here with you today. So I want to thank Marisa and Dr. Felipe Torres and the whole team. First of all, I want to thank all my team in our clinic. And now you will understand why. And the goal of my paper is to share with you our experience in all the clinics where we have these the devices. And the first space is the trauma room. Then we'll move into pain clinic and then the ICU. So it is all severe cases or acute cases, and I will explain how the cases are, how we do it, and many things related to the operational parts and systemic part and the medical part. And I hope you will enjoy. So when entering the trauma clinic, we are in Colombia, in a small city, and with a reference center for all the traffic accidents in Colombia, in our region. So normally these different problems at the beginning, there was no beds available, and the surgery times were delayed because of the edema, and there was no surgical material for the surgeons to work. So there was a big demand on drugs because the patients had a lot of pain, and the complications because of infections was also quite high. So we drew a plan, and since we are the reference center, we wanted to do something different. So we brought the devices to the trauma department, and we assisted the patients here in the ICU, and also in surgery, and people in the hospital. So it was for the patients before the surgery and also after the surgery. So we brought this high technology to these rooms. So we worked with all type of technology before, but to Paris, so really made the difference. So our surgical time, we managed, it was 7 days of delay. We managed to reduce this by 2.5 days. And now we're missing still some surgical materials, but the patients are much better and no edemas. And before this, the patients want to have more and more drugs every hour. And with these devices, we managed to distance or to delay the consumption of drugs. So the costs went down in the clinic in terms of drug consumption. So since it is a trauma room, we receive many patients with problems in this spinal cord trauma. This patient had an injury by a fire gun with a fracture in lumbar number 1. And the neurosurgeon said, "There's nothing I can do. I cannot access," and he didn't start the protocol. We started the protocol. We have a window of 36 hours after the trauma, and here we started after 12 hours. So how do we do it? The patient arrives. We start with an impedance symmetry, tetrapolar, if possible, and then we measure all the muscle weight, and then with that, we start our intervention plan, and we do different physical tests if the patients allow. In this case, there was no mobility of the legs, so we did this just with the arms. Then we did the hands dynamometry to measure the strength in the hands. And with this, we prepare a rehab plan. We are doctors specialized in sports, so we prepare the exercise planning inside the hospital. Also with the sports people we do, but we do this inside the hospital mainly. Also, we do measure the exercise load, and we do a synergy with the devices. So we started here with hyperbaric oxygen 24 hours after the trauma. 5 days in a row. Also, we did a Diamagnetotherapy with a neurodegeneration method with a superinductive system in the consolidation area of the fracture, and radial shock waves with low pressure, high frequency, 4,000 shots, 5 vertebrae above the lesion, and also the vertebra underneath the lesion. So with the CTU Mega-20, we would do at the same time shock waves and diamagnetic pump. So the pump, we would have 5 vertebrae above the lesion and the shock waves on the feet soles. So we did this continuously until we would do 20 sessions with the patient. And after 25 days, we had the sphincter control. After 30 days, we were within the gym with bigger loads. We started telling them, hey, you now you need to move your arms to get stronger because you're going to depend on your arms. So the commitment of these patients was very favorable. And look, after 38 days, look at the weight. And we had different therapies, support, physical therapy, neurosurgery also. And on the 15th of June 2022, the patient had a prosthesis and could walk. On the 20th of August, he could already travel alone by car. And normally he looks after the kettle. And in November, he was already riding his horse. And he participated in a competition. And he was second. Here you can see. That's amazing. That's one of the most fascinating cases that we have with spinal cord trauma. So 1 year and 3 months after, he told me, doctor, I start feeling my other leg. So I want to have CTU. So please, I want to work with the pump. So I said, well, let's see. So we did another 20 sessions 3 times a week. I started to say that he would feel some shocks, some electric shocks, and rotatory feeling here. And he started to lift the foot. And right now, Juan can walk. He's missing 20%. You can see he can walk with his Canadian walking aids. And in the last video, you can see he can walk with the help of his friends. This was 2 weeks ago. He can dance. He has a very positive attitude. And for craniofacial trauma, this is really good because it is just 1 day with CTU Mega-20. And the maxillofacial surgeons, we are now in need for them in the trauma room. So they always say, the surgeon says, I'm not going to see the patient before the CTU. So now here they can go for the surgery 1 day after, because he did day 1, day 2. Here we had exosomes on this patient. I'll show you later how the graft looked, because here we had exosomes and we devised Omega-20. This is also a very beautiful case. This is a friend of mine, the orthopedics trauma expert, Ramon. And the patient wanted to preserve the foot. and we had plastical surgeons, and she was a colleague of ours. She was a nurse. It was slippery, and she was on her motorbike, and the truck drove over her foot. So we managed, and we avoided the amputation. The doctor did a very good surgery, but unfortunately, the first part, died. The first piece that was inserted. So the first flap did not work out, but then it worked after that, and this was a few days after we were training with the pump, and this was after 2 months. And right now, she can already walk with no support. Our mobility is perfect. She started to work, and she came back to work after 4 months with no pain now. And she continues with physical therapy. We continue with CTU, with shock waves to manage fibrosis. And she's amazing. And this is on the hand. She's a bacteria expert. She suffered an injury with a fire gun, and she had a fracture with on the head of the first metacarpion. So the surgeon said, well, this is not possible. I'm going to do an arthroplasty with interposition so that she can move, sort of like doing like a lever movement. But, it was difficult for her because she was a bacteriologist. So we started our protocol with focal shockwave. This was the protocol that we used. We used 5 sessions once a week, monitor therapy, 15 sessions weekly. Also hyperbaric medicine and a psychological treatment that I had never had before. And she managed to deal with depression, with the post-trauma situation very well. And after 2 months, we can see the evolution here. We see there is a bone. The head of the bone was rebuilt. She loves the disc dog sports, and now she has perfect mobility. She can hold it. And obviously this we did with a team of occupational therapists and physical therapists and exercise. But precision of the holding of the hand is already working. She went back to work after 3 months. The other area where we work is the pain management. So in this case, this is a sports teacher in a very good health, and he had a herniated disc, post-lateral left, with a compression of the root S1 left. This I didn't manage to see. I needed to have a video session, video conference, because the patient could not move. He was in bed. He could not get out of the bed. And the first consultation was in bed, but I said, well, no, we'll have the images and radiographies and everything, electrographies, but I need to see you. So he came in April. He had to take a flight to come to our clinic. And in this patient, the recovery was super quick. It was 1 week. He managed to go back to work after 15 days. And we had 10 sessions of CTU Omega-20 and diamagnetic treatment with shock waves, hyperbaric oxygenation, five continuous sessions. It was all continuous or intense because he wouldn't live in the city, and he had to go back, and his wife had to go back to work. So we had to do everything within 1 week. So it was intense treatment with this result. On day 2, he was able to walk with some aid. He managed to sleep again. Before that, he would only sleep 1 to 2 hours a day. And on day 3, the pain had been reduced by 30%. On day 4, he could walk with no support or no aid. Day 6, 70% improvement of the pain. And day 10, 90% of the pain was gone. Then he traveled back to his city, and day 13, he was back at work. He remains with no pain, and he has a physical job. So he had a commitment to reinforce his abdominal area, and it was quite easy because we would give him the instructions so he would understand all the loads of the exercise, so he understood everything perfectly, so he could do things in the distance. Now this is a case with a trauma on the foot, and it was 2 years after the trauma. The patient had this electromyography. Here we can see an acute situation on the tibia with a reinnervation situation. So after 2 months, we had 2 weeks of treatment with 20 sessions. Oh no, my apologies. It was 2 weeks, 10 sessions of the pump, and 5 sessions of shock waves.
Movimiento lateral ya es prácticamente normal. Y se evidencia también que puedo subirlo. Ya se puede subir y bajar. Y los movimientos rotatorios son prácticamente normales. Falta muy poco por llegar a los
there was no
dedos.
longer fallen foot.
Solo los dedos también se pueden subir.
We removed the orthesis. And this was before I came here, 1 week before I came here. You can see how he can walk. And the electromyography, we see it is compatible with a partial lesion of left peroneal in the process of reinnervation. And this was 2 years after, where you could have thought there is no longer repair that can be possible. So here we had vertebrae fracture of a man who fell from off a horse with a big lumbar pain, and in the RMI we can see the different discs damaged. We placed intravenous exosomes and CTU Mega 20, 8 sessions, hyperbaric chamber, shock waves, 8 sessions also. We can see here, this is how it was. And 30 days after, this was the protocol. It was 10 sessions of shock waves. He came with a 3D CAT with a degenerative discopathy. So he was very shocked. He was like, maybe they were wrong. There is no fracture. And I said, well, yeah, this is very strange. Go back to the office. Maybe this is not wrong. This is not your image. But no, it was correct. It was totally resolved. And you can no longer see the lesion. So it ended up perfect. So we just need to continue with the treatment with the CTU for the discopathy, for the degenerative discopathy, and 0 pain. Then with one of the nurse that we had in hospital with the biopolymers, she was slowly going into sepsis. She had everything. Her wife was a doctor, so you can imagine the anxiety that she had, and she was going to go into the ICU. And in the ICU, they were told about this technology that could be useful. So the plastic surgeon did not want to work on this because there was a lot of edema and many systemic inflammation symptoms, and this could get complicated. So we started working on focal diamagnetic shockwaves. This was the protocol that we performed. Radial shockwaves and hyperbaric medicine. The response here was immediate. From day one, the fever was reduced. On day 3, she was sent home. And 2 weeks after, she sent me this picture. And here you can see the edema area. And she was already going to the beach just to enjoy with no pain. And the plastic surgeon said, well, then I'm not going to do an operation. Only if you have inflammation again, please come back. But keep doing these shock waves and then we can control the problem. And it's best not to have a surgical intervention. This was an elbow, very painful. It could not move much, only 90 degrees. And with just one session, we managed to improve it. We controlled the hematoma and the pain was gone. And the patient didn't live in the city, so she had to leave quicker. So she could not do this movement. So you can see here the extension, the rotation.
Genial. Perfecto.
It was
Ya
just one
estamos
session here.
más de 90 grados. Rotación.
So here we
Hazme
had a
así.
focal shockwave and
Eso.
CTU Mega 20. And the last one, this is the ICU. And this is an amazing case. When we were in Panama doing the opening, I was called, hey doctor, there is a patient who is very, very bad. And then we need to get the tubes into the patient, and the patient doesn't want to have that. And they were like, please help me, where's the pump? And I was like, oh, no problem, I'm in Panama, I'm not there, so we have no colleagues to help him. So we started in the ICU, inside the ICU with Magnetotherapy, because it was the only device that I could ask for people to bring it in a safe manner. And after 1 week, when I arrived into the city, I visited the patient, and we started working with a diamagnetic pump. And we saw that they had a national variant and we managed to regulate that a lot. He had a very bad breathing pattern, breathing difficulties. So in the diaphragma and transcranial, that's where we started the treatment. Thanks to Dr. Felipe, who was my guide remotely. So after 10 weeks, he was able to go home. It was a very, let's say, severe protocol. It was very intense or continuous. He's an engineer, but he was very strong. He wanted to go back to work. So he did all the exercises at home. Because he could not travel. So we have this protocol with 10 continuous hyperbaric chambers with 10 sessions of CTU Mega 20. And the CTU's wave on the hands and on the feet soles. And then after that, 10 hyperbaric chambers and 10 CTU shock waves all across the body, from the face to the feet. It was 10 physical therapies, 10 occupational therapies, strength exercises, and also with some whey protein and probiotics and prebiotics. And then he started here moving the arms.
Subes, brazo,
In this
hacia
case, the
arriba.
most difficult thing is the moving the hands.
Eso.
And that's how he started to get the recovery. So he was not able to touch his ears at the beginning. And now in this occasion, he already had a cephalic control. And he could open and close his eyes completely. And you can see here he can
hoy tenemos de
eat
control
again or answer
Sergio.
the phone.
Hoy estamos
And
16
now he,
de
before going into
diciembre.
the chamber, he could move his
Listo. Vamos a
legs
mover
and move his
brazo,
knees
tronco.
and the hips,
Perfecto.
rotation.
Hoy tenemos de control.
And he did some exercises at home. After 2 or 3 months, he could walk with his wheelchair. He did a lot of exercise. He was very committed to do the exercises. And after 4 months, he was like this. So he wants to say hello because he's connected online following this conference. And he loves the CTU Megatoni. He wants to buy one for everyone, for all his friends. And all his friends, all his community is connected over there because they want to know about this technology because of this case. Here in pressure ulcer, this is quite frequent in the ICU. This is quite difficult within these sores, but this patient allowed me to do this. So we had this sore and it was not closing. This patient has diabetes, and in 2 months he was closed as this. So he was doing exercise. He was in a coma status before, and he continued our instructions, and he did a lot of exercise. This is a case of COPD. And this is now over. It was difficult for the pneumologist from the very beginning. Someone was telling him, stop going there because you're just wasting your money. But he was saying, no, I'm not wasting my money, and I'm going to see my friend in the clinic. And she's great. So during the pandemic, we had so much work with problems of oxygen, and we lent him an oxygen generator. And when he was able to come out of home, he just wanted CT omega 20 all the time, and the shock waves. And he wanted to have bariatric operation, but the surgeon said no. With the situation of your lungs, you cannot do so. We helped him lose weight, healthy eating. He also was smoking, but we managed. We had 15 sessions on CTU omega 20, also magnetotherapy, and after 1 month, he no longer needed the oxygen at night. It was only 1 hour that he used it. He lost 20 kilos. And after 4 months, we managed for the anesthesia expert to say that they can do the operation, and they did the bariatric operation. And after the operation in the CAT, the pneumologist said, hey, so where is the COPD problem? He had the spirometry, and the pneumologist was saying, hey, explain this to me. I don't understand the situation. I don't understand a COPD patient who stops to have a COPD. So now he's sending me all the patients to work with me. So this is the patient with the perfect oxygen saturation. He had high blood pressure, difficult to control. Now he no longer has high blood pressure. Now he's not smoking, he quit smoking, he's doing a lot of exercise. So yeah, this was our results. So this was our very beginning. I love this picture because I never thought that this will happen. So I really thank you for being part of this community, of this work. And I thank you for your innovation because this really changed the trauma room, the ICU. So the ICU with the Mega-20 and creating all the protocols to work with it, it was not easy. And we've managed to have this in the health system in Colombia with all this technology. So I thank you all. This is my team at work. Some of them are no longer working in the clinic, but some of them are still with us. So I really thank you. Thank you.
Thank you very much. Thank you, Karen Cardenas. The videos were fascinating. The pictures were fascinating. So we've got a promising future ahead of us, but the present has already been fantastic. Okay, so we're going to get started. Estefanía Torres and Karen Cardenas. Then we will have you in the debate after the next speaker. And this is when we will have first roundtable. Okay, we've got now doubts. How do we work on post-trauma, combining shock waves? And for this, we've got here Michela Galizzi. Thank you. Thank you very much, everyone. I am Michela Galizzi and I work in Milano in a private clinic in San Raffaele, and I'm also a physiotherapist of the Special Forces in Switzerland. So I bring here my clinical experience and something that's very interesting that I have been working on. So when we've got our patients, my patients usually have problems in their skeletons, sometimes, for example, athletes who have arthrosis in their knees. And then when we've got a patient, so then the most important thing is to have a right assessment after we have listened to them, listen to what they need. Then I can see the options I have, and one of the options I have is therapeutic exercise, manual therapy, diamagnetic therapy, dry needling, or shockwave therapy, anything that we can find useful. So medicine has forgotten this interest about this magnetic field. In the last few years, we have this interest again, thanks to this technology that allowed the machines to develop magnetic fields of high and low frequency. This is very interesting because thanks to this, this creates a movement inside the body, whereas with the low intensity electric fields, then is not possible. So we can see a difference in the tissues as well. This is very interesting because we were speaking about pain. So one of the hypotheses about why the magnetic field, the CTU, is useful in this when there's pain is because when there's pain, there's also an electric change, and CPU normalizes this, and they interrupt the propagation of the stimuli. So there have been studies, this has been studied for a long time, and they've got a very high levels. when we use them for problems in the shoulders, in the elbows. There are studies of a level, and we have had very efficient studies. So having these two technologies, why do you have to choose between one another? Why then we just need the shock wave or the magnetic field, or maybe we can use both of them at the same time. So, for example, on the shoulder, I can use shock waves and magnetic field, or just the shock wave. So literature is helping us because the interest about magnetic field is increasing, and this has started being thought about because we can get the two therapies together. So the magnetic field has been efficient when treatment tibial fracture, lumbalgia, and as well as shock waves. So one of these studies is the treatment combined treatment of electromagnetic field and shock waves when there is a tibia fracture. So we need to think that 44% of the people who are older than 30 years old, they have one of these pathologies. So when we treated the 86 patients, then we could see that they could be treated just with shock waves and transduction of therapy, electromagnetic therapy. And the results showed that the person treated with shockwave therapy and high-intensity magnetic field, they had better results regarding the diminution of the pain and a better function. So then the results of this combined therapy were better. So the hypotheses were better because we could see that the interesting part of the shockwave is in reparation and proliferation phase, in the remodulation phase. And this is fundamental. The role of the magnetic field is fundamental. The magnetic field produces more collagen. So when producing this, when they produce more collagen, then their recovery is better. So also the resistance of the repaired tissue was measured to see the resistance of the tendon, and then we could see then that the resistance was much better in the patients who were treated with shock waves and magnetic field. This is actually very interesting also when preventing recidivism, because when there's a tendon that can absorb the energy better, then it's a tendon that that's more difficult to then have problems again. Another study that's interesting, well, it was for the recovery of the fractures that did not recover well. So then we saw that the magnetic field was a good option for the pain treatment, but also for the recovery of the function. Or the patients who were treated with magnetic field and and shock waves had have less pain and a higher percentage of recovery. So we need to understand what we can get from these two energies as well. The high intensity magnetic field, well, literature tells me that it can be very efficient for solving this pain, recovery, the functions, etc. But if I can combine these two energies, then, well, literature says that we're on the right path, because the articles I showed you were written 8 years ago. So now this combination of therapies is very recent, actually. So we need to understand the combination of the therapies that we're interested in and the responses that we can have thanks to these therapies. So, for example, mechanotransduction, etc. But at the same time, we need to know what the secondary effects, the side effects could be of these therapies, and then we can join them, we can use them together. So when we have a patient who has ESO, then these therapies could maybe not be effective. Yesterday we spoke about being very specific, so then give the patient the more specific treatment regarding time, cost and efficiency. So the time can be very different because in my case, I'm going to give you my experience with people in the army, and sometimes I cannot choose how many times I'm going to treat them. So just I will show you some clinic cases where I just had to adapt myself to the demands. But I'm going to show you as well the efficiency of a treatment. So the critical points could be also some stimulus for all the studies. They could be time, frequency, for example, when we have to use these shock waves. Regarding the shock waves, protocols are really clear, but regarding electromagnetic field, still is not that clear. I think there's much potential to development. So, well, these critical points I wanted to show you. In these critical points, we know that time can be different, and then the time for recovery can also be reduced. Let's get on to the practice. So this is a clinical case, May 2022. He started, he was feeling some pain in his knee. Then we had an assessment, we evaluated it, we had the scan as well, we had X-ray, and here we could see, we could see that the patient had arthritis, and in the literature we find many cases where these type of scans show this arthritis in a very advanced way, but with people who had no symptoms. So these type of tests do not lead us to think that maybe the patient could have such a high pain, such a strong illness. So we started the treatment with the shock waves. And this patient was a bit older than 50 years old. He was working in the army. He was driving a lot, so he had two problems: edema and then strong pain. So at the beginning we could reduce the pain with shock waves and with magnetic field. And obviously all of this accompanied by exercise and other things. These patients, at the beginning, most of it, even if we told him to reduce his activities, well, he didn't listen to us, so that did not help, obviously. And he was doing activities that required, that were like lifting weights, and I told him to use some support, because when he was starting to feel pain, that he couldn't even work. So then I thought it would be, I warned him he should use the support, but he didn't use it.
I farmaci, scusate. Quindi
But with the electromagnetic fields, we achieved goals that were actually very, very important, even if the patient was not being helpful. Mostly in these days where he could not stand pain anymore. Then November, the situation was actually quite bad, because and he decided to have bilateral hemiprothesis, because the pain was very bad. It was terrible. So we had the two protheses in the same day. He was in the hospital for a month. I didn't see him, we just spoke on the phone, and then after a month is when I treated him again in December. And in December we started the treatment again to improve the quality of the bones and the recovery of the bones when they had put the prosthesis, and then a treatment with the magnetic field to reduce the enema. In January, this patient went back to work. He hadn't been using the supports he was supposed to get. And this is the beginning after the operation. You can see the scars here. And in this case, we also use the magnetic field because regarding the effects, we can have a better recovery, and also the scar can recover better. It gets healed quicker because there are some substances like collagen that rise through the process. And as you can see, we improve the quality of the scar. These images come from November after the operation. This is a picture he sent me, and he was feeling very good with this treatment, so he took himself this picture so he would send it to me and to tell me that he wanted to do this treatment on his own. Just some days ago, 29th of May, he sent me this picture in which you can see he was back to work and he's doing sports again. He's doing like intense activities such as the one you can see. He's riding his bike in the mountains. So obviously his strength is not perfect, it's not to it's 100%, because as we said, the patient is not being completely helpful regarding some exercises, but the clinical result has been just wonderful. Another patient, another case, a patient who is 50 years old, an athlete in the army. He used to the sport, running every day, and while he was running in the forest, he had a sprain in his ankle. So the result was not just this sprain, is that he had many edemas in his bones. There were so many of these edema, these bone swellings, bone edema. He was suffering so much, so the patient was in so much pain, and he was told he would run again. And there was also, obviously, his psychological state was also complicated. It was something that concerned us because he was so used to doing sports and activities. All of a sudden, he couldn't do it anymore, so he was very depressed. So we started using these magnetic fields and shock waves. He started in January to do 3 treatments, because then he would go to do some training abroad, and he was going to be abroad for 3 months. So my goals were to treat him. I have my goals because I knew I could treat him once a week. So 3 shockwaves, 3 magnetic fields with high intensity, and thanks to this, his body started a biological process of recovery, because he was draining the swelling, and then he was recovering his bones as well. So we continued with the treatment. After a month and a half, we saw him again. We were just we were mid-March, and we still had well, you can see that it was a bit swollen, it was a bit itchy, so he couldn't run, but the result was good, and he started to run again. Like, he's obviously running a bit slow, but he can run. So I only saw him 6 times, but in this case he was very helpful because he was doing all the exercises we told him to. So it was because we used these 2 technologies, because they reduced the pain. Mobility was compromised. He thought he wouldn't be able to run again. And these could be some of the exercises we did, but there are other ones. So we've got here another different case. It's a bit of an extreme case. There's a patient who had a fibular fracture. When he came to us, So he had fixed, if we could say so, the fracture. So we got this kind of plaster off, and we used shock waves only just for one session. I could treat him twice with the magnetic field, but despite all of this, after 20 days, he went back to doing his activities. And it's also very interesting to see a case like this, because the person came here to accelerate the recovery process. And these patients used only some drugs, not many of them. This person who had the edema in the bone, he did use some drugs with the therapy, and this is another example of the same patient with the fibular fracture. And well, I hope you enjoyed my presentation, and I thank you for listening to me. Thank you, Michela Galizzi. That was also very impressive. The picture of the bike is not for everyone, not for all the type of audience. So we've got these machines, but it is true the cases were very complicated. Well, yesterday we were speaking about this magnetic pump, and we are vibrating again with these shock waves. So I guess we'll want to know more, and probably you have questions, so please do not be shy, do not be embarrassed, because we're going to start with the first round table of this block of diamagnetic therapy and shockwaves. So again, we call Estefanía Torres, Cardenas, Michela Galizzi. The moderator will be Gentian Cuko. So a big round of applause for all of them.
Thank you so much. It's been more than 20 years now after the use of shockwave treatment. So very clearly, technology has grown a lot. There's more and more uses, and different institutions promoting different uses. So it's no longer destructive energy from the first uses with for some treatments at the very beginning that were used for to treat kidney stones. This morning I was preparing a little bit of a surprise during my breakfast. I've used some devices by other manufacturers for shock waves, so I thought of an idea, and I want to apologize with Mr. Lagata, because I did a small experiment yesterday at home when I discovered this technology with the shock wave. When we talk about energy, we need to see the energy and what it looks like. So I did a very short experiment yesterday. This I did at home. This is something very simple, and you can see how there is something going through. I need to see, because the patients had no pain, and I was used for the patients, especially with a focal wave. Normally treatments hurt, but when I discovered the CTU, the shock wave, I was sort of like, I could not believe it, and I needed to see why. I needed to see if it was sufficient and why. So I did this experiment, and here I am now, 5 years after, talking about shock waves. So now we have a few minutes for Q&A. Good morning. I have a question for Dr. Karen. In the ICU, it is very interesting to treat acute trauma, and I loved your paper, but I would like to ask you, in what type of ICU does it work best? Is it for cardiovascular or for neuro treatments? And what type of complications could we have in the ICU? That's a great question. Thank you so much. We work in the multi-use ICU with cardiovascular, so it's a polyvalent, and also in the polyvalent room. So in the polyvalent room, we do more treatments, and we see sort of everything. We have for women after giving birth, for the pulmonary problems, toxicology. So it's a very varied. We work on edema, pain, sores due to pressure. So we work on most of everything with our patients. So we requested that in every bed we have some sort of intervention, if it's a neurological, pulmonary, or heart. But for heart issues, we're only working on rehab or heart rehab. So they want us in some areas we don't have CTU yet, but I want my dad to be treated also with exosomes. He had a positive echo stress for the inferior side. We placed some exosomes. Also, we treated him with a pump. And the day after, he was going to go for catheterism, and he was only applied 1 stent. Or it was going to be a minimum of 1 stent, but we didn't need to in the end. So it's a very good case. I'll share that with you also. There is a lot to do. It was not easy because there is a lot of skepticism, as you said. So if I don't see it, I don't believe it. But the different colleagues, the intensive care doctors and the orthopedy, because we got everything in the ICU and we treat everything for neurological cases, even urology. So we treat all the patients with all the pathologies. And the patients with polytrauma, can we use CTU together with the ventilation and monitoring? Yes. Yes, we've used it. For oxygenation, when we have to place it very close or on the thorax, when the tubes have been extracted, if they can tolerate at least, then we use it at least 5 minutes. If they don't need oxygen and no saturation, then we start doing the treatment. And that is where we do high rise, because we can have the patient treated for a long time. So it's very important to check the timings to do the treatment. But if the patient is with a tube and he's connected on the thorax, and we want to work on the legs, then we can freely work on the legs. And one last question, if I may. The treatment time, even though it's acute trauma, after how many hours does the patient see the results? Well, this we see immediately. So yes, it's in less than 24 hours. Yes, definitely, yes. So the role we have is the patients are leaving their beds quicker. And if we wait 1 day, they were missing 1 day, they will stay 1 more day in bed. So sometimes the patients come into the hospital and sometimes they don't even have a bed available, and sometimes we treat them on the chair. This is great against hematoma and to treat any lesions or sores and open fractures. We treat all the patients for trauma, so it's immediate treatment.
What you presented, it shows definitely that you combat the inflammation and that you induce these wound-healing macrophages, probably with the help of myokines, which come from the connective tissue. And you also showed that you can treat autoimmune diseases, but you have to catch them early, right?
Yeah.
Because when the autoimmune disease lasts longer, then you have a transition into M2 and then you cannot treat anymore.
Yeah.
So, but it should be definitely distributed among scientists and clinicians that there is an option for the early autoimmune diseases by your treatment. I think it's very, very important.
Ahora mismo estábamos hablando sobre ese tema.
Yes, of course, we were just talking about this, and
rheumatic diseases like the B727 syndrome.
Enfermedades reumáticas.
No.
En enfermedades reumáticas si has probado en sus fases iniciales, in early phases.
Yeah.
Yes.
see, we actually have a big experience there in rheumatic diseases. Basically, we've had in sclerodermia, and we've had some pathologies such as rheumatoid arthritis and lupus osteomuscular. There we had very good results. And in acute phases with traditional drugs, and afterwards with an interesting control, reducing the C-reactive protein and reducing, checking that interleukin 6 would go down after treatment. And even though it was something we were going to tell today, also in colitis ulcerative, calprotectin went down with a direct treatment with a pump on the fascia of the intestine. Yes, that's also quite interesting. And recently, we had a case of psoriasis, and it was a very acute case, and it was great results. And also, she was losing her hair, the patient, areata, alopecia areata, and after 2 weeks, all her hair grew again with platelets enriched plasma, and so she recovered all her hair, and we already have the evidence, so it's quite obvious.
Yeah. Yeah.
Okay, they go in the same direction, so you have an amplification system with the exosomes. Yeah, so that fits the issue, yeah. Very good, thank you.
Thank you very much.
And I have another short question to Michaela. How about the what is the condition for not treating with diamagnetic therapy?
Okay. The contraindication. So normal contraindication could be, for example, the presence of pacemaker, if you have something ferromagnetic inside your body, just in the place where is the ferromagnetic part, or if you have a severe heart condition, because you move fluids, so it's a contraindication to move too many fluids in such a condition. So that is not a lot of contraindication. And nowadays, in different, according by the country, tumor. So, for example, in some country, you have to wait 5 years of negative check before doing some therapy in general, not just the magnetic.
That fits the issue, but implants is not a problem.
Implants, no.
Yeah, okay.
No. Implants is like prosthesis. Yes, because they are not ferromagnetic. Thank you.
Pregnancy, yeah.
Pregnancy, okay, yes, sorry. Yes, even pregnancy.
In pregnancy, like everything, you can do nothing.
¿Y en tumores también malignos?
Sí.
No se podría.
Also with bad tumor, in the presence of bad tumors also. Normally with the shock waves, and in the different international conferences, we hear some times of treatment and some protocols, established protocols. And also we hear in the CTU Omega 20, we hear about the protocols and the times. So when I hear you all the three, I see you're working with this. So because I see there was so much therapy in the times in the therapies and the treatments, and the results are very interesting, very quickly, and biologically I'm missing some understanding because the growth factors we can increase, of course, and we do not want to increase it too much so there is no damage during the repair. But I see you change this concept. So do you believe that the protocol depends very much on the patient, and we can do different types of therapy on one chronic or acute patient with the indications that we can get? And secondly, where would be the limit, or to what extent can we continue treating the patients with this technology, or is there no end or no limits? So first thing, I recommend when we use a shock wave, in this moment, there is more possibilities to do an early in the treatment, thanks to using the very wide rise. So this allows for people to do the treatment quicker or earlier, and then the patient can recover better. And also we can start working with the protocols and develop our own protocols knowing the technology, but sometimes when you stop seeing changes, then it's necessary to reassess the parameters and the protocols you're using. So we need to take into account the energy that we are using, very much like, well, the scientific evidence with the success cases that we always had. And yeah, that would be my recommendation. And then if you no longer see changes after 5 sessions, then we will need to check what's happening. And something really important is that we need to also have the patients having the chance to test this before surgery, because with this, some patients have avoided some surgeries. I had the case, for example, of a patient who was going to have a hip replacement just because of the pain. The pain was so strong that the doctor said, well, then let's have a hips replacement. But in the end, now she's keeping her hips for 10 years more. So yeah, we need to control this and control the aspects of regeneration of the bones. So this is just a new chance before surgery for many patients. So just we need to reach our conclusions quickly because time is almost over. Yes, but yesterday we were talking about medicine and personalized medicine. So we have different tools, and it's on us which tools to use, and we can complement them, put them together, modify them as much as we want. But we need to have all these tools available to choose with the different pathologies. But there is still a long way to go to personalize all the treatment so that we can have a really personalized treatment. There is something paramount here in your question, and this is research. And if we do not write, if we do not publish, then it doesn't work. But in our institute, all the patients, since they enter, they're very strict. And we need to always write and keep a protocol for everything we do, just whether it works and whether it doesn't work, because we need to keep track of everything, because we're going out of the parameters from the traditional science, so to say. But it is obvious that we need to keep record of all these results so that we can adjust these new protocols. So, but definitely this is really great for the patients. And obviously we are a scientific community, as we heard yesterday, so it is important to have very clear indications, and it is very important to take into account that there could be variations with different patients for with the treatments. And this shows the how rich medicine is as a science and as an art, because but of course we need to have some protocols. I have a question for Dr. Galizzi. We were able to prove efficiency in edema after the prosthesis and after the trauma, in bone trauma. So I guess we can use this therapy also in other cases and in other diseases. Can we combine the therapies? Yes. I've had some patients with different conditions, and the magnetic field allows us to stimulate the vascular system. And the magnetic field allows us to have a better drainage, allows us to stimulate the nervous system and vascular system. So this will help us to also improve the metabolic response of the tissue. So yes, we can integrate all those different technologies. And obviously, we will see and how it depends when the patient comes to us. If it is edema phase, then we need to have a movement of liquids, or if it's a more advanced moment, then we can stimulate more the tissues. So it depends on the situation, how the patient comes. Great, just the very last question. As a counterindication, what about the age? Me, I work with very young people, and for trauma, is there any problem to use it in the growth cartilage? Do we have any information about this? And also my colleague here is asking me about ALS, if you have some information if it can be used for ALS. So it's not recommended to do this treatment on the cartilage of growth or growing cartilage. It's not recommended, but we can use shock waves in the cartilage of growth. So maybe in some years we'll be also told that we can use magnetic field in the growing cartilage. But we cannot do it so far. And for ALS, well, you have many cases of ALS in Colombia. So it's a very difficult case. The treatment works when it's a motor neuron first, but when it's ALS, then the disease goes very quick and the regeneration is slower than the advance of the disease. Yeah, of course, and the diagnosis is very late, and then it's, yeah. Right, so thank you. So we finish here with our first round table. Thank you. Thank you so much. Thank you to all the speakers in this round table. So do not leave the room yet, please. Do not leave. Did you like our dance yesterday? Flamenco? Could you like to have something as thrilling today? Well, we have very good news to share. But it's not going to be me. I will ask Dr. Felipe Torres to do it.
Thank you. First of all, these speakers have been great. So every day we are having a better option and we see a bigger group. And this is why we want to invite all of you. We want to invite you next year to the 3rd Congress of Diamagnetotherapy. We want you to come with us, not just this group, but even more people. And we want to invite you so you could see where the Congress is going to take place. The 3rd Congress, International Congress of Diamagnetic Therapy. the third symposium in medicine personalized will be in Colombia in June 2024. So we are in this World Congress, the third symposium of personalized medicine in Colombia. So we invite you to to enjoy the weather, to enjoy the people. You'll always be happy there. And sometimes go to the other part of the ocean. It can be a bit hard, but we will welcome you with our open arms to have the best scientific level, because all of us will be there, even more people will be there, so you can have all the information. Thank you very much.
Muchas gracias.
Thank you. Thank you, Dr. Felipe Torres. And now, yes, you can go ahead on your coffee break.
Ah, ok, Fisao de YouTube channel. Ok. Oh, perfecto. Ok, listo, voy a buscarlo aquí. Listo. Ah, ok, Fisao de YouTube channel. Ok. Sí, sí. Ok, vale. Ok, listo, voy a buscarlo aquí. Listo. Ah, ok, Fisao de YouTube. Ok, ¿cuánto piensa? ¿Como 15 minutos? Sí, sí. No, está bien. Yo digo que cuando piensa que voy a presentar. ¿En cuánto tiempo? Sí, como 15 minutos. Ok. Está bien, 15 20 está bien. Ok, vale. Ok, listo, voy a buscarlo. Sí, bien, listo, está bien. Ah, ok, Fisao de... Ok, ¿cuánto piensa? Ok. ¿15 minutos? Y usted me deja saber, me deja saber sí, entonces por el WhatsApp cuando ya esté listo para presentar. No, está bien. Yo digo que cuando piensa que voy a presentar. ¿En cuánto tiempo? Sí, sí, como 15 minutos. Ok. No lo tengo prendido. Lili, está bien, 15 20 está bien. Sí, sí, listo, okay, es mi esposa que lo tiene puesto. Voy a buscarlo. Sí, listo, está bien. Ah, ok, Fisao de... Ok, ¿cuándo piensa? Ok, 15 minutos. Y usted me deja saber sí, entonces por el WhatsApp cuando ya... Ah, un segundo, sí, sí, lo tengo aquí, espera. Ok, listo, ya, ahora está. Ok, ok.
Hola de nuevo, bienvenidos again. Espero que hayáis disfrutado del café. ¿Qué tal? ¿La habéis digerido?
Hola. Hello, everyone. How did you see the news? Who's going to Colombia then? Right, let's get started with the second block that is going to be very interesting. Is this Diamagnetic Biotechnology in neurological pathology? So we've got here with us Felipe Torres. So let's give him a big round of applause.
Voy a tratar de ser rápido.
Today again I'm going to speak very fast, but no, really, I was joking. I'm apologizing. I'm joking, but I want to apologize because yesterday I think it was too fast for simultaneous translation even. So I'll try and be as agile as possible, but let's take this different. So first thing is that the research we've been doing with our Peripheral Academy for some years, and when we had the pandemic, of course, we slowed down a little bit, but we've advanced quite a lot. And we now have some papers to be published in different areas. So it's not only what we've done, but also others doing with technology to continue improving what we do. And second thing, it has been a long time that we have been working with degenerative diseases. And we are now working with two groups. We have the Latin American group with children with autism, and also a group in Medellin, Colombia, working also with autism. So it's a big group where we've been signing an alliance with different doctors for nutrition, genetics, neuropediatrics, and pediatrics, and rehab, and us. So the brain is a different world. Obviously, here we can discover more and more about the brain, and we need to have more responses because tomorrow degenerative medicine will lead to regenerative tissues to replace a heart or a lung or a kidney, but the brain will be a different context. So let's talk about neurodevelopment. Some images we cannot show from children, also because of authorization, because sometimes it's children where the parents don't want to allow this for the images to be shown. But let's talk about the context of brain and body are in an endless circuit, which is a circular, so it's a somatophysic and physical somatic. So this leads to a psychological situation of accompanying a patient. So when they go into depression, for example, a patient, if they have a partner and the partner breaks up, then they're sad, they start eating a lot, and they start with an endocrine process and not good sleep, and then they end up with a very bad situation, and this is a second neurological alteration. And the same happens with the patient. When the patient comes, then they may end up with a mortal disease when it becomes difficult to treat, and then they can start and enter depression. So it's a circular situation where we treat everything, the homeostatic control systems from the central nervous system and the autonomic system and the endocrine system and the immune system. A cell cannot work in just one area. Here we can see a lymphocyte stimulated by all the different hormones you see on the screen. And this produces interleukins, but also we have encephalin, endorphin, dopamine, and all this in the list. And this helps us to regulate all the processes. So now we talked about epigenetics yesterday, and depending on our environment, we see that the chronic inflammation increases with the age. Interleukin 6 increases. It depends on the country, but you can see here that in Japan this doesn't happen. It doesn't go down, but it stays stable. So thanks to interleukin 1, for example, this helps to induce the sleep. So we have some studies showing some evidence of the development of the brain, environment, and immunity, and therapy between the process of inflammation and emotional alteration. And with all this, we can come to a deregulation of the process as a response of the adults, and also we can have an alteration in the children. So here we can see an emotional dysregulation. So in the children, we have an adaptation to these emotions and also a strategy of response. But if there is no good response, we end up with an inflammation in the adults, and this can lead to some specific alterations that we'll see. So negative emotions in children lead to a higher inflammatory situation in their adult years. And also we can see raised plasma nerve growth factor levels. And that's why, well, maybe that nothing hurts, everything's beautiful, but then you get married and you continue seeing things beautiful, right? But, well, it is important, all those different stages. And then stress can obviously go into two processes. We have a decline of the immune system or an increase of the inflammation. And normally we have the two pathways, and depending on what we say, we can have both things. So with age and stress, we can have this situation with these cytokines. And here there's also an increase of the interleukin-6. So lower defense and more inflammation, so the pathology starts. So this is what we see. Normally this is a dendritic cell conditioned by interleukin-2. So we can have this division to Th1, 1702. So in these interleukins needs to be normal levels. So here we have a process where we can have a control for the pathogens or a modulation for the gastrointestinal system. So for this, the lymphocytes need to be divided to have the right response. But unfortunately, one of those going down is interferol. And this we see in viral processes, and that's why in the acute processes, as we saw before with Dr. Karen, there's a very, very good response to this, but whenever there is a high stress, there is a problem, we can have also a problem and an imbalance. So in those cases, the risk of cancer can be higher. And you can see here interferon related to the neuronal activity and the environment. You can see here the stress, lack of sleep, and difficulties in social levels. I have some patients where the parents said to me, well, that doctor, well, now I'm saying hello to people. He's already saying hello to people, to the friends and to the parents, but he likes being alone. But we're not creating we cannot create sociabilization with the technology, but we can reduce or we can balance the oxytocin situation. Whenever there is effects of stress in the body, well, all this can happen. So there's alterations, as you can see in the screen. This is part of the neural alteration, fibromyalgia, and you can see all this is interrelated. This is a specific triangle, the alterations in the sleep, fatigue, headache, etc. And of course, there is so many drugs that you can take for all these situations. So in this case, we can have pain, fatigue, depression, sleep disorders. Also with the increase of interleukin-1. So yesterday I was asking about pain. This is the central sensitization. We have some regions which are altered in the patients. And here I was asking, well, could we have a response with this device or with the MIGA-20 on the areas that we see here? And this is quite important for the management. And yesterday we also talked about mechanotransduction, pathological. And this is what we've seen in some movies in trauma of boxers in American films. So there could be a bad mechanotransduction, and then we can have some mechanoreceivers, which are totally altered and a reduction of the plasticity. And this is what happens in an area where the capacity goes down. So we need to understand this as like this in the axons. We have these microtubules on the top. And this is always part of the communication. We have an intracellular space. So there's always this communication in these spaces in direct communication, as you can see here, through the integrins, and also here the cadherins and the selectins, so that there is a single electric communication and a wide communication in the response of the muscle or any neuronal activity. But through this we have different tissues, and this is what engineer Lagata explains. We're going to take this the whole body, so that's why traditional radiofrequency electromagnetism traditionally works on a very wide area, but not a specific area. So today we know we have oligoandrocytes. I'm so sorry, but this is too fast.
Mielinizadas, por eso tenemos fibras lentas y fibras rápidas que pueden ayudar dentro de todo esto. Pero además tenemos células endoteliales, procesos vasculares, donde el músculo autónomo tiene una respuesta. Y entonces miren cómo cada cosa vamos trabajándola directamente a nivel cerebral para poder manejar todos estos procesos. Esta neuroinflamación causa ansiedad, desórdenes del sueño, depresión. Hay un cambio psicológico. Este cambio psicológico del estrés no solo se da a nivel general, sino a nivel también de las células haciendo una oxidación más alta. Este es un concepto de ansiedad fisiológica que todos vivimos. Voy a salir, ¿será que me va a ver bien? Van a decir qué aburrido, qué mala charla, qué buena charla. Es una ansiedad fisiológica. El otro problema es que yo subiera acá y me pusiera a llorar. Eso ya es patológico. O simplemente saliera corriendo, un ataque de pánico. Allí entramos en un proceso de una ambigüedad de lo que queremos y lo que no podemos hacer. Es importante manejarlo. Pero miren, el 40% de las personas jóvenes están sufriendo de problemas de ansiedad. En estos momentos el Colegio Americano de Estimulación Transcraneal refiere como tratamiento 1A la estimulación transcraneal para depresión, ansiedad y problemas psiquiátricos en primeros estadios. Y eso es lo que hace la CT1 Neuro. Y eso es lo que hemos visto, pero lo más grave es lo que vemos en los niños. Estos niños que son adolescentes y que adolecen su vida todos los días porque no les gusta nada. Pero esto conlleva otro gran problema y creo que lo vivimos todos, no solo los niños. Y es que hoy se nos volvió una pantalla la vida.
So we all see these problems also in the children who are working a lot with the screens, and they have lots of anxiety. And also for us adults, we're working a lot with the papers. And now we need to process so many articles on our smartphones and everything. So this leads to big problems in development, increased inflammation in the adults. And there is a process of increase also in the women with all the different hormones. And here you can read the prevalence. So people want to do so many things and be here and be there and be with a partner. So there is selective mutism, specific phobia, social anxiety disorder, panic disorder, agoraphobia, generalized anxiety disorder, and lots of drugs which are not necessary. I have two groups of infant neuropsychiatry, and one of those groups they always administer the drugs. I've not seen the children yet, but they want to administer those drugs. So this can be managed in these areas you see in the screen. And this is why we record the problems. If I ask you, and we had no problems last week, and if you had no stress in that moment, you will not even remember which clothes you were wearing. But if you had a traumatic event, you will remember how you woke up that day and which clothes you were wearing, how you watched your clock, and then something happened. And this is because we will be recording this process here in the hippocampus. But in BNST, here we have the inflammatory memory, and this creates alterations such as autism. So there's a blocking of the thalamus in the prefrontal area, reducing the process of analysis. So we are Homo sapiens sapiens because of this, because of the prefrontal cortex. So when we start having problems, we can have anxiety and panic. Then this area can be blocked. The second area that can be blocked is the amygdala, connected here to the BNST, and this is a trigger to have a result to the amygdala, like feeling stressed or quiet, or if I had some problems in the past or whatever. So sometimes we cannot control our panic. So this happens too much in the young people because they're so worried about everything and they're protected by parents. So this led to everything from increasing. We all suffer from problems when we were children. We all had some situations or some losses, but the responses within this area are different within this amygdala and brain nucleus of the stria terminalis. And this may drive different defensive responses, and there's different secretion of neuronal growth factors. So here we can have a reduce of the cells at the prefrontal area, and this can lead to the dementia frontotemporal, and which can be controlled and with big difficulties. So here, for example, you can have prenatal maternal stress, and this can lead to an activation of the HPA axis of the mother, and this can reverb on the fetus, and this can lead to cognitive problems such as depression, anxiety, attention deficit hyperactivity disorder, and conduct disorders in the children, also autism. So this neural plasticity, we need to remember that we have two types. We have the physiological cortical plasticity. This is how we develop our brain until the age of 28. But also we have the capacity to build our brain during the whole life. So in the ancient tribes, the old guy was the wisdom guy, was the wise guy. But today we call them the crazy grandpa. But this is different. So this is the continuity and the plasticity that we have. So we need to understand that we can have to stimulate astrogenesis and oligoandrogenesis, so that we can see where we want to work. And this leads to having some specific factors, these neurochemical, neurogenomic, and proteomic types. And this leads to an output of BDNF and VEGF. This is cerebral neurotrophic factor and vascular endothelial growth.
De demencia o en pacientes de tercera edad, porque ya no hay factores de crecimiento normales, son factores de crecimiento normal. Y lógicamente cualquier tipo de estimulación logra una neuroplasticidad aumentada, dentro de ella la estimulación magnética y las terapias celulares. Esto es lo que vemos cuando hay un daño en un nervio o en un axón, y es que vuelve a crear como si fuera un callo óseo, pero a nivel neuronal, que solo pensamos en el hueso. Y lógicamente esto hace que desde el uso de la resonancia magnética funcional entendamos un poquito qué es lo que tenemos que hacer. Cuando rompemos esta barrera, alteramos todo el eje hipotálamo-adrenal, dañamos los procesos genéticos, hacemos que esta situación de autofagia apoptosis se rompa, que debería ser siempre un poco más autofagia que apoptosis, empieza más apoptosis, aumento del AP53, haciendo el citocromo C, liberación, disminución de la actividad de la mitocondria, primero aceleración, después disminución y apoptosis celular, encontrando un daño. Pero si encontramos disminución, encontramos una aceleración mitocondrial con el equipo y podemos trabajar sobre ello. Siempre la inflamación, la hemos hablado que es uno de los procesos. Cuando hay inflamación crónica de bajo grado, hay disminución de los factores neurotróficos, los que acabamos de hablar, disminución en la reparación neuronal, aumento de la apoptosis. Después de esto es dado por la interleuquina 6. Empieza la inflamación crónica de bajo grado, acuérdense, no baja la interleuquina 6, la interleuquina 10 no logra compensar, el TGF-beta causa fibrosis de la glía. Esto se puede dar no solo a nivel inflamatorio del cerebro, sino desde cualquier zona inflamada, conlleva todas estas patologías en conjunto que tenemos en una relación y conexión psíquica. Tenemos también disminución del triptófano, disminución del 5-hidroxitriptófano, por lo cual hay disminución de la serotonina y aumentos o cambios en la POE4 causando los nódulos neurofibrilares que vemos en la demencia o en el Parkinson. Y por último, un aumento de la vía de la quineurina que hace aumento en la neurotoxicidad, atrofia hipocampal, déficit de la memoria y déficit cognitivo y problemas de demencia. Pero miren cómo lo que hemos visto es que podemos trabajar directamente sobre el entendimiento vascular y de oxigenación de las células a nivel general. Es ideal, como maneja cualquier otro electromagnetismo, no es que no se haga igual, manejamos el estrés oxidativo que se maneja en la célula, haciendo que la hibernación neuronal tenga una respuesta. Cuando la neurona es como una arañita, si ustedes tocan una arañita, la arañita se encoge y queda quieta. Lo que pasa es que el problema es cómo ella siente su medio ambiente. Si siente que está libre, vuelve a activarse, pero si siente que hay inflamación, se va a quedar así mucho tiempo y si no come, se muere. Y es por eso que en los stroke o en las enfermedades cerebrovasculares es importante hacer las terapias de forma inicial para encontrar resultados como los que encontró la doctora Karim. Entonces, ¿qué pasa? Hay aumento del cortisol, de la CTH, bajan las 5-hidroxitriptófano, síndromes depresivos, aumentos en el NFK-beta, pruebas de aumento de interleuquina 6, de interleuquina 8, de la factor de necrosis tumoral alfa y aumento de la inflamación. Volvemos a esto, donde causa al final todo esto un proceso de demencia y pérdidas neuronales que tenemos que controlar. Pero miren cómo la estimulación magnetomecánica hace que juega un papel crucial sobre los astrocitos que tienen un proceso específico en la corrección de la plasticidad y lógicamente hace una modificación genética de la estabilización. Cuando yo empecé a estudiar neurología decían que el cerebro no se recuperaba, que lo que le pasaba a una neurona no había recuperación. Hoy sabemos que la plasticidad y la posibilidad de una regeneración es más alta dentro de estos procesos. Ahora hablemos de un poco del neurodesarrollo rápido, porque ya me pasé como 500 horas. Estamos hablando del autismo. Básicamente estamos hablando de 1 en 68 niños actualmente, 1.5%. Pero esto sí depende, miren lo que era, 1 en 5.000, era una enfermedad huérfana y rara, 1 en 500 en el 95, 1 en 166 en el 2004, 1 en 68 en el 2014, 1 en 50 en el 2016, hoy vamos en 1 en 42. Eso significa que ya no es una enfermedad huérfana y rara. ¿Depende del medio ambiente? Sí, definitivamente en Colorado, que es un ambiente abierto, estamos en 1 en 92, en New Jersey estamos en 1 en 41. Sí, lo que comemos nos hace lo que somos y el estrés de vivir en New Jersey seguramente es muy diferente a vivir en Colorado o en vivir en Lugano, Suiza. Pero el punto importante es todas las causas que pueden llegar al autismo. Conceptos familiares, tenemos alteraciones, desórdenes psiconeuroendocrino-inmunológicos, causas metabólicas, toxicidad, disbiosis e inflamación perivascular, importantísimo en lo que estamos manejando nosotros. Lógicamente todo esto conlleva disruptores endocrinos, metales pesados, partículas ultrafinas, por eso ayer me decían, en toxicidad funciona y pienso yo que sí, porque lo que vemos es un recambio de la matriz extracelular, que los proteoglicanos son los que acumulan estas partículas y las que hacen un cambio del desarrollo. Acuérdense que la parálisis cerebral, como lo hablaba ayer, no es de la solo músculo, sino que parálisis en el desarrollo. El BDNF, la neurotrofina 3, la neurotrofina 4 no avanzan. Esto causa que el 17% de todos los niños menores de 18 años estén afectados por desórdenes del desarrollo y alteraciones en el sistema nervioso, como las que estamos viendo acá. Estos factores de crecimiento, vamos a leer letra a letra, no, esto lo importante es arriba, el factor de crecimiento neurotrófico causa alteraciones y lo que vemos en el Alzheimer. Vemos la neurotrofina 3 como un control del dolor neuropático y un control de la comunicación de estos microtúbulos y esta función mitocondrial por lentificación en la actividad eléctrica de la célula del hipocampo, pues viene a todo esto. Esto viene en muchos estudios, vemos cómo el hipocampo está hipodesarrollado en estos chiquitines, vemos cómo el cuerpo calloso no tiene la actividad, pero cuando empezamos a estimularlo se va condicionando, ya no está azul, empieza a estar un poco más activo, empieza mejor y tenemos que trabajar sobre zonas específicas, cuerpo calloso, básicamente corteza cerebral, cerebellum, amígdala, hipocampo y ganglio basal, que es donde está el núcleo estriado terminal que acabamos de hablar. Entonces, como se dan cuenta, trabajamos sobre el estrés y el trauma sobre los niños. Este es un punto importante para entender que cada zona ya está. Miren la memoria, todo lo que maneja. Antes teníamos una zona y hoy tenemos un punto importante. Acuérdense cómo se manejan los neurotransmisores y estos factores de crecimiento, y es que se manejan a través de los microtúbulos, y estos microtúbulos tienen una zona estable y una zona lábil, que lo que hace es que cuando se está transmitiendo, el la molécula es diamagnética y tiene una zona estable para que fije, una zona instable para que ruede, una zona estable para que fije, una zona estable, por lo cual cuando ustedes lo miran en una microscopía electrónica, ellos están caminando sobre el microtúbulo. Pero ¿qué pasa cuando esto se cambia? Hay una desestabilización, hay un daño en los microtúbulos y es una alteración como la atrofia multisistemas que causa este daño y es muy poco reversible. Estos se pueden estimular a través del proceso magnético y la idea es poder tener moléculas que podamos llevar hasta allí a través del proceso magnético. Cuando envejecemos hay cambios, pero hasta en la mecanotransducción de la temperatura, hay intolerancia al frío. Cuando somos jóvenes estamos sin chaqueta, ahora no va envejeciendo, ahora todo me da frío y es parte de esto. La depresión, el tratamiento con procesos con estimulación transcraneal ha mostrado que hay algo muy interesante como una posibilidad del tratamiento que tenemos. Esto ha ayudado a que tengamos un control en la demencia y que podamos también pensar en diferenciar a nivel de los cultivos las células para que tengan un aumento en los neurotransmisores, un aumento en estos factores de crecimiento y que lleven a una mejoría. Esta inflamación es lo que vimos en el COVID y es por eso que tuvimos hoy una respuesta. Hemos hecho un estudio muy bonito en estos pacientes con unas respuestas de mejorías con pocas sesiones, 3 o 4 sesiones transcraneales con muy buena respuesta. Pero tenemos que acordarnos que trabajamos bajo el oxígeno y ese transporte de oxígeno es importante llevarlo desde los vasos y hay que mejorar el flujo vascular y ese flujo vascular es parte de la diferencia de la presión, de la resistencia vascular y esta plasticidad sea parte dentro de esto de lo que estamos haciendo. Ahora, esto es lo que empezamos a hacer con nuestros pacientes. Vimos cuando no se les hacía y se les hacía inmediatamente, aumentaban el flujo vascular, pero no en uno, en todos. ¿Y ellos están enfermos? No, todos los pacientes eran sanos porque eran todos los de la clínica. No arriesgo a los pacientes, arriesgo a mi gente. Entonces, vimos una respuesta interesante y después empezamos con los pacientes. La respuesta es mucho mejor. Estos son rangos de cambio que vimos en ellos, que vimos en las imágenes y lógicamente los estudios que hemos publicado en enfermedades huérfanas y raras básicamente con patologías neuronales y con estimulación neuronal específica. Hemos visto que hay plasticidad en paciente sano porque la plasticidad en paciente enfermo, hablándole, pero en paciente sano la plasticidad aumentarla es muy complicado y aquí vemos cómo mejora esa plasticidad, por lo cual ya sabemos que porque eso es con diamagnetismo, tiene una respuesta mucho mejor. Lógicamente el uso de las nanopartículas, lo que vimos ayer en los artículos de regeneración, la implantación molecular y como conclusiones, pues saber que nuestros tejidos nerviosos son dinámicos, adaptables, es un sistema plástico que nos deja trabajar y que tenemos que tener una plasticidad en el tratamiento para poderlo tener, que la adaptación extracelular es muy importante para las señales biomoleculares y evidentemente que la neurorehabilitación, la estimulación a nivel neurofisiológico y neuroquímico es importante. La estimulación más importante y el por qué uno está aquí es por los que ama. Este es un video y se lo dedico a todos los que están siempre en mi vida para poder trabajar en ellos, con ellos. Y no funciona el video, pero si funcionara el video no solo la tiene a ella, también hay otra gente. Entonces les quiero agradecer a todos. Esto ha sido un sueño muy lindo para trabajar con todos. Muchas gracias. Los dejo con el video, ya me voy. Esa es mi hija. Gracias.
Thank you, Dr. Felipe Torres. It's always a pleasure listening to you, and it's such a shame that we can't listen to you more, but it's fantastic just to see you here. I would like to remind all the speakers, I would like to send a kind reminder. I know it is hard, I know it's complicated. I know it's a very difficult issue when we have such an interesting thing to speak, but we need to kind of stick to the time because we do have a program with many speakers and we don't want to occupy other people's time, but always, Mr. Felipe, it's great to have you here. I won't take any longer. Let's have the next speaker, Vincenzo Rania, pain treatment in multiple sclerosis with Diamagnetotherapy. Thank you very much. Hello everyone, thank you for inviting me here, and thank you all of you for being here in the second day of the Congress. I would like to share with you in our experience with the pain treatment with treatment when they have pain, and we are speaking about very complex symptoms, very complex exercise. So we are now treating their needs and their pain in order to improve the life quality. Multiple sclerosis, it's a pathology that's very spread, mostly in the Western world, more specifically in the north of Europe and in the American continent, in North America. So it is actually a very complicated disease because the patients have a disability that does not allow them to move and just leave them lying down. So this is an idea of what you can see in the illness. You can see the lymphocytes and all the cell stakeholders that do not recognize the neuronal structure, this myelin, and through a process of swelling, then the nervous tissue doesn't respond, and then there is a pathology with a clinic framework that is very overwhelming. Without going into further detail, because Dr. Torres already spoke about the pathology, then we can see in this picture that the swelling process, the degeneration of the neuronal activity, brings to radiological frameworks to process to have this myelin out. So, and all the patients can carry out, and they can have many different treatments. Most of it, the ones who are for immunodepressants. There are several drugs that can attack one or several cell elements, but I don't want to go too deep into this because the medical treatment is very complicated. It can vary a lot depending on the type of multiple sclerosis people may have, depends on the clinic stories, etc. It's very varied. So we've seen rehabilitation already has a relevance, so it should be something that's more and more specific when treating a patient, because the patient needs to be treated globally so the person can be examined. And this is the only strategy, physical rehabilitation, but also instrumental rehabilitation, because they'll allow us to reduce the clinical frameworks of disability in order to improve the life quality. And in some cases, to prevent some serious situation. In this study, we could see that the pain you can see in the patients is headache, neuropathic pain, muscle pain, lower back pain, and most of it, this muscle spasticity. So the symptomatic treatment for all these topics that show the illness, we've got some drugs that are relaxing, for example, for the muscles, but many times they don't give a clear response. So we saw it's necessary to just face the pathology from another perspective, trying to get over the paradigm, the traditional paradigm, and stimulating the answer in the patient. So we study pain. This is one of our latest studies about the mechanisms of the drugs, and they act in different channels like sodium, calcium channels, because they manage the pain But many times this is not enough, it's not good enough, and this is why we're here. The drug cannot be the answer to everything. More specifically, we've been observing 15 patients, but we're working with more and more of them, and they've been subjected to our study. So you can see the inclusion criteria. Patients that have this pathology, who are older than 18 years old, they are in a scale and Oz that's above 6, and they have had chronic pain since 6 months. We've included also some people who are younger than 18 years old, people who have neoplasias, and women, pregnant women. We want to reduce the pain regarding intensity and frequency, and we could improve patients' lives. How do we do it? Well, you can see here this has been 12 women around 56 years old, 3 men around 53 years old. So, and ours is higher than 6, and we evaluate DN4 to evaluate the pain as well. And then we have also tried to assess their disability, whose percentage is in average around 42%. So if it was, the quality was good enough, it was better than 60%. But what you can see actually from this number, this means suffering for the people who suffer from sclerosis, multiple sclerosis. So I'm going to show you some clinical cases. This case is a woman. She's 67 years old. She had this secondary progressive multiple sclerosis. She can't walk anymore without a support. She needs a wheelchair. She has had lower back pain with an intensity, a pain intensity is 8 out of 10. And the N4 is 6 out of 10, and also bilateral cervicalgia. And she's also has spasticity, hypotony, hypotrophia, and you can see that at a radiological level, her spine is like this, as you can see in the picture. As what also happened is in the portion C4. So what did we do? These are the drugs she used. You can see it's actually several of them, but the life quality has already been reduced because she has to take so many drugs, as you can see here. So we can see oxycodone every morning and every night, pregabalin, baclofen, and this was still not enough to reduce her disability and her pain. So then we took her into 2 sessions per week, and following different protocols regarding her nerves, pain control, neuropathic, and mostly in the low back pain.
Il quadro fosse abbastanza importante.
We can see the results here. Here, the conditions were very relevant regarding pathology, but we've seen many improvements. The neuropathic pain improved quite a lot, and she reduced the drugs she was taking in NRS, got decreased up to 4, and her life quality improved. Sometimes the patient calls us and she says how she can come back to our health center because everything is better for her now. The way she was moving, but also her quality life. Before, she couldn't even tie her shoelaces. So everything is just better. So she could see that after all the sessions. Now she's still in therapy, but she's not taking all the drugs she used to take anymore. So obviously her treatment is better. We see another case now. It's a man, he's 50 years old. He's got multiple sclerosis that's remittent to recidivant. he couldn't move and he could walk, but he could barely do anything else. He had a reduced mobility and he needed to use a cane. So it was a huge range of problems. His pain was higher after having ocrelizumab. That's a drug that was used for fighting some cytokines. Some illnesses regarding pain therapy have an impact and they reduced its evolutions. However, they don't work on this pain. So when there was a higher symptoms, it was high through the day until it got to an NRS 8, a neuropathic pain that was not so big, but his life quality, it was in a very low level. Here you can see the L5 area, and as well as the vertebra L3 and L4, as well as the condition of the spine. You can understand then that the pain was a big problem, because these are the drugs he took: migbalin, alpha-lipoic drugs, N-acetylcarnitine, and some other ones that were used to contain the degeneration of the nerve. Also metformin, and other times he could take another drugs, but they didn't have any good results. So what we did is we took a protocol of Diamagnetotherapy. We have consultations, appointments every week during 4 weeks. We had biostimulations with never fast, never slow for 10 minutes. Mostly in the lower and middle pain. You can see the results here. So the answer was just fantastic. After 2 months, the patient had no pain. Obviously, it was a long path, because once we get a patient like this, his emotional framework is also very complex, because no one really takes care of them. They just take their drugs and that's it. But many times drugs are not the solution. So this person could just come to our to the doctor and we can speak to them. We will have a treatment, but after we could cancel out the pain. So this was very important because we improved his quality of life. So we could also suspend this INA, and he's only using pregabalin now. So this obviously improves the pathology. And in order to conclude, we can say that this additional treatment with diamagnetic therapy improves the symptoms regarding intensity and frequency, and prevents the client to be treated in a more invasive way, and obviously it improves his life quality. So I'm reaching the end of my intervention, but I have to say that I was very interested about the transcranial stimulation, and I have to say that treating our patients, in many times I did think that we could act on a peripheral level, but when we need to look at literature, and I have seen this study that was published in Frontiers in Immunology, and we could see that they were assessing the most efficient treatments in the patients with MS. So, well, this transcranial, apparently it's one of the most important treatments. It's one of the most efficient treatments because it raises the excitability of the cortex spinal system. It favors synaptic transmission, and these are the other studies that were taken into account for transcranial magnetic stimulation. I don't know if you're interested in it, but you can read it because it is actually very, very interesting. So many treatments, many patients were treated that had a fantastic response. These patients many times couldn't even raise their arms. So it was more efficient as well, and the elasticity of the bladder it was improved as well. And I did have questions before I came here, but I did find some answers. So I am hoping that in the future transcranial technology can be spread and get better results, as we are saying with this diamagnetic pump. Thank you very much.
Muchas gracias, muchas gracias.
Thank you so much, Vincenzo, for your paper. I was just giving some news, and this is just amazing. I think we're going to do a bit of a difficult connection. We're going to connect with an astronaut from the International Space Station. I think he's connected live. Hello, Karim. Karim.
Buenos días.
You can hear me, right?
Sí, lo escucho muy bien.
Yeah, I can hear you very well, yeah. So I'm told you're in the International Space Station, is that correct?
Más o menos, estoy
sort of.
Orbitando sobre Calgary, Alberta, Canadá.
I'm orbitating around Calgary in Canada.
Aquí
what's the time there?
Más o menos
Well,
las
right now,
4:48 de la mañana.
It's 4:48 a.m. I'm going to ask the whole audience to give you a big round of applause for getting up so early for us. Thank you so much for being here with us through this online connection. It is so important to have online streaming, and how the technology is so important. So, Karim, without further ado, I will let you start your paper. Thank you so much.
Gracias. Pues primero, muchas gracias a FISAUDE.
Thank you so much. I want to thank FISAUDE for the biomagnetic technology and these therapies, because this is the future of many parts of medicine. So thank you guys for the big job you're doing.
Quiero compartir con ustedes un poquito sobre mi jornada,
with you my
voy a hablar en inglés el resto de la conversación.
daily work and my daily life. I'll continue talking in English.
Delgado, and I am not a doctor, unlike many of you, nor do I play one on the internet. I am a man who lives a life of service, and this person that you see here that I'm hugging, that is my father, and his name is Néstor Francisco Delgado. And today is full circle because he actually went to medical school and the university in Barcelona, in the same country that you're in right now. And my father really taught me to live a life of service, which I live now. 8 years ago, he passed away from Alzheimer's, and he was a medical doctor, a gastroenterologist, really leading the forefront on ahead of his time. He was doing quite a bit of research on the gut biome and the gut and brain connection. And in a lot of senses, I've kind of taken on the research that my father started and continued to evolve it. Now, from this Alzheimer's and the strategy that we face in our lives, I made him a promise. I made him a promise on his deathbed that I was going to find a solution to Alzheimer's. And 8 years from now, 8 years into the future now, I'm happy to say that we feel like we have a really robust solution to help people, not only with Alzheimer's, but many of the other neurological disorders, and empower practitioners like yourself to solve a lot of these different complex neurological disorders. Now, when my father passed away with Alzheimer's, I was able to put together my superpowers of R&D, and my background is research and development into many different verticals. I started to look at the direction of health technologies, and looking at the last decade where a lot of the focus was in equipment, hardware, and consumables, looking at historical evidence to help patients. And looking at this current decade, it's really focused on wearables, big data, and health analytics. What really surprised me about health technologies is I was really quite literally flabbergasted that it takes 10 to 20 years for an innovator like myself to take something into the market because of all the regulatory boards and everything else like this, right? Or even a new therapy. People who have Alzheimer's and these neurological disorders can't wait that long. So I decided to further look at what's going on in the trends on health technologies and looking at the next decade. The next decade is all about robotics, AI, and augmented reality, and even VR, virtual realities. Looking at trying to stay ahead of the game and doing a bit more preventive care. Now, all these things are the promises to reduce research and health costs and open up new ways of service offerings. Now, the sad part about it is that, as you know, medicine is transformed quite a bit into systems of billing and processing patients at a large scale. The art form of medicine is really a lot of times being lost in some countries because of that pressure that is being put on medical doctors. And we believe that through artificial intelligence and wearables and health technologies, we can empower doctors to reclaim that and be able to reclaim the art form of medicine. Now, when my father passed away, I made him a promise that I was going to find a solution to Alzheimer's. And so, taking my R&D superpowers and product powers, we decided to build a team to take on Alzheimer's at scale, and looking at it almost like a moonshot to actually get to a solution to Alzheimer's. So when I looked at Alzheimer's, I realized that I didn't have a lab, I didn't have millions of dollars at my disposal, but what I did have was access to research. So I became a meta researcher. I started doing research on research and finding solutions that are evidence-based on the macro level and on the personal level of a client. We started applying agile methodologies to helping clients find early data sets, early and often data sets to find solutions to some of these problems. When we were looking at medicine, being a systems and a technology guy, I started collecting quite a bit of different modalities from neurotechnology to consumer electronics, became really obsessed with mapping consumer electronics along with medical, the standard medical equipment, so that I could look at the variances, so that I can then not really focus so much on precision, but just looking at trends over time and trying to provide early data sets and often information often and quickly, so that we can then adjust to see what works, what doesn't. We started looking at AI and machine learning and really fusing medicine into a full system stack, right? It was kind of crazy for me to realize that people were just stuck on silos, while really the human body is a collection of systems and subsystems. So we started really focusing on systems biology. We started embracing open source and open health solutions. We started to actually leading parts of the open health studies and technologies, and really focusing on crowdsourcing of different research initiatives. And we started applying a rapid prototyping approach of failing often and quickly, from technologies all the way down to different types of therapies. So we quite literally travel the world and start collecting different types of modalities to help with the technology and also protocol development. Now, what we seek to do in brain mechanics is really democratize health and wellness. And this is driven by folks who actually want to take control of their health and wellness, low-cost sensors, and AI machine learning that's spreading like wildfire, and also easy access to consumer lab testing. All fused together with consumer electronics and wearables. Now, let's talk a little bit about those wearables, because they seem to be pretty sexy topic nowadays. So the wearable technologies right now, the history of wearable technologies is you used to wear a watch and it will give you some information, right? Very useful, the time of the day and things like this. Then things evolved to Fitbit, which would take you information like, steps that you walked and things like this, but not very helpful. Giving you a little bit of sleep data, but that's about it, right? Further down to wearables 3.0, which is now devices like an Oura Ring, which gives you very precise, fairly precise information by measuring the blood flow through your finger, right? And these are complex systems that have things like measure, blood oxygen saturation and things like this, and also help you to make decisions based on trends over time. Where we are in brain mechanics, we're not so much interested in the individual devices. What we're building a comprehensive platform for health and wellness. We don't necessarily get married to one specific device, but we integrate all devices. So whether it's a device for measuring biometrics, biometric rings, or measuring things for your EEGs, for brain waves, far near infrared devices, brain functional assessments, and things that are really, really interesting for your populations. We talk about electronics and pulses. So we have things like, for example, wearable PEMF devices. We have devices that actually have cranial electrical stimulation, alternate current stimulation, direct current stimulation, photonics, be able to actually have very robust changes in the brain. We'll talk a little bit about that. And we actually developed 6 different ways using consumer electronics to clear amyloid plaque, right? Also, devices that actually help to tune the fascia, the human fascia, which has direct effects on the brain restrictions and lymphatic clearance. And I'll talk a little bit about that. Now, with these simple, humble consumer electronic devices, we've been able to actually achieve very interesting results. Things like delivering mRNA upregulation, growth hormone, IGF-1, VEGF, and progenital cell stimulation. We've actually worked on solutions to fix misfolded proteins, lengthening telomeres, and reducing senescent T cell counts on individuals. Some of the solutions that we've come up with and processes are able to upregulate mitochondrial health, increase plasma count by 600%, and deliver 5 times the amount of oxygen to the brain, lighting up a person like a Christmas tree, increasing improve fluid intelligence by 20%, and also twice the amount of learning capacity and improved brain functional performance, all using consumer electronics. This smart well approach that we're taking is all about precision wellness. And we seek to really bring in a wellness revolution. This includes a wearable health technology platform and also biometrics, along with biomarkers, all feeding into an artificial intelligence that is able to go deep and wide in reinforcement learning, but also explain its findings using natural language. We believe that in order for artificial intelligence to be responsibly carried out, it really needs to explain why it arrives to this conclusion. And we have some important patents around that we're actually going to be sharing with the world as an open source solution so that all humanity will benefit from it. We take these different information, all these different sensors, and we actually are building now a very high resolution big data of the body perspective, allowing us to measure a 360 perspective view of the human body at a very low cost way. Now let's talk a little bit about the practical applications. I'm making some really bold claims here. So I want to show you just some examples of how you can actually benefit from some of these different innovations and apply them into your practice. So let me give you an example of how we started. So in 2014, when we were doing the Alzheimer's research, we realized that sleep was a really important thing. Now, current sleep studies require all these wires and things whirring around on a person. You go in a foreign clinic space or take all this equipment home. And these studies cost about $500 to $1,000 per sleep night. Now, if we're doing rapid prototyping innovation, that's a lot of money for us. We're a non-for-profit, and we weren't able to afford this. So through our research and development, we actually developed solutions today, like this wearable device that you see on the right here. And we're able to actually capture 30 days worth of data. And instead of spending $30,000 in costs around that, it would take us $1,000 to capture 30 days worth of data. Now, being innovators, we didn't really want to stop there. We also wanted to be able to actually have some robust biological changes in our devices of sleep. So 4 years ago, we actually were one of the first groups in the world to be able to induce delta waves through PEMFs. And then through all these different devices, we're able to actually increase the amplitude and frequency of the delta waves. Now, why is that important? It's super important because delta waves is the body's, the brain is, when it's in delta waves, the body's actually activating the lymphatic clearing, almost like a washing machine of these different amyloid plaques that are in the brain. So by increasing the delta waves, generating delta waves in the frequency and the amplitude, we're able to actually clear amyloid plaque. Now, we didn't stop there. Our devices are also able to deliver real-time cognitive behavioral therapy. So if a person's having a hard time sleeping, the brain, this device is able to sense the frequencies and able to actually guide the client into getting deep sleep. Now, what's really exciting about the research that we're doing here that I want to share with you, there's going to be a study published soon where we're taking 2 years of R&D into really deep understanding of the fascia and be able to loosen up the fascia so that the lymphatic system can actually kick in and clear things even at a deeper level. And we use photobiomodulation, intranasal, as well as on the head and on the neck to really trigger this effect, robust effect. And we're actually right now in the process of helping others getting certified on these different technical protocols. Well, now, one area of innovation that I really want to share with you today that really might be beneficial for you is dealing with brain function. So as we're developing these protocols, trying all these different multiple modes, we really needed a really fast, cost-effective way to measure brain functions. And right now, as many of you know, measuring brain functions is done through an fMRI. These things cost $1 million. They take up a whole room, and they cost about $3,500 per sample in the US. Now, that's very impractical when we're a non-for-profit trying to capture brain samples every so often. So imagine right now if you were going to using diamagnetic therapies and trying to measure the effects of single-cell sequencing in 100 patients over 6 months. Now, right now, you're limited by how much samples you can capture because it costs about $3,500. And in a case like this, it would cost $700,000 of cost, but you're really getting about AM radio type resolution, not very much information. And I've been told that an ideal way would be to actually capture 52 samples over this 6-month time period to really get into very accurate, high resolution, almost like 8K resolution of the changes that are happening in the diamagnetic therapy. Now that costs about $18.2 million. What I'm here to share with you today of a really novel approach to measure brain functions using somatosensory systems in the body. This device is called a brain gauge, and it's really a game changer, and it's been a game changer for us in our research. It really measures brain functions and task neurofunctions at a very low cost way. Now, the same example we talked about, we could actually be able to deploy these devices in the clinic and at home and testing at massive scales. We're talking about $18.2 million worth of value for $180,000 on that scenario that I mentioned. And the clients don't even have to go to your clinic. You can capture samples on a daily basis and a weekly basis, however often you want to capture the samples, all using this simple to use device at very high precision. Now, this brain gauge is simple, intuitive, and it measures a battery of tests. The battery tests take 5 to 7 minutes to assess. And they measure very specific areas of the brain and measure things like speed, which, as you know, is related to white matter and myelin, and directly related to the neurological neurology, right? So speed, accuracy, time over judgment, time perception, connectivity, plasticity, fatigue, focus, all these different metrics that you all have been talking about that you're looking to actually measure, we can measure this with this device. Now, the key thing about the cortical metrics is allows you to track responses of treatment across days, and it rolls it into one overall score. So it's very simple to use, and it's colored by numbers. This score is called a cortical metric. So the key of this whole is that we are able to determine treatment efficacy in a very low cost way. Now, let me show you an example. I had some images here on the left of a wearable PEMF device. So this is a real life situation in our world where we're doing an alpha lab testing the performance of a wearable PEMF, one of the modes that we're using for Alzheimer's and dementia and traumatic brain injury, of one of our PCS multimodal protocols. And so what you see here right now is treatment. We started the treatment, and then we got some improvements, but then we actually stopped the treatment early. We're seeing decline. So this is a very good indication of just cutting the treatment too early. But it just gives you a good idea of that we're able to quite easily plot things over time. Now, the brain gauge is very scalable. It has 40 years of science. We have animal models. It has a wide spectrum of neurological disorders that we can actually measure with this device, and it's FDA listed. and it's used over 30 countries right now. In fact, is being used by the NFL and other sports teams and leagues to start measuring and democratizing brain health across the board. So, in summary, BrainGauge is a fantastic way to integrate smart wellness solutions and track recoveries over time. And we look forward to collaborating with many of you to see how we can actually work in taking the BrainGauge and applying it to your clinic, along with potentially how we could show you how to take consumer electronics and get really great results in your clinics. All right, well, that is all I wanted to share with you. We would invite you to reach out to us if you are interested in doing any innovation R&D, along with interested in the BrainGauge. Yeah, there's a QR code here as well where you can actually click on that. We have a special promotion for other practitioners as well for the BrainGauge. If you're interested, you can just click there and you can get some discounts. Now, if you have any questions, I'd like to open up the floor for any questions for you.
De nuevo, muchas gracias.
Thank you so much, Karim. Thank you so much for the effort for connecting online, and thank you for getting up so early to be here with us online. Thank you so much.
Gracias a ustedes, un placer.
I thank you, my pleasure. I'm so happy that you're in Canada and not in the outer space. Great, so our next speaker, we're going to have a big friend of mine on stage, Serafín Ortigueira. He'll be telling us about diamagnetic therapy in peripheral neuropathies. Thank you.
Good morning, everyone. Well, first of all, I am very happy and I'm grateful for being here. And I wanted to speak about Paris Academy. Thank you so much, Paris Academy, for allowing me to participate here today. And I wanted again to congratulate Paris Fisaude and the organizers for this magnificent congress that we are enjoying. I'm a physiotherapist in a city in the north of Spain, in Coruña. I am in a center of neurorehabilitation, and I also am a professor at university. My clinical experience is developed in neurorehabilitation in adults, and more than 90% of acquired brain damage. But today I'll be speaking about it's 20 minutes, it goes so fast, so I'll try to do my best. So how this diamagnetic therapy can help you with neuropathies to treat this problem that you'll see, because the numbers speak for themselves, and how it could help us in a specific case of self-immune. So in order for you to have some context, we've got some information here. Approximately 20 million of Americans have some neuropathy. That, as you know, is a degeneration. It's an alteration of this great network of peripheral nerves that form our body. So if you can see in the range, the older, obviously the bigger prevalence, but in a number that you can say that is quite shocking is this 14 billions. It's 40 millions, what we would say in American. So 4 billion of expenses for these type of problems. So if we think about this neuropathic pain, well, the range also speaks about a margin that has between 3 and 17% of the population. And something that we already know is that the majority of the treatment for these type of problems, pregabalins, etc., and many other ones that we have already mentioned, apart from having many side effects, they also have scarce moderate effects in some neuropathies. So as it is said in this article of this magazine, then we need other approaches in order to help these people who have this such strong pain, because they need to improve their life quality. some of the facts and data that we can have globally, they also think about the prevalence and the incidence. For example, we've got a study from the Netherlands that every year we get 8 cases out of 1,000 people. So it could be 800 per 100,000 inhabitants. Also, for example, like diabetes. More than 26% of the people who are diabetic, and in the UK, but it's also in many other countries, they have some neuropathic pain. So if you translate it, if this figure, if you translate it globally, it's nearly 50 million people or patients with cancer that, given their cancer or maybe the oncological process or the treatments, they are getting to appease this type of problems, then 1 out of 5 patients with cancer have got neuropathic pain. So it is for the study, because in 2014 it was a year for neuropathic pain. Other data that you may know, but it's still shocking and it is frightening. Nearly 20%, so this is a British study, but also it can be translated globally. Nearly 20% of the British patients who have this neuropathic pain, they score that the situation would be worse than actually dying. And obviously that would entail another risk that before having used other opioids, because this was one of the main cases for suicide actually. Well, there are many neuropathies in general, depend on the classification, depending on their causes, diabetics, alcoholic cases, because of chemotherapy, autoimmune like Guillain-Barré syndrome that we spoke and that we will speak about that later, because of exposition to toxic substances or other infections like HIV. They can be proximal, distal or confused depending on their distribution, and the clinical presentation could be mononeuropathy, multiple, polyneuropathy, mononeuropathy. And then depending on the nerves that will be affected, then we also have a neuropathy in the motor parts, and sensorial, mixed or autonomic. So even if we have this huge range of neuropathies, depending on the different criteria, different classification, all of them, or nearly all of them, they share some common features. We can see it in their mechanisms, or mechanisms at a microvascular level, hypoxia, because of the light of the vessels, where we will have also some swellings. We'll have microvascular processes that depend on the swelling process that we spoke about this weekend, and you can see it here in neuroepithelial infiltration of inflammatory cells like monocytes, monoclears. We spoke about all of this yesterday. The different degeneration of the myelin. So this anatomical model from the magazine Nature is actually quite familiar to us, because it refers to one of the neuropathy that's a consequence from diabetes. That is such a common thing right now. And you can see that the cells are shrinking, and all of this causes swelling, and like Dr. Torres said, well, this leads to that degeneration of the myelin that you can see on the bottom left. This is the same one from diabetes as well. You can see they're shrinking in the basal membrane of the cells, and there's a dysfunction of this type of cells are very important. That could see they were affected by this type of pathologies, but not just this, also in degenerational pathologies like Alzheimer, multiple sclerosis, etc. And what you see here is that it was also spoken about, Dr. Torres and as well as other speakers, about how important it is to keep this integrity of the barriers, both neurovascular at a brain level. Classical image, as you can see here, of an immune under the syndrome of Guillain-Barré. In this case is quite shocking what you see here. And I think that now in the Congress we don't really have to go in depth about the diamagnetism, because I think that's been very clear. We have been lucky enough to listen to even the creator of this fantastic technique. So just very small things about it. Dr. Torres spoke about it very well, apart from enlisting all the structure and the target where we could use this therapy to help some organisms and tissues. As we said, the magnetic fields, electromagnetic fields show us that there is a huge potential for the treatment of Alzheimer, Parkinson, multiple sclerosis, as well as other ones, and as well as the peripheral ones that obviously I don't have such a huge experience with them, but I already have a success case here that I will show you. And I think it was also quite clear that the electromagnetic fields of low frequency but high intensity help us to regulate this treatment that sometimes is counterbalanced in order to stop or halt this interleukin 6, for example, and also counterbalance it with the expression or the stimulation of the transcription, or for other interleukins that are more resolutive. Okay, and now as we know as well, if we pay attention to the histopathologic mechanisms, well, this technology will allow us to select very specifically some specific parameters to choose different type of processes, because it's not the same thing tackling the acute phase, like Dr. Cardenas was saying about a neuropathy, Guillain-Barré syndrome, if it's in a chronic phase or if it's in an acute phase. So it's not the same parameters that we're going to be using when we are moving the liquids in both phases, in both stages. So now here we've got a very classic picture of the 5C67, and here we have a case of the Guillain-Barré syndrome. As all of these, you can see the excess of the previous roots of these 5 modular levels. So on the right part, you can see that it's blurred because of the infiltration that happens in these patients in this phase. So all the images that I'm not going to pay attention because this timer is already stressing me out a little bit. So I'm going to speak about cases that really drew my attention. So it's a male. So this man had a validity for 4 months. He was treated here in Madrid because they wanted him to go back to walk. But when he got to us, he had this capacity of the upper limbs, the more distal the worse. So it was very low. So our MRC of the extension of his fingers was 0 when we got him. So this is for you, the idea to see how he could move his wrists and his fingers. And this day, after a month being treated in our center, I was just inspired. I'm not going to say, okay, no, he was just a perfect candidate. No, we want to try to develop and research, investigate, understand, following this Dr. Torres, how this therapy helps us. And so this day I decided, you can see like he's not moving, he hasn't got any extension in his wrist or fingers. So I decided to try this CTU at a distal level. So my reasoning was, let's stimulate the nerves and the muscles that belong to this nerve, the ones that are responsible of the wrist and fingers extension. So for a month we failed in some stimulation strategy, both electrostimulation, functional and classical, because we wanted to find with the electrodes stimulate these nerves that have no connection. So as I said, we failed. The response we had was a failure. So in this moment, we started to suspect that we wouldn't have this still response. If you don't have them in your hands, then this would require a big, strong level of dependence in his life, as you can all imagine, as you can all say. So this is the first part of the session. So where you can see what he is doing. Now he's trying to move his palms. He's activating it. So we were stimulating the extensors, the radial nerves, and some parts there, and we could see he was starting. I was like, oh my God, we do see some extension now. We can work with this wrist. So once we were here, my motivation made me to share this with Dr. Torres, and he said, like, okay, let's show it. I was like, okay, then let's assess it properly. And for me, it was very important to value the dissociation of the movement, because these patients, the ones who have such a huge difficulty, because they do whatever they can. They even they use their flexes, even their necks, even their jaws to see if something's working there. But I wanted to say, okay, let's dissociate the movement, because I know it's not functional, but I'm very interested to see how this is going to work. So, for example, lifting the arms to the front, to the sides, and we can see here the capacity that he has. Because it was a bit asymmetric, it was less in the upper left limb, in the upper left arm. So we're here, this was our 4th session with diamagnetic therapy, and up to here we were only treating shoulders down. You know some, but I was wrong, but I'm going to explain why. So we are repeating here, but you can see the results from the 1st session, and here is the 4th session after 4 weeks, more or less. So we saw the wrist extension, and the 5th finger was extending as well, and that led us to say, okay, this is actually working. So our treatment tackled much more the upper arm, the left arm, instead of the right arm. So at this moment here, our friend and mentor, Dr. Torres, told us something that was already a part of a theory, but we didn't do it on the practical part. And he was like, don't forget that it's not just the root, it also goes up. So it goes up through the bone marrow. And I told him he's nearly doing a Miller Fisher, but he was intubated. So he was like, okay, don't forget to stimulate the bulb and the bone marrow. And that's what we did in the 4th session. So after 14th session, that's when I sent my presentation. I think I was one of the very first one. The patient is doing much better, but you can see the improvement, the dissociation of the movement, in which there are other muscles that wouldn't go in this pattern, like brachial triceps. You can see that the patient is doing much better when lifting the arm, when putting the arms aside, and it's very obvious in the dissociation of the movement that is anti-natural, which is, okay, you can listen to it now. That is when, okay, it looks like get your motorbike started, so you can see the both arms and how he's doing it here, that it increased a lot, this movement dissociation for the comparison, which is what you're gonna see now, how it was different in the dorsal extension and in the wrist, mostly in the wrist, after these 14 sessions. And you can see here that there is a big change. But not only that, is the patient can go to 2 parts that are antagonists. Because when we have a patient and you do this flexion, it goes up. So you've got the elbow flexors and antepulsors with an internal rotation. And here the patient can do this, activating the triceps and leaving the arm there. So the repercussion is going to be very interesting, as you can see. Right now, up to this moment here, we thought about, we had a goal to improve the movement, because he could walk already, but if you see he's walking, you see that 2 kilometers per hour, so he wasn't feeling very safe, if we could say. And there wasn't a huge risk, but you can see his steps and everything. It wasn't the safest thing, it wasn't the greatest thing. So you say, okay, so let's see what happens if we stimulate the peripheral nerves of the lower limbs, lower legs, to see your muscles, the flexors, etc. Because all of them influence in these activities. And if you see the comparative, and we had a 14 session for the 5, 6 sessions for the plexus and the lower limbs. And you can see here the length of the steps are better, the movement, when he's moving his arms also, we can see the difference because of the upper limbs, and the posture is much more uptight. If he's on 2 kilometers per hour, then we think that they need to translate it in a functional field, and this will translate in being more autonomous. So you can see the length of the step, and if we take it to a 6 minutes test, then when he gets to a center, he can only do 270 meters. That's barely nothing. And after 5-6 sessions, that's when we sent the presentation for the Congress, then it was 360. That's nearly 50% improvement in his walking skills, and he wasn't even walking on it. We were not walking on the belt or anything. It was just in the protocol incorporate some work in this back part and the muscles, as I said. So the challenges we had to see as diagnostic therapies, as they can help us in these pathologies to generate more clinic cases like Dr. Cardenas, like mine, and then put them in common so we can study the variables and find the better parameters to offer these patients, so we can offer recommendations for their own cases, which is what we want to do, which is having a better scientific production. Conclusions and not challenges anymore is that diamagnetic therapy is safe regarding PN. It's safe when we are tackling neuropathies. It's non-invasive, it's easy to apply. So I'd like to know if he had done that before. How would he have reacted when it happened in that acute phase? It's easy to apply, as I said, both in the patients who are in hospital and the one who are not in the hospital. So it is faster and better than conventional therapy. So let's do it. Again, thank you to all my colleagues. It wasn't just me. I have the responsibility to speak about it here, but all my team work with it. The team I'm lucky enough to be here, to be working with, who's helping this and this patient. And I don't know if in Coruña we'll have so much for a congress, but I would love to have a symposium all there. Thank you very much.
Muchas gracias.
Thank you. Thank you, Serafín. Thank you so much. So with your presentation and all your cases, we're still shocked about how it works. So without further ado, we call upon we'll call upon Felipe Torres, Vincenzo Rania, Karim Delgado from his spaceship from Alberta in Canada, and Serafín Ortigueira. Thank you so much. Please stick to time so we won't go over time. We've got 10 minutes. From this very moment on, all the questions you have, shoot.
So good morning everyone again. So let's be quick. We only have 10 minutes for Q&A. So let's see if we have some questions in the audience. We talked about many topics. It was all very relevant and very interesting. So any questions? Let's see here.
Females during 13 to 18 years and suffering from depression, that may be also due to the deficiency of this COMT enzyme, that is degrading dopamine, and that is severely affected by estrogen. So one can look for the deficiency of this dysfunctional SNPs. And this is probably due to the oxidative stress by the imbalance of COMT and MAO-R, the monoamino oxidase, which is also an X chromosome gene. And there we have another idea how that could induce autoimmunity.
Yes. Lo que sí hemos visto en algunos pacientes.
Yeah, we've seen in some patients in this age, we see changes in hormones, and this can lead to an imbalance of H1 increasing interleukin 17, as the doctor said. So we can do a balance of the dopamine, and this imbalance can create an alteration of the GABA, causing also an alteration in the noradrenaline. So this leads to polycystic situations often also, with this like a self-immune situation. So we've done a study with some patients with some depression, with dopa, GABA, and serotonin, noradrenaline, and also with cortisol. And we feel we will find a low serotonin and moderate dopamine, but we found a big process of fatigue, renal fatigue, and a serotonin that was very high instead of low. So we believe that part of this is similar to what happens with diabetes type 2, which is a damage in the receiver and a blocking, and that's why then there is more serotonin to compensate the depressive situation. So what we did with these patients was bringing this to better drainage and an improvement in the receivers. Thank you, Felipe. Thank you now, Felipe. More questions? Congratulations for your paper. It was very interesting. What is your experience with the diamagnetic therapy in patients with a botulinum toxin, and what were the times? We've seen that there is an increase of the period of placing the toxin. So we're placing it after 8 to 10 months. So now with this, we can have it longer for 1 to 2 years, but we do more with the CTS wave. With diamagnetic therapy, we will wait 3 weeks after the placing of this to stimulate it, and so there is no drainage of the toxin, and so that we keep it longer. Great, so if there's no questions, I will ask. You showed us, Felipe, that there is also microbulia involved. So if we deal the patients, if you treat the patients with opioids, are we going to see a change from an anti-inflammatory to a pre-inflammatory situation? Do you think this could be modulated? Yes, so neurotrophin 3 and 4 are very active in the glia, and traditionally the chronic process with opioids is low, and interleukin 6 and interferon are high. So after the transcranial stimulation, we found that increased neurotrophin 3 and 4, and we believe inflammation was going down. So I believe, yes, with this we can change it, we can improve it with the technology. And what can we do if we use botulinum toxin? We've seen some similar experiments with therapy. Have we done any research on using this therapy for botulinum toxin? Well, ozone therapy is a therapy that we've known for many years, and this allows the patients to stimulate the response of the tissues through an acute oxidative stress, also modulating the tissues, the damaged tissues. So we've seen the benefits of the treatments with the ozone therapy, including diamagnetic therapy. So through this, the ozone can reach nervous structures that we could not reach with other methods. But we may need some more infiltrations a bit deeper, and also oxygen and ozone therapy. This can help a lot if used with combined with diamagnetic therapy, because this could stimulate the cell regeneration in a broader way. Any more questions? If we have a patient after 2 brain tumors. Now she has shaking like Parkinson. Could we treat her with diamagnetism? In this case, if it's a secondary Parkinson after the inflammation, we would observe, we need to first understand what the zone is. I like doing the ARMA in the perilesional area to find the relation of these to Parkinson, and if we find that we stimulated the specific area, there we can see a control of the movement rather than in the shaking. But yeah, we can achieve a better control. And what about the area? If can we stimulate it? Well, if there is an active area, and if it's been more than 6 months without reactivation, although probably we can use it later on for cancer, but right now we have to be very careful in the treatment of the areas where there is an active tumor.
For the English questions. So, Dr. Torres, your trend that you showed for autism and ADHD, other autoimmune diseases, is there any correlation, is there any study from the infant or childhood vaccine schedules that have just been overlaid into the youth of America and other places? I think it can be directly correlated right now.
Aunque hay estudios que muestran sí una relación directa del uso de vacunas.
Well, with the direct relationship with the use of vaccinations for the later uses to start with autism, for example, this has not been placed at first level, but that's what the studies say. But 90% of my patients say that after vaccination, when they're older than 1 year, they start with the activation of autism. And obviously, we believe that in the first 2 years, the results are much better if we do it in the early years rather than waiting for them to be over 12 years old.
Rania, really interesting work. Did you get to the mobility side of your improvement with the MS patients? I noticed you dramatically reduced the drug schedule. But is there any mobility improvement that you've been able to see on the study yet for motion? For motion? Mobility improvement with diamagnetic treatment from the MS patients? Not yet? Not yet?
I don't understand very well the
I'll ask
question.
You separately.
Okay.
Thank you.
Sí, la promoción de la diamagnética en el uso de la patología de la esclerosis múltiple, poderla llevar a que sea un tratamiento.
A good good pain control, and the way to treat the patient is it come in our hospital twice a week, and we can have a really tight follow-up for the patient, and to ask the control by neurologist. But the diamagnetic therapy is very good because even if at the moment we use it only for the pain treatment, I hope in the future we can use it for to control the degeneration of the axons. Okay, for the moment we use it only for pain control, but I think that we can improve the treatment with a specific protocol for control the evolution of the pain of the illness.
The sport is important. In the last 10 years, I work in stem cells in sclerosis multiple, and we get good results in the stop the development in the disease. For really in the last 2 years is about the stem cells and diamagnetic therapy, and observation more faster recovery and really more movement after to treatment. Before is only stop the disease. In this case, is return to the non-normality or is return to mobility.
Yes, symptom treatment is the way in the USA, And I believe that you're on the track to healing these autoimmune disease, and you can start with MS. But it is phenomenal, and please keep up the excellent work. Thank you.
Altre due domande. Una la facciamo al dottor Delgado.
We have two more questions from Dr. Delgado and Dr. Ortigueira. So one question, Dr. Delgado, what are we expecting for the future in Canada for the biomarkers? Biomarkers are something which are very complex. So how can we do for predictivity? How do we do the analysis of biomarkers so that we can apply them to our patients? So one of the problems that we have today is to understand what type of pain it is and where it comes from. So biomarkers can be sometimes very strange and sometimes they're not specific. So if we think of the proteins and cytokines, how can we have all these languages being interpreted?
Non ha capito.
Ok. Dr. Delgado, I have a question for you. What is, in your opinion, the possible association between biomarkers and predictivity of disease? I think to pain disease. For example, reactive protein is not specific, as well as interleukin or matrix metalloproteases are not specific biomarkers. How is possible to understand the specific role of these biomarkers in with artificial intelligence or with other development of the future medicine?
Sorry, there we go. I couldn't hear you before.
Oh.
Can you repeat your question one more time? My apologies.
What is the role of biomarkers in the disease, in your opinion?
Biomarkers are really important. We believe that with the platform that we've come up with, we're able to look at a 360 perspective view of the human body, and biomarkers and biometrics really play a key role in understanding that. Right now, human beings, even very intelligent people, are not able to see the patterns across multiple depth and width of it, right? And so biomarkers are a really important measurement, but I think that we need to look at the 360 perspective view, because a lot of times we might not see the impact across systems, right? So taking a fully comprehensive approach, I think it's a valuable thing. Biomarkers are critical to that. I think they need to be, for artificial intelligence, the wider, more information we can have, the better that we can actually see these patterns. That might not be very simple to infer with just human intelligence. So artificial intelligence is allowing us to really get into deep and wide analysis of biomarkers and biometrics, and really make those correlations and see the patterns that are not visible to us intuitively using the human brain.
Okay, thank you very much. L'ultima domanda, dottor Ortigueira, qual è l'esperienza nella neuropatia da radioterapia o da chemioterapia?
So Dr. Ortigueira, what is the experience with the machines we have? How do you use it right now? So right now in the clinic, well, thank you so much for your question. My experience with this type of cases, it's zero. I've had no experience with those cases. But right now I have a very rare neuropathy, because I had not treated that before. It was a neuropathy which is sensitive, purely sensitive. And I've had some historic patients in 23 years working in neurological rehab. I had patients with neuropathy after radiotherapy and chemotherapy, but I didn't have this technology, so I didn't test it. So I'm more based in the classical electrotherapy. So I'm so sorry I cannot answer to your question. Right, thank you so much. Now we can move on.
Thank you everyone who's been participated in this round table. So the next speaker we have is a speaker with a huge experience when treating clinical cases that are not, I'm not going to say impossible, but very complicated. His name is Estefanía Torres. He's coming from Italy, and he's going to speak about diamagnetic biotechnology in pulmonary vascular inflammatory pathologies.
Hello everyone, Estefanía Torres is my name. I'm a physiotherapist from Italy. So today I hold my paper in Spanish, so my apologies if I make any mistakes in the Spanish language. So before we start, I would like to thank Peripheral Academy and the company Peripheral and Fisolde for inviting me to be here again in this conference. So I will present my clinical experience with the diamagnetic pump that I've had this experience for 12 years. This is the team in my clinic. So thanks to their work, I achieved all the results I'm going to introduce now. So I'm lucky to work with many orthopedic doctors, neurosurgeons, and also rehab doctors. And also as a physiotherapist in Italy, I'm also lucky to go to the surgeon theater with my colleagues. So these are some of the data from my experience. As I said before, it's been 12 years of experience with the diamagnetic pump, and I treated over 6,000 patients, and we had over 35,000 treatments. So you can understand that in our clinic, we use the diamagnetic pump sort of every day and sort of always for all patients. And we start off in the morning, we switch it on in the morning and switch it off. Switch it on in the morning and switch it off in the evening. So very honestly, we can say that for us and for our patients, we use it for our most complex patients. So our diamagnetic pump helps a lot, and it helps us obtain results we had never obtained in the past with other devices. So this is the first case that I did with diamagnetic pump. It was a very complex case. It was a very young lady. When she had this accident, she was younger than 18, and she was a dancer. And I'm also lucky to work with this surgeon. He's a freak about reconstructive and plastic surgery, and with him we obtained an amazing result. So it's Dr. Sergio Vrazzano from the most important hospital in my city in Naples, Ospedale Cardenas. So this was the situation. This is how the lady came with the ambulance to the hospital. I'm missing here the picture of the first time where the lady came to my clinic, because I was very confused on what I was looking at, and I could not be so quick as to take photos or anything or video. So here we can see what it looked like after 2 sessions. And here we can see a video before, the day before and after. Maybe we can, let's see if we can play the video This was before she came to my clinic. And the doctor did a muscular transplant from the dorsal for the quadriceps. And this lady, when she arrived in the hospital, the only solution there was to have the foot amputated to protect the vascular system. Can we have the video? Oh yeah, perfect. This is what she looked like before she came to my clinic, and as you can see, after the reconstruction, there is still a lot of soft tissue missing. It was all very inflamed, like a balloon. And also here we can see the videos. And the lady came to my clinic in the wheelchair. And after 8 sessions, she could walk. And the main problem was that she also had a fracture of almost everywhere, but especially was in the foot. It was an exposed fracture. But she could walk with her crutches very quickly. So before that, she didn't have the possibility to use the shoes, so she was going with a walker. So this she could walk with crutches after 8 sessions. You can see to the right. So when she came to my clinic, she had no mobility at all. These are some of the pictures where we can see the evolution of the patient and the evolution of the tissue. And it is important and very obvious the effect on the movement of the liquids, but also the effect on the scars, and also on the skin and on the tissue. So this is the evolution and the chronology and the follow-up after 1 year. And we can see a huge difference, and especially the lady went back to doing everything. She could walk, run, and what she loved most, because it was her dream was to dance again. So she would always ask me, Doc, I want to walk, but my very dream is to dance again, because I live for dancing. And everywhere she's been in many newspapers about dancing in my city. So these are the exercises she would do in the gym with the rehab doctors. And there was something that would she had shell kinesio 4V, and this is why this made things a bit slower. So when she was good with us in the clinic, she would do all the exercises, she would go up the steps and everything, and proprioception was good. But whenever she was outdoors, at the street, and in another environment, when she wouldn't feel safe, if it wasn't a safe environment, she was scared of doing the steps. So little by little, when she was walking, once I was walking with her the street, doing some steps, and she changed a lot the way in which I will understand the pathology and the psychological problems that these type of patients can have. So as a summary, I say this is the miracle of the diamagnetic pump.
These inviolable sanctities were preserved in those 10 words. And it is the desacralization of all of these that has put us in the mess that we find ourselves.
And I forgot to mention that, well, the accident that she had, this happened during COVID. And she had been in hospital without seeing her family and her mother for 3 months. This was the first time that she went back to dancing. And she graduated in dance. This is another case with the same situation, with the risk of amputation. In this case, this was a bad patient because he was smoking a lot, and he would also drink alcohol. So it was not what I expected after the experience that I had with this great girl. With this patient, you will tell her to do this, and she will do what you say. So this patient was a bit more special, but after getting his trust and his respect, he improved more. And the diagnosis was also a multiple fracture with the risk of amputation. So the treatment was also with Dr. Sergio Razzano, with a total reconstruction of the skin and also muscular transplant from the dorsal and also from the leg on the foot. This is, so this was at the beginning. Some of the first photos when he came to our clinic. So the foot was like a balloon. It was so it was really, really big. And after working with the, actually here you can see already the difference to the right after 2 months of treatment. So this patient, I also need to say, the diamagnetic pump allowed me in my city, I'm in Sorrento, to the south of Naples. Now I have the possibility to treat patients coming to my clinic from other cities. So this patient had to travel almost 2 hours of car to come to my clinic. So with all the difficulties of this patient, because obviously they was coming in a wheelchair, and they need someone to assist them, to bring them. But this patient treated him no more than 3 times a week. And these were the results after 2 months. After the different sessions. So you can see also how the color of the skin is evolving and not just the edema, and also, of course, the scar, and the mobility is also improving, of course. So here in the video, this is after 2 months of sessions with the diamagnetic pump. And the shoes, it looks like the clown Krusty from The Simpsons. It's 3 sizes bigger. But for me, with this type of patients, it was important to wear them as soon as possible. So, because from the psychological point of view, and also so that he can have a better load management. So, but I always think of these patients whenever they do the first step, because for them it's like doing something abnormal. For them it's really something really important, extraordinary. So we also do global work at the gym with the different tools that we have. And this was after 35 sessions with the pump, and the results were super amazing because the gentleman, he was smoking the first months, but I was very scared about that, of not doing a good job, or not being efficient. And as you can see here in the first picture, there is a huge difference of how it was before and after the diamagnetic therapy. And you can see here also the scars and the color of the skin, and clearly the mobility. This was at the end of the 5 months of treatment. We can see it looks almost like a normal foot. So at the beginning, if I had shown you the pictures here at the beginning, you would have never believed what it looked like before. So again, this is the evolution of the second miracle, of my second miracle with the diamagnetic pump. So I have many cases of fractures, hernia, protrusions. But what I like really presenting to you, these are cases which I call the wow effect. Because when a doctor when a physician sees these results, it's really difficult not to accept the results of the diamagnetic pump, because if hadn't I had the diamagnetic pump, I would have never believed in doing such a job, and also having the responsibility as a physiotherapist to deal with these patients. This was also crazy, this case of this patient, because he had tried everything and everything went wrong. Before coming to my clinic, he had went to the surgeon 6 or 7 times, so they had tried everything: orthopedics, plastical surgery, reconstruction, and he had also had a Lizarov, and then it was removed, and then again Lizarov. So it was like the Russian roulette here. So the patient didn't know what to do, and every time you do not know what to do, every time they wouldn't know what to do, then the patient goes to the destination, which is amputation. Once they try everything, then it's like, oh, so sorry, we tried everything, but we need amputation. But luckily enough, this patient went to my friend, to the surgeon, and he did a similar. He came to the surgeon for plastic reconstruction, and he did a transplant just of a skin transplant. You can see what it looked like before, and a lot of skin had been removed and a lot of bone. So he just did a skin graft, and after the skin transplant, as you can see in the second picture, there was a lot of edema. And they had to continue with the reconstruction job. He had the VAC therapy. This granted the possibility, after 10 or 11 years, to have an objective look and a direct look during the treatment to see what the diamagnetic pump does on the movement of the liquids. I'll show you the video later. So here this was before the treatment. As you can see, there's no movement of the liquids. And now after the pump,
Sergi, il drenaggio ha messo
like
il tubo con la pompa. Ci mi vede pure al dottore.
So yeah, this was a message I sent to the doctor. I said, Sergio, look, the drainage, now this is working very fast now. It's running really well. So now it looks really good. You can see the big difference with
Sergi,
the movement of the liquids.
il drenaggio ha messo il tubo con la pompa. Ci mi vede pure al dottore.
And in the last picture, we can see the drainage of this treatment. During this treatment, in this session, it looked like a shower. The video is very short, but it was like it was running like a Ferrari or an F-40 airplane. So this is really what the pump does. We can say it in many words, but normally we believe what we see. So this is our reality. And of course, we are working a lot with the device. So then the patient came to my clinic in a wheelchair with many problems on the back and cervical problems and headaches. So it's very complex patients. And this was the perfect patient because here everything I asked him to do, he would do it. So the result was amazing. And also we did with the same doctor, we did a plastic reconstruction from the he got the orthopedics with Philo de Kirchner for the fracture. And also there was the risk of amputation, but not because of the severity of the trauma, but because he had been for 3 months in another hospital just waiting. I don't know what they were waiting for, but yeah, he was in the waiting list, and there was a big risk also with the risk of infection. There was a big risk for amputation. So this is the evolution of our patient. So this is how he arrived into our clinic. It's always the foot is like a big ball. And after the months, these are the results. Also mobility clearly starts to improve. So here we can appreciate the change of the foot, the shape, the color. So this was after 30 sessions. He also came in a wheelchair. And then he was older and he was a bit more scared to do everything, but he did.
Luoghi smart, lo potevate mettere. Come si sente?
The patient said to me, "Hey doctor, you could have told me, if you had told me you were recording a video, I would be smarter with my clothes." But I was like, "Hey, we're just recording your food, so that's fine." So this is another guy. He had a motorbike accident, and there was also the risk for amputation, and also with the infection, because he had been waiting in 2 hospitals for 2 months, going from one place to the other, and the doctors wouldn't know what to do. So you go to one hospital and to the other. So in the end, it was 4 months of waiting. So yeah, they didn't know what to do. So also, he was lucky to meet Dr. Razzano. So then he came to our clinic. So here we can see the third picture. This was the day before he came to our clinic. And this was after the first session. And the problem of this guy is that he also had a big fracture in the ankle. And there was no surgery treatment there in an orthopedic way. So now the problem was not just the edema and the reconstructed tissues, but the articulation blocking. So the colleague, the speaker before, said that one of the causes of, well, a big cause of suicide can be when some patients suffer certain diseases. Like this patient had a very bad situation, like every day she had a neuralgia of her trigeminus, and here we'll cover it for her. He was normal with his neurology, and after 10 sessions, but her life changed. And after she was treated, she gained again the will to live. After she had been suffering from neuralgia of a trigeminal nerve. And this is one of the cases where we treat. Well, just very quickly, we treated very quick after the surgery. After most of the surgeries that we can treat in our clinic, we treat very quick after the operations. So here she had the operation of vulvar valgo. This was the treatment. And she had this problem in the toe for 3 years. Also, she had an osteotomy of the toe, and after 1 cycle of the diamagnetic pump, she had no pain. I'm so sorry that I'm running so fast because the time is over, and also because I need to catch my flight. I need to run for my flight. So now, in case of this was also a case of fracture or polyfracture with the same patient and the same patient on the shoulder, elbow, and also on in the hand. So this is a very important space here, as you can see here, in the elbow. So the doctor said, "Hey, so now here we need a miracle." So now they call me Saint Stephanos. So yeah, I did a small miracle here. So this was before and after. So this was after 3 months. It was all very clean afterwards. And this treatment we do in the fractures. Even when it's covered, we can do it on top. On top of the cast, we can work up to 10 centimeters above, and with this we can win time, and the patients gain in health and money because everything goes quicker. And here, this was an osteopubalgia, and with a lot of pain. This was the edema. You can see, and this disappeared after the treatments with the pump. In this case I know very well because that's myself. So I do mountain biking. So it was the 24th of April. I broke my elbow with the capitalo-radial fracture, and then on the 2nd of May, before treating the patients, I treated myself as a patient. I didn't have a good face. And you can see that after 1 week, my goal was just one. I wanted to train again. And I didn't have no cast or no anything. I was a very bad patient. And the orthopedic said, hey, you're crazy, you're insane. But well, we know all sports people are crazy. So my goal was to compete before a month because I had a run, and so I had a lot to do. So yeah, I won the race. So I'm so sorry, I'm so over time. This was also a case where we were not sure if he was a temporary osteoporosis, but with the pump we had a very good result. Here we had also a very good result. He was a player of the National League for volleyball. This is a case also where after 3 months of an operation in the elbow, he came to our clinic for rehab, and there was a blocking of the elbow, and with the diamagnetic pump we did a very good job to unblock the elbow, also with the shock waves. This was a case of a tennis player with a big limitation in the movement. So we can conclude that after 12 years of use of the diamagnetic pump, this changed my life in these 12 years. This really, really makes a difference, because what I am today, this is thanks to the diamagnetic pump and thanks to Peripheral, because all my life long, my life evolved about my job and my family, and I need to thank the pump a lot, because thanks to the pump, I am what I am today as a professional, and a little bit also as a person. So this is my little girl, and now she says, I'll do the therapy on you when you're injured, because I think you're no good physiotherapist because you always injure yourself. So you're no good therapist, so I'll treat you. Great, so thank you so much, and thank you, Peripheral, and thank you, Fisauda team, for the great job you're doing here in these years. So we really hope to continue evolving for the best. Thank you very much.
Gracias. Muchas gracias.
Thank you very much, Stefano. Thank you. I have to say, flight back. Shocking pictures, the ones we've seen, right? It looks like something so magnificent. It's like a miracle. So Stefano was saying, as a physiotherapist, I wouldn't even been there to take on such a challenging case like the ones we've seen. But what we've seen is the result of the work of the magnetic therapy. Right, so Next speaker doesn't need any other presentation. She's a real training of diamagnetic therapy, Ariel Alfonso Varela. Thank you. It is great to be here, see all of you and feel as if I'm at home, because you make me feel at home every time you open your clinic's doors, your hospital's door, and when I get the chance to share with all of you a little bit of this craziness I've got in my head whenever I go to your clinics or to your hospitals and you open your hearts as well. So it really is beautiful. First of all, I would like to thank Pariso and the engineers of Pariso, because otherwise we wouldn't be here and this family would not be existing. But also Fisaude, every person that's part of it. First of all, Raul, who gets us started to do these diamagnetic miracles. Lolo, for his amazing work, for doing everything we can see here. Fernando, and I would mention each and every single one of you, because the final result, well, I get all the homages, kind of, because I bring the technology, but what would that be without the technology, without the doctors, the ones who always reply my answers, or my questions, sorry. Well, my name is Iria. I've got a clinic in Vigo, in the north of Spain. It's a clinic where I combine physiotherapy with training, because I'm a physiotherapist, but I also got a graduation in physical activity and sports. I've been working about different treatments, and I've been training different sessions in several things. And we started working with magnetic therapy, and I can say I'm happy since I got to know it, because I really am doing what I enjoy, and I can do these things because all of us here, this is what we're here for, because we want to help people, we want to help our patients. So I really do not want to forget and express my gratitude to all your efforts. I'm grateful to all the doctors, because this was very complicated, because we always had to show that this actually does things. So sometimes it's very tiring to be justifying yourself all the time, to be showing all the time that it works, that it's real. When you see what the machine does, we say like, then why is it not present in more hospital? Why is it not in the ICUs? Why are doctors not using it? Well, because it is hard, I understand. Maybe in the future when we look back, then we can see, as it's always happened in the medicine of history, but thanks to crazy people like us, thanks to professionals and doctors who are here, who are promoting all of this, because I'm sure they have to face all the colleagues saying, but what is that therapy, new therapy you're talking about? So again, thank you for being here, and I want you to investigate even more about this, so we can dedicate more efforts so this can get to patients, so the patients can have a better life quality with what we can do. This is for me, right? Yes. Okay. It's a great honor, but it is also a responsibility being here, because we speak more and more about this diamagnetic miracles, so I demand more of myself and you demand more of me, because I understand that this is a diamagnetic therapy, it's an integrative therapy, and we are demanded for more, and they require more from us, and it happens the same with you, because you have more expectations for you, for the patients, so you can give them solutions. So I feel okay, I feel relaxed if with these slides you'll see, then I can get to you summarizing what we've explained before, which is everything that the machine can do, because you see, like Dr. Pietro said, Dr. Felipe Torres said, that it is our diamagnetic therapy, and with these two technologies, or three technologies that we have, diamagnetotherapy and the waves, so through them we get to people, and then we can do three things at three levels. The liquid drainage, so we get the swelling out, we renovate the extracell matrix, and we interact with the cytoskeleton, so we achieve things like the ones you'll see. So once we've understood this, in the pictures you'll see, I want you to think that since it's a personalized, a customized therapy, we need to reassess, reevaluate the goals we want to achieve regarding these three things I just mentioned. What do we really want to get? So the first patient, I'm really fond of her actually. She's like my family now. She came to Madrid after 5 months. She had had a surgery that didn't go quite well, as you can see. It was surgery in her abdomen, and she had a necrosis. She had 3 surgeries afterwards. So every time they wanted to close it, it opened up again. So you can see all the pictures. So when she came to me, she had a severe depression as well, because she had what you can see in the picture. So she was depressed. She was having so many problems. So our colleague Sebas told her to come see me because she had this swelling. They told him it was because she was allergic to something. And no, not really, because what happened is that she was burnt, and she had 3rd-degree burns in all the walls of her abdomen. In the scans, in the echographies, we couldn't see anything. Everything was just black. She was taking anti-inflammatories, antidepressants. So we had a surprise with Marta, that's the patient. So we cleaned the wound and we started treating her. And the goals here is what we are speaking about, is firstly, get the swelling out. So also, we would need her to trust us. She need to be reliant on us, because she was like, I'm just so tired of everyone doing all of these things to me. So we got all the liquids out in the diaphragm, abdomen. We had the machine with a CTU on top of the ulcer to stimulate all the proliferation and all the scarring. And once she got up the bed, she could stand up, she could sit up. She was not just sitting down. She was like, okay, I can stand up. And maybe could I go through this to the beach with my mum? And she's like, okay, she got to see the light at the end of the tunnel, because we told her, go to the beach, of course. And she told me, okay, I'll be back on Monday. We used to do 3 sessions per week with cases like this one. On Monday, she called, she was doing amazing. She felt amazing at the beach. So could she stay? And I was like, of course, go ahead, join with your mum. And 11 days afterwards, this is how she came back. She hadn't seen her ulcer because it was covered. So when I saw it, I was like, what has happened? Because from here to here, just with 1 session, 11 days afterwards. So this also changed my way of treating her, because we got the evidence and everything you're doing, that you understand what's happening here. So 96 hours is the minimum for the generation process to start working, and then give another stimulus afterwards. This is in regeneration, because to control the swelling, this would be different if in case it was because of this inflammation, of this swelling. So the first session this is the 5th session on 29th September. You can see that the swelling is still there. So we need to control the pain. We did control pain neuropathy high in the ulcer, as the doctor was explaining. So to generate more tissues, we were reducing the abdomen, because we need this, so there won't be any problems in the future. So as you can see in the first sessions, so it has nothing to do. So the control and the diaphragm, they were completely different. So my obsession is that I wanted to close that ulcer, because we wanted to work with the diathermia, with diamagnetic therapy. So we wanted to combine both things, because since the very first session, all the tissue you could see changed in that very first session. So what we knew would be harder would be to work with the tissue around the ulcer and the one that's in the belly button. And once we got to close the scar, then we started working. Sorry, this is just a video, so you can see it. So these are different ways of working with it. We work with the neuromodulator of the surfaces, and then we were working with the shocking waves that doesn't hurt at all. And this tissue that's harder in the scar. So we were combining shocking waves, and we did 3 sessions with shock waves. We did them in the clinic, first one, another one in the physioda in the seasons, the sessions, and the last one was 4 days ago. And you can see here the difference of the process. So this is when she arrived, first session, 10 sessions afterwards, 13th session. This for me is very important. So this is why I show you the picture. So you can see that she has got hematomes, because I was doing this movement of the liquids. Whenever she said she was feeling different parts, because when we were combining the liquid movement, and the bruisings came up because she still had some coagula and then some clots, and this is when these bruisings came out. So we could see after 15 sessions here, from the first session to this one is the one she came the other day. So in the picture it looks like she's got some gaps, but it's just the color was whiter. This is the change you can see after 17 sessions and Marta. So it's very important when you ask me, when we speak in the forums and everything, and this is why I still insist on these goals and understanding the physiology on what we want to do, because I don't want to clear false expectations, because we want our treatment to be effective. So if Diamagnetotherapy, then we can close these tissues, because it's easier to work on these tissues. We can work on this hypotony that's secondary for, it just comes after pregnancy and birth, and then work to close that diastasis. But many times you tell me, well, I've got a patient who's 58 years old, he's just obese, can I close that? Well, is he pregnant? Because this is a baby of grease, it's a baby of fat. So if you've got the rests there on the parts, on the sides, what do you want to do? So if you want to close this diastasis, then we have to work with it, because there is excess of fat. Then we have to intervene with obviously food and doing some exercise, magnetotherapy, and then burn this visceral fat, because this is a hernia. So the tissue you see outside is the viscera that are coming out. So I need to work with it for putting everything together, and then generate some fascia amongst them for closing the abdomen. I think you're following, yes. So whenever you ask me these things, it's important, because when we're dealing with some chronic or low back pain, we need to see this, because, and I hope we can study this, because I want to study all the patients, and the patients I have seen who had low back pain, 100% of them, they had some abdomen diastasis, abdomen hernia. So when I go to a clinic that, for example, I don't know, they trust me, they expect a lot from the technology, and then they bring me a patient who had many treatments and everything, but they want me to perform a miracle, but I'm not going to be doing what he's been doing, treating the low back. So I treat the front part. As I was explaining before, while we were practicing, with the liquid movement, ultra high, intra high, so we release the fascia, we drain the liver, and once the patient gets up, that is the first time that feels a change in the back. They feel a change in the posture and in the front part, because that is the one that's creating that pain. And obviously we need to work on the upper limbs, in the lower limbs, and blocking the thorax. Which all of this seems easy, but obviously it's not. We just have to work on it. It is important to, with what I'm saying, to choose the accurate moment, because we need to get the best results. Why is this? Well, because as we saw with Dr. Karen, it's not the same thing to treat this abdomen surgery. You could see that was a disaster, but it's not the same thing working this after 5 months, an abdomen surgery 24 hours afterwards, because the results are this one. Just a month afterward, 4 sessions of CTU Omega 20, as you can see, because the first one looks like a corpse and the second one you could go to the beach. So it's important to be confident, because we want to prove that there are scientific evidence that this is safe. We are physiotherapists, we are doctors, and we can tell a patient, once you leave the hospital, come to us, even if you have the drainages still, because we will generate. We are not going to repair, we're going to regenerate. And this is very important if we want to diminish 90% the anti-inflammatories, and then when we get the final result. This is another patient. I'm also very fond of her. And you can see there are 2 pictures. They look the same. It is a patient who came 5 months after having surgery of the Achilles tendon, and she had it cut, and she was operated urgently, but they didn't put the bandages. They didn't put the bandages in the calcaneus. So 1 week afterwards, she had this ulcer here. She's 29 years old. She's smokes, and she is a little bit overweighted. But 5 months afterwards, she was like this. This was the second session. The very first one, when she was to get information about the treatment to see if it can be done, she came with another physiotherapist. Then I treat her on top of the bandages. So I didn't see the ulcer. So I tell her, okay, next time, please ask the nurse to get some bandages so I can change it, but I can see the tissue, I can see what's happening, so she can adapt. I can adapt the treatment regarding what I can observe in my patient. So in the second session, when the patient came, I removed the bandages and I start treating her. I clean the area, I put another bandage on top of the ulcer, and then the machine. And 10 minutes afterwards, I don't see anything. So, and you may ask me, what do you have to see? Well, things that I usually observe when I work on ulcers or tissue, or things that you see, you touch, as I was talking to Michela, because you see something's changing, the blood, for example. But I didn't like those 5-10 minutes after the treatment. I was like, okay, I'm going to put the diaphragm. So, and then you ask me, better with the diaphragm, some or not? Well, it depends. If you need it, you go for it. If you don't need it, no. If you wanted the blood, then you use it. That's what I wanted. I wanted the blood to gather. So I put the plate below the thigh, and I put it in touch with the skin, and you can see the difference from one picture to the other one. On the right side, the blood got there, and never again in the next treatments I had to use diaphragm. I just used it here because we activated something that needed to happen for this ulcer that had been stopped for 5 months. It's like the system had forgotten that they had to, it had to heal this. So then this is what the nurse sent me. She had been healing her. She had been taking care of her for 5 months. You can see there, 7th November, 21st November, 12th December, and then 8 sessions, 28th December. And Dr. Felipe was speaking about this, so if I can summarize of what everyone has said, just showing it here. So Felipe Torres was saying, like, depending the times we need to see the changes for the diamagnetic topics. So you can see the 8th session here, and then 16th January we kept on working because we activated the cells, the tissues, and they were still healing 8 sessions afterwards. And this very last one was 3 days ago. She was going to be as a patient, but she was going to come yesterday as a patient, but she had to be healed. So you can see the machine here, and before the session we had, and it is, I know you are used to it, but as a physiotherapist, it's incredible for me to see how the fascia layers are activating, how we are generating all of this, and how they specialize in whatever they have to specialize. If it's muscle, if it's skin, if it's filling. So what are we going to do now? Well, I was still paying attention to the graft. So when the doctors saw that, they were like, what is happening? What's going on? So they said, like, okay, maybe when you put your foot on the floor, does it hurt? Is it not going to hurt? Well, if it hurts, and the tissue stays rigid, stays robust, then we use shock therapy. Because if the calcaneus and the fibula are bones that get load and they need support, so once it's closed, if they've got the fibers, then we'll treat them with shock waves, as Dr. Karen was saying, using it in the calcaneus and in the calves, so you can improve it and have a very complete treatment. So this is another patient. It's good because we're not going to have lunch yet. The ones that have been out and have had a lunch, maybe you are not feeling amazing right now when you're watching these pictures. So, well, this is a patient who fell off a tree, like literally fell off a tree. And he fractured the calcaneus and the stragglers. He went into the hospital, he had reconstruction plates, and then he was dismissed. He went back to his house, and the week after he came back with foot swollen. He had high temperature, huge pain. After being tested for COVID, then they said, like, okay, something in the foot, and he was saying like that, like, okay, no, my foot hurts, I have got no COVID. So they could see he had a problem he got in the surgery, and because the surgery had only been done for not a long time ago, so obviously the calcaneus was not consolidated, and they needed the pseudomonas stays in the plaque until you don't get the plaque out. Then doing a graft would be complicated. So we could see let's see if we can get you the plaques out. And he was coming here like this. It would have 8 square centimeters of ulcer, a huge swollen. Maybe you can't see it here, but the heel, the calcaneus, it didn't belong there. And he said he was in diamagnetic therapy, and the and the surgeon said, like, maybe we wouldn't need the graft here. And the surgeon had said, yeah, whatever you want to say, because if you can cover that tendon with diamagnetic therapy, if you can cover that scar, then I won't operate anymore. I don't know if you searched for the surgeon on LinkedIn, but have a look here. Because we treated it with 2 different goals. First, get the swelling out, get rid of that swelling, and obviously the pain that this swelling was causing. And you did this moving the liquids and with the membranes. So the fractures will be put together again. We don't have to do it every day. No, we need 96 hours in between. And then with another membrane to start the scarring. And you can see here the coin size, so you can really see the picture. You can see the difference. Here it is. So obviously, we need to understand that the person could get rehabilitated before, he could walk before, he had no complications at all, and now he could get the plate out and they would need a graft. Because otherwise, there would be problems with the graft as well. Again, thank you to the hospital San Juan de Dios with Soraya, who wanted to fight, because when they knew the technology, well, I really enjoyed when Jose was saying like, oh, you're so lucky, you're going to this team, and it was like, no, I don't care, I'm not interested about any other thing, I just want to go to the hospital. This is that diabetic woman. She was in the hospital for 8 weeks, so you can see how the tissue was getting blacker, and it was just kind of rotting, festering. And I did sessions, and I don't have anything to say. Just look at the pictures a month afterwards. This is another patient, the ones that I really like. She's a lovely girl, and if it wasn't thanks to Miriam and her daring, we wouldn't have treated a person like this. She had an operation in nearly all her body. So her legs, her bottom, her tummy, and her breasts. So, and it's like, no, after you leave the hospital, you're amazing. But no, it looks like you just fell off a plane. There's a way you feel. So she came to Miriam's clinic in Barbera del Valles. I went there to treat her. So then they can continue with the treatment themselves. And I started working with her, treating her. I liked seeing this. We didn't need the bandages. She said that the drainage were hurting. The stitches she got were also very hurting. So surgery was 25 January. She came to us 27th January. She had a mastopexy, which is like her breasts were open. I don't want to say boobs, I really want to say breasts because I want to be polite, sorry. So she got her breasts open, then they were sewn back, and she said that she was scared that her nipples would fall off. So she was feeling such a huge pain in her breasts. She was obsessed because she said like one breast was much bigger than the other one, but it was just because of the swelling. So we started treating her. We just went by parts. As Jack the Ripper said, let's go in parts, let's do parts. So we treated what worried us the most. First, the breasts. So she would get the swelling out. We would get the swelling out. We would get rid of that swelling. Sometimes you can't really appreciate it in the pictures because until they finish the first diamagnetic therapy, like they even cry and they just say, oh my God, thank you, it's not hurting anymore, I don't feel this pressure anymore. So you can see 3 sessions before and after. Before and 3 sessions afterwards that are independent from the other ones because we couldn't do everything in the first session. So we were just dividing it in different days. This is for the legs, 3 sessions afterwards, understanding always that the plastic surgeons, they said getting rid of these bruises, that would take 2-4 months because it takes a while to get rid of those bruises. And then the surgery had been on the 25th of January. And afterwards, this was the second session we had in this area. She felt pain on the side because when she was drained, she didn't get sewn. They put just like a bandage, and she had the skin out. So whenever we got the bandage out, that's what was making her feeling her painful. So we had these bandages, and then we said, okay, go to the doctor so they can sew you. But the doctor didn't cut at all. They didn't do that. So this is how we got the bruises out. We got rid of the bruises, 2 sessions, 3 sessions afterwards. And this is what was the fun part, I would say. And I say it's fun because I think it's very important to understand physiology. When we were working on her breasts, I told her that please explain to your surgeon that we were doing this diamagnetic therapy, that even if he didn't know about it, it's something that regenerates at least 40% of any other thing that we might be using. So I saw this more times, so whenever there are things you need to remove, because they cannot be reabsorbed, if you accelerate the process and you wanted to get these stitches out 10 days afterwards, but you don't get them out when it's already scarred, then the body tries to get rid of them, and these create an infection. And this is what was happening. So we treated her, and how we were treating the breasts, we didn't create any pressure, there was no pain. And once we felt the tissue was getting back, then we just mobilized it. And this is where we had like our fights, because she talked to me through WhatsApp and she's like, no, I think it's going quite well. The next day, it gets red and the skin goes off. If you see these stitches, it looks horrible, as if we were sewing a chicken. So I told them, you need to tell the doctor to get rid of those stitches. They need to get them out, because otherwise we're just regenerating, but then infecting, regenerating, then infecting. And the doctor said, like, no, it wasn't possible. That just put some cream on, because no machine would accelerate it. And so the stitches were not getting out. So a week before, it was like that. I was like, please. She went to the clinic and she's like, just get them out, please, because I just can't deal with this anymore. Everything is fantastic, but this is not regenerating. So when we got rid of the stitches, then you just see 8 sessions afterwards, 10 sessions afterwards. I don't know what they're telling me. They're saying something, but I don't know what it means. So this girl here, also very fond of her, and she had a pathology. She was born with it. She had her malformation that she had veins and arteries all together, and while she was pregnant it got worse, and the solution, it was just amputate their hand. It's not just, it was like even amputate the arm up to here. So what she wanted to have, obviously not having any pain. And so another physiotherapist sent her to me, because no one was helping her. And as you can see, before and after 3 sessions. 3 sessions after the treatment. And I don't know if Dr. Blanco is here, or maybe he had to leave, but this is... do you want to explain it? Yes, you can come here. Well, this is thanks to doctor like Dr. Blanco, who are faithful and they believe in what we're doing. Then, like this, I can treat and maybe get all the privilege, like Emmanuel Lama, helping them. Hello, good afternoon. I'm Juan Manuel Blanca. I'm the Chief of Services of the football club in Fuenlabrada. And first of all, I would like to thank you for your invitation. I was here and I really wanted to learn what this is about. Working in football is working new miracles. You need to perform miracles every single day. And I think this is important to see why this was happening. So this footballer, was operated in November because he had a fracture of the of the right tendons in the ischiotherals. So we put an implant, the surgery went well, and while he was recovering, I guess because he was dealing with lows, then he had an edema on the ischiatic area. Then, and this is quite normal because that's where he had the implants. He had a scar where the stitches were, and what we couldn't just quite get, it was that he had this edema in the bones in the femur, because we could see something was happening, and then the truth is that the bone edema for us is, for us who work in traumatology in sports, then it is a big problem because we don't know and we don't have the tools to solve everything, and it's based on the experiences because there's no treatment that can help us. So we talked to Fisalde, and I'm really thankful because thanks to them we could use the cases, and I think this is the most descriptive one. Then we started with a treatment like with Iria, and it went very well because we were combining magnetotherapy and shock waves, and the evolution was as big that 1 month afterwards we had another scan, and the radiologist and the surgeon Manolo Leyes called me at midnight just to tell me what has happened here. And well, the edema had disappeared on the head of the femur because that was our main concern, and it had nearly disappeared with an improvement of the scar, and this improved the situation of the footballer, in this case allowing him to go back little by little to his job, to work in the pitch, and the evolution was amazing. I think he's in love with this treatment, and every time something hurts, now he just wants to come to have this diamagnetic therapy. He's playing now, and we are very happy and we are very grateful for having this technology. Thank you. And just to finish, to see how this treatment, cross-sectional treatment, as Jose says, is not just for physiotherapists, it's not just for doctors, it's a therapy we should all know, and it can be in all the treatment levels, from hospital to clinics, and this is what I do, everything that I'm doing. So she was ill in her ear, she had otitis, then I picked her up from school, and she was hurting so much. Four doctors said that it was nothing in her ear, it was something from her jaw causing this. So I got her, and I was like, okay, Iria, what would you do with a patient that's not your child? Because I just wanted to throw myself out of the window. So we took her to Fisalde, and I was like, okay, let's see what's happening, because with everything that I've been learning, everything that I've been explained to, let's see what happens. So I put her Diamagnetic therapy. So I took her doing this in the ear. I took the picture because someone asked me, like, what are you? So I just took the picture. I didn't even want to make a case out of it. She even fell asleep, and we put the membranes, 25 minutes. She woke up and was like, oh, feeling? She was like, yeah, I'm good. And it doesn't hurt anymore, but I just want to go home. I feel weird. So I took her home. She had such a high temperature, and she just told me, I'm just feeling okay, I'm good. I touched her, and we took a pus ball from her ear. And then she was like, at the hospital they were saying that I had nothing, but I was really feeling it, so you can tell. And this is after she had this pus out of her ear. So, because we could drain her ear like this. So, thank you very much. And I love you all.
Muchas gracias, Iria. Muchas gracias, eres infatigable.
Thank you so much, Iria. You're tireless, as you can show us every day. You're traveling all across Spain all the time to teach people in the country, to do the training. A big round of applause for the great job of Iria. And always with a huge smile. So next we're going to have the last paper before the round table, Gentian Cuko, sarcopenia. We're going to see how to treat it with the new technologies. I want to thank Paris Academy and the whole technical team and the organizers for having me here. I know we are behind the schedule, so I'll just summarize very quickly to go into some concepts. So I'll flick through the slides very, very quickly. So sarcopenia is just not just the loss of muscle mass, but also often we have elderly people suffering this. So it's also a loss of or reduction of muscle strength. And it's not all the same. There is different features. It is classified as level 10, but often we can compare it to malnutrition, cachexia, or fragility, but it's all different things. It has a huge impact on health. It can lead to fractures or cognitive alterations and everything we can think of. And it also has an impact on the sanitary economy. And the costs in hospital can increase up to times 5. So the European work on sarcopenia in Europe, the working group in the first meetings, they thought that this was an elderly syndrome. But in the last update in 2019, there's now the concept of muscular strength, because this is about the functionality of the muscle. And also we have the introduction of a primary sarcopenia and secondary sarcopenia. And then there's also the classification of acute or chronic. As we know, when we get older, me also, so after the age of 30, we start losing some muscle mass, muscle strength, and more after 50 years, and after 60 years. And also there are some changes in terms of the fibers and the different moving units in the muscle. So the most important elements here with oxidative stress and chronic inflammation. So we've already talked a lot about chronic inflammation in this Congress, and I will not talk about interleukins. So I'll jump this. And here, when it comes to muscular activation, we need to take into account the whole chain from the activation from the brain to all the elements that are included, participating in the activation or the muscle contraction. So these are all the systems which are different tissues. And we have membranes, ions. So there could be any failure here that could lead to some disorder of the functioning of the muscle. And this we can summarize as transduction of signals, as we've been hearing these days in the conference. And also we need to take into account that there is something we cannot change. We have a peak of the muscle strength, and at an adult age this can go down, and we can try to minimize this but not stop it. So this graph may also recall something similar to what happens in the decreasing of bone mass. So now there's also not just sarcopenia, but also osteosarcopenia, because this is all related. So it's not just a muscle issue, but also we can have some bone problem. So this is a pathology which is underdiagnosed and undertreated, with a high impact in our society and our economy. And what is essential to deal with this? Well, we need an early diagnosis and an optimal treatment. So we've improved in the diagnosis in almost everything. Now we identify this quicker. We have a flow chart with the different symptoms, and it comes from different associations to help us target the treatment better, whether it is just for sarcopenia or osteopenia or osteosarcopenia. Also, we've improved in the early diagnosis. So the European Working Group on Sarcopenia, now with very little devices, with these means of diagnosis, like the hand grip here, with very simple tests, we can do early detection of the patients here. So as we explained before, this is not just a problem of the muscle mass, but also of the muscle strength. Also, we've improved a lot in the secondary causes of sarcopenia and osteosarcopenia. So all these causes we can modify through a healthy lifestyle, nutrition and exercise. And we've had a lot of advancements in the exercises we need to do. It should not be just aerobic exercise, but we should combine exercises. Also, we have some products of nutrition with some supplements that we can administer. So there's a huge advance here. So if everything's clear, so why can we not eliminate sarcopenia? Why do we still have sarcopenia? Why do we have patients where sarcopenia continues despite doing everything properly? So here the clinical doctors always have a problem, and when we speak to the industry, to the pharmaceutical industry, since we are now here in this conference, interdisciplinary conference, it is important to help each other. So that's why we can use technology. So of course we have this device. We've been talking about this since yesterday, and the features here seem to be at least very interesting. So we have enough intensity, high intensity, low frequency, and a selective amplitude. So with this, we can stimulate different tissues, different structures. So when it comes to the protocols, what, when, and how to treat, this is a pathology which is not static. Sarcopenia evolves, and it has different moments. We have different ages. It happens at different ages, different sex in the patients. Osteopenia or sarcopenia, different emotional status of the patients. So this is all changing. So how to treat them? Well, obviously, when we cannot get to more with exercise and with food, and we need to treat this. So here, when we need to act, it's not just that, but also in the talk by Dr. Karim this morning, we've seen that we can also act at early stages. I personally do not have the experience there, but other doctors have. So I would work with the experience that we have with some patients now. I'll work on the bigger muscle groups, but also going back to the whole system, maybe thinking if there is some failure in the whole system from the brain down to the specific muscle. So here we can see the individualized treatments that we should have. And even from one session to the other, maybe we should always constantly adapt the protocols. And the same happens when we apply the exercises. If you do exercises, you need to go in crescendo, increasing the difficulty, so there is a change in the physiology. So we already have some studies published on various pathologies and the impact. And we can see that magnetic stimulation together with the classic stimulation can be really good for muscle evolution, and especially when it comes to neuroplasticity. So if we work on this, we can reach also the nervous system to have an additional stimulus to take the plasticity of the tissues. So what do we need? Of course, we're missing more and more clinical practice with all of you guys. We've seen some very interesting cases, so that's why we need a bigger network so that we can comment on all those clinical cases. So we're missing more investigation, more research. And of course, we have some studies where we can talk about magnetic stimulation, and there are some studies where we can check. And of course, we need to analyze the dosage, the duration, the times. So it's not just the beginning. So there's a lot of work still to be carried on. So of course, now with the Peripheral Academy, probably we can improve much more. So we can summarize that diamagnetic treatment is a painless treatment, and we can have a greater tissue penetration. It is a selective stimulation. We obtain a homogeneous diffusion, and of course, skin contact is not necessary. So this is great to continue advancing from here. So now I just want to thank NAFTA Health Space helping me here. So this was the beginning of, it was one of the first places where we've been working with diamagnetic therapy. Thank you so much. Thank you so much, Gentian Cuko, for keeping your time short. So let's have now Ilya Alfonso Varela. Stefan Rocco had to run to catch his flight, and Karen Cardenas will lead this round table. Let's keep it a bit brief, because I'm sure everyone is a bit hungry. So please ask the questions you have, but short questions. Thank you.
Okay, so really, this was fascinating, and you finished with a topic that it was my thesis. I love sarcopenia, and that's why the intervention was before intervening the patient with CTU in order to give to achieve those goals. So if you have any questions, I would love to have questions. Hello. In what moment? Well, we know sarcopenia can be something chronic, and many people can have it, and obviously we know that it's related to our body and our muscles. For this, we need strength exercises. So when do I apply the pump? Before or after? Well, that's what I was saying. Do you mean related to the strength exercises? Yes, before the exercise or after the exercise? Well, I think it could be in both cases, before and after, because what the pump does is you can modulate the parameters depending on what you get. If you want to stimulate before the muscle and then do a different stimulus, you can do that, but it depends on where you're applying it as well. If you want to apply on the muscle or in the nervous system, then maybe I would do a prior stimulus and then I would help that muscle. But it is what we were saying before, then our practice is variable and we're working on it. We are gathering some data, and it's a pathology that's actually very interesting. And then obviously given the impact, the socio-economical impact they have. Okay, yeah, thank you. Any other questions? No, they're just hungry. Yes, very quickly. In the ulcers, when we use shock waves, then we expect to have an acute response. So they're using it twice a week. So if we do it with diamagnetic, then I imagine the response is higher. So have you tried with both of them or just with shock waves? I've done it. I always start with diamagnetic, and when my objective is to get more flexibility in the tissue, then I use that shockwave. But in the malformation of the veins and arteries, we treat it with CTU, and on the area that's more festered and that's thicker, then we put the shockwave on top of that, so you can get the infections out. Yes, another question, but it's not really about today, but I really want to, because I know it's about your studies. We saw fantastic results, and I saw many patients who improve in the pulmonary replies, but they still response, but they might still have some problems. So in the bronchial tree, but in the previous parts, so we get some better results. So have you worked on this area and do you see better results, or have you not? No, to be honest, I have no experience there, because we get patients who have chronic part, so we don't really think about rehabilitation. So we have this type of patients that in Spain you get them through the healthcare, and obviously the results that you have is what it is. So with pneumologists, we have to work with them, so we can study that, or maybe there's a clinic case, but experience as such, I'm afraid I do not have it. Any other questions from the audience? Yes, from Ecuador. Melissa Villavicencio says hello to Iria. And she has got a question. So she was asking about the sarcopenia associated to osteoporosis. So we are receiving many patients with osteoporosis. Well, the evidence, we say, if you want to have a clinical trial, then obviously that requires a lot of things. And so the evidence as such, no, we don't have it. But we have got evidence regarding magnetic stimulation in several tissues, in bones tissue, muscle tissue, and we are applying it. So we also have an ethical topic. If we get 20 patients and in all of them we do, in some of them the pump and in other ones not, then maybe this study is not so feasible from the ethical point of view. So it needs to be a study with what we have as a foundation and then applying and seeing the differences, but we're working on it. I can't really tell you any references for now. Okay, any other questions? But we're running out of time. Yes, time is ticking. Clock is ticking. Right, let's have lunch then.
Empecemos. Hola de nuevo. ¿Qué tal?
Hello everyone, how are you? I hope you regained your strength in this little break. I hope you enjoyed your lunch. In order to get ready to the next block that we have, we are getting to the end of these second sessions of the diamagnetic therapy. This block now is called New Insights on the Future of Diamagnetic Technology. And the next person who's going to talk is the multifunctional physiotherapy and diamagnetic therapy. She is Roberta Cagnetta. Thank you, everyone. Good afternoon, everyone. And I know it's a bit complicated to speak right after lunch, so I'll try to be short and I hope I won't bore you. Thank you so much for inviting me. I'm a physiotherapist and I've been using diamagnetic therapy for 8 years now. And I chose to speak about the multifunctional physiotherapy. But I could have chosen many other topics because you have already seen the results in these days. The results of the diamagnetic therapy are many of them and in many fields of medicine. I'm also a professor in medical tools and I'm founder of Neurodevelopment. That's a methodology I'll explain afterwards. And in this method of rehabilitation, we use these type of therapies. They're more functional therapy. It's used and is known in South America and in Spain, but in Italy not so much. And this is why during the last few years I committed to speak about this type of therapy. So what is it? It is a branch of physiotherapy that wants to prevent, evaluate and do non-invasive treatments of all the dysfunctions of this system. So many times we don't know all of them, but there's many of them. So it also concerns endocrine, metabolic and vascular illnesses. So also obviously also for surgeries, plastic surgeries, different dermatological pathologies, scars, lymphatic and phlebologic pathologies. And this last sector of rehabilitation, that is functional, is part of the regenerative. So novel lympha is a method that we started applying through COVID. And it implies the use of techniques, manual techniques, physiotherapy for the treatment of the tegumentary system, the vascular system and the lymphatic system. So this is a picture where I use everything I've mentioned. Nowadays, the number of patients that go to the plastic surgeon and the aesthetic surgeon needs, the number of people is just rising, it's increasing. And there are more and more operations that are minimally invasive because clearly the patients nowadays want to go back to their normal lives. So these operations need a rehabilitation that's specific, rehabilitation of the tissue and of the movement. In the last years, I've worked quite a lot in the period post-surgery, more specifically in minimally-invasive interventions about liposuctions. These type of interventions It's an operation that in South America is very common. So our Italian doctors went to Italy, went to South America. They learned the techniques, but the problem was the rehabilitation. In the post-surgical period, because rehab requires timings, modalities. Yeah, so timings mainly that are very, very specific. So this is not very invasive. So you attack the grease, the fat in the areas, and it's aspired. The grease is aspired. We use a small tube, only 2-3 millimeters. So the scars will be very small. Everything is just very little invasive, and the results are very good. So you can see here our patient. She is a doctor, and she came to my office a month afterwards because she didn't respect the surgeon's indications. The surgeon said to the patient that she had to go to physiotherapy, but because of COVID and work issues, then she delayed the beginning of this therapy. So then she came to my clinic, and you can see the fibers she has in her abdomen. The bruise is you can appreciate also the bruise, and even here this is smaller, but it was bigger when she arrived. The patient was not happy with the result. So a fibrosis was created. This fibrosis is a natural process after a trauma, which is happening after an operation. So what worries us is the excess of fibrosis. So now we know that it is possible to prevent or reduce the formation of fibrosis, or at least prevent the excess of it. And then we can see how you can treat these fibrosis. Therefore, this fibrosis, it's an excess of connective tissue. It's a stimulus of the growth TGFB1 that helps to produce collagen. What it hyperstimulates this growth factor are different factors. So swelling stress, mechanical stress, thermal stress, and genetic predisposition. Also, after this surgery, some things can trigger this fibrosis. So what we have is after a surgery like this one, it's very important to respect the phases where the physiotherapist doesn't see the patient. So we can see here this scheme. And when I was studying, I was told that it was very important for prevention to work on the proliferation phase. So from the third day after the surgery, and then remodelation from the 11th day to the 3rd month after the operation. So rehab, as you can see, is quite complex in Italy, but patients come after 15 days of the surgery, because the surgeon who was trained in South America understood the importance of the surgery, but didn't know how important it was to have this physiotherapy afterwards. So they would say to the patient after the surgeries, just stay at home, just have some rest, and after 1 or 2 weeks, then you go to the physiotherapist who is specialized in this. So I started to work with these cases, and they arose quite a lot after COVID, because many people use this plastic surgery because our rhythm was not the same as they used to be, and then many people also used to not eat well, so they would gain weight, and all of that led to this type of surgeries. So knowing the potentialities of the diamagnetic therapies, and I invited the surgeon to send the patients to me sooner. So after the third day, from the third day on, after the surgery. So we started this therapy with results that really were very good. So in the proliferative phase, so from the day 3 to the day 11, it's the physiotherapist has to work in order to prevent these fibrosis. So the swelling management, pain and edema management. We've been speaking about this for 2 days, and obviously what I'm going to speak about now is the diamagnetic pump. So I was working at this when there was no diathermia, because in this process it's very important to respect the temperature, so there won't be a fibrosis. We have done a draining work, and I use some cream that I created. It is a cream that has a great potential. So the protocol from the 3rd day until the 11th day, there was lymphatic drainage, and then there was a patient, for example, who came here after this surgery, and he had done an abdomen surgery, and as you can see, the patient had many bruises and he was hurting a lot, and he said, well, I'm here because the doctor told me that I should come here on the 5th day, but I don't know what you can do because it really hurts. So to gain his trust, I proposed to use this diamagnetic pump treatment. He said that it hurt less. So he said, while you are working, I feel less pressure. And I could say I even like it a little bit. So that was in the very first session. So it's very important to obtain the patient's trust. I am used to having this beautiful effect with the diamagnetic pump, but every time I'm still told I'm very happy and I really like it. I like to ask the patient how they're feeling. And when I see their smiles, it just makes me feel very happy, because they came to me in pain and they feel less pain now. So after the surgery, we start rehabilitation. In this case, I used diathermia, respecting the temperature at 37 degrees temperature, because radiofrequency in these 37 degrees has got a very positive effect, and using temperature higher than 40 degrees that could create fibrosis. So it is very important to respect this information. So I carried on with the treatment, associating some stimulation, endogenous stimulation. Here you can see the patient after 11 days of the surgery. So he went back to the doctor to see how he was doing, and this is the first patient that I treated respecting the guidelines, and the surgeon called me, Roberta, you performed a miracle. And I said, no, it's not magic. is just called diamagnetic therapy, and that is the truth. I have only been working with a technology that was respecting the person. Here, this is 3 months afterwards, so you can see the changes. The first one, 5 days after the surgery, and the other one, 3 months. No fibrosis at all, no pain, and with all the functionalities. So I don't have to say even that in all these patients, apart from sleep alteration, the joints alteration, there's low back pain, and they use supports. So these supports, sometimes they limit the patient's movement. Many times I find also problems in their respiratory systems, and I've got a holistic vision, and I work accordingly to this vision that I have, and I get these results. And I feel satisfied with my results. This is a patient, like the one I was saying before, who arrived in my office very late, and the doctor who operated her said, like, maybe I have to operate you again. And with her, I used a different protocol, or I tried, and I used the protocol that was focused on fibrosis. So the patient had, she was feeling pain if the abdomen was hyperstimulated. So we started with both the diamagnetic therapy and shock waves. And before that, I started using radio frequency with 37 degrees to get rid of that fibrosis part. And then I completed with a diathermia process, because after getting rid of the fibrosis, there was also the tissue was damaged. In these cases, we don't do like lifting. And in many cases, the patients say that the volume was reduced, but the quality of the tissue, it's not better, it's just worse. So after that, we decided to work with a diamagnetic pump. You can see the result. The patient was very happy, so was the surgeon. So he continued sending me many patients. You can see all their clinic cases here. You can see here the phase prior to the surgery. Then the phase post the surgery after 10 days, and then 3 months afterwards. So it's a patient who didn't go to the beach because he was completely unsatisfied after his surgery with his shape, but it's clear how obviously health, it's a complete state of welfare. I want to finish with this picture because during COVID, just a bit before, I asked my boss if we could maybe buy another diamagnetic pump, and he looked at me funny, but I managed to make him understand that it's the first technology that we are using and that we can diversify one rehab work, and then I showed him that just one pump will be used for physiotherapy to regenerate, and the other one for the muscle and vertebral effect. And I was obviously right, he trusted me, and I hope I didn't bore you. I have tried to be very fast, and thank you so much for your attention. Thank you so much, Roberta Cañeta, for your intervention. All the applications of this diamagnetic therapy are very varied. Next speaker will give us also an insight about the application. So pelvic and urogenital pathologies is the Diamagnetotherapy a new possibility? So, Estefanía Torres, come on over, the floor is yours.
Good afternoon, everyone. I would like to thank Paris and Fisalde for inviting me to participate here to share my experience on pelvic and urogenital pathologies. I'm a urologist from Colombia, and my life really changed professionally and personally when I became a mother. So not just personally, but I also understood what it means to be a patient, and I understood what the pelvic floor is. So I understood that sometimes you normalize things and you do not say, but this is part of the process. So thanks to mechanotransduction, I understood what things we can do, because there's multiple things we can do with all these pathologies. So what is it all about? Well, when it comes to pelvic floor, we start having functional urology. Well, we've already seen many articles, and also we can start to see this as a rehab technique, because we have all these techniques and technologies where with low intensity, also with laser and PRP, with this we can have some effects which will help us improve to have a better quality in the tissues and everything related to the pelvic floor. So we're here, are we treating a symptom or are we treating a problem? So this is very important in the pelvic floor, because many of these pathologies, so often we resolve the symptom but not the root cause. So with these technologies can have a regenerative effect and disinflammation, and this can be a possibility to bring a cure with a regenerative treatment to many pathologies. So mechanotransduction in neurology brings us the opportunity for this to be an alternative and even a main treatment for those who do not want to end up with a surgery, or maybe they do not have the indications for a standard surgery, or they do not want to depend on a drug for the rest of their lives. So for mechanotransduction, we can learn that there is a big range of treatments when there's problems in the pelvic floor, like erectile dysfunction, as you can see here, and pain in the pelvic area also we can have. So we have also aesthetic urology to treat these areas. So all these we can have because the pelvic floor as such, it is the only fascia in our body which is hormonal sensitive, and there will be changes within our lives, especially in women, because there you adapt, and then there's going back. So if there is a change in this fascia, you will have all these consequences. So here we can adapt to mechanotransduction, and that's why we can treat all these with diamagnetic therapy, because this is covering all these effects of mechanotransduction with other techniques that we can also bring together with the radio frequency and shock waves. So with this we can promote the results, and we're going to focus not just on the pelvic floor, but we can also modulate the transmission of nociceptive and neuropathic pain signals, also stimulate fast and slow nerve fibers. So this is for incontinency, and here the fibers can tell us how this incontinence is, whether it is more neurological or if it comes from the lack of strength of the muscles. And also we can have some tendon stimulation, which is also part of the urinary incontinence. Movement, also chronic pelvic pain, and also we can have movement of liquids and stimulation of the cell membrane, plays a big role in erectile dysfunction. Also, we have muscle stimulation, where we've seen very good results. So diamagnetic therapy, together with radiofrequency and shock waves, this is a great blend to combine technologies to have the best for the patient. So honestly, I started with these pathologies: erectile dysfunction, urinary incontinence, and especially I've worked a lot with lasers and magnetic functional stimulation. So I just took the difficult cases, and this I did with shock waves and also with the pump. So we started with this. This is organic origin of erectile dysfunction. This is 80% of the cases. So we need to understand that erection is a neurovascular reflection that requires for an emotional and hormonal action. So here there is a relaxation of the muscle and of the mid section. So there is an increase of the oxygen. So there is a dilatation of a sinusoidal tubercular smooth muscle. So in this case, then there is more pressure, and then there is a successful erection. But when there is dysfunction, we'll see three big causes. We have this dysfunction. So in these cases, we may have vasoconstriction, thrombosis, and inflammation, and fibrosis. So it'll be like a vicious circle. And also, this is a cause, but also we can have an older age and diabetes having some fibrosis here. So it could become more stiff, more rigid. So we could also have some alterations. So all these technologies, we already have some evidence that the shock waves will be improving the endothelial dysfunction, because it will make it easier to have the dilatation. But also the shock waves help us for nervous regeneration. So this is a response of the endothelial area and also of the nerves here for the nitric oxide. So with radiofrequency on the skin, this creates an organization and an improvement of collagen, but with the compression here for the venous area not to escape. This is thanks to the collagenous substances. So it's also good to use radiofrequency. So now it is great to have these two machines for this pathology. So the diamagnetic pump, we've seen that this can arrange the collagenous tissue to have a better elasticity. So here we have some images of a healthy patient. This is a range. And if there's a dysfunction due to the age or the diabetes, there's a disorganization, and we lose here the compression. So there's a venous leak. So the shock waves will regulate the system and will grant the opportunity to the patients, those who have some neurological alteration and those who have diabetes. Normally they stop responding to oral drugs, so they need to be injected with drugs. So as the disease advances, normally they do not respond to the drugs, and probably they will end up in a prosthesis. But that's not the best case. So the best thing is to use all these technologies and this science to avoid this. So this can be an anti-aging science. So here it's great to use diamagnetic therapy with radiofrequency, and also combined with shock waves. So with this, we can have this angiogenesis for the long run, and in the short run, we can improve the production and the effect with the vasodilation. So the patients with the shock waves in the second session, they're already having a morning erection. So this is a proof that the device is working, because sometimes it can be a mental issue, but if you have a morning erection, then we are on the good track. So this helps the patients motivated to continue with the treatment. So I've worked with a few patients, but we're taking all the right steps and we're working out on some protocols. So obviously I'm not bringing you pictures here, of course, but I'm showing you here my protocols and the questionnaires. And it was a big challenge because this is a taboo topic, and the patients, sometimes they're really tough in the questionnaire, or they respond, "Oh no, I have no problems, doctor." And especially when they're more shy, they're speaking to me as a woman. So normally, erectile dysfunctions can be moderated in severe, moderate, or low. So if it's moderate to severe, they should do a Doppler echography. But this can also be very invasive. So what I'm doing is that if it's a moderate to severe situation, then we do the Doppler ecography before and after. And if we have a patient with a moderate dysfunction because of a venous leak, these are the results of the Doppler ecography. And if the leak, or if the venous escape, for this it has to be above 5, but here we had some 22 at the end of the erection. So probably this was a venous escape. So this patient had 6 sessions. And we've seen before, it's good to have 10 sessions or 15. So it's just similar to shock waves. You can have 6 to 12. So it will depend on the patients and the treatments. We'll need to see what will be the best protocol. Of course, we need to personalize protocols according to the needs of the patient. So this patient had these 6 treatments with shock waves and diamagnetic pump, and the improvement was amazing. Now he's not injecting any drugs. So now this is the results of after 3 months. But of course, we can have changes in the future again. So we need to see when we're going to do another Doppler ecography. So then the venous escape here will be smaller. The second patient had low dysfunction, and he didn't want to take drugs. He had been treated with traditional focalized shock waves with a little bit of improvement, but occasionally he would need drugs. So he was treated with the pump, and he said, "Hey, so this is totally different compared to the shock waves. This works really good." So I only did the pump, and he's not taking any drugs, and he's very happy. So the question is, the initial patient, he could improve because he had a moderate dysfunction, and I asked him 4 months after, and he said, "Well, so I'm scared. Sometimes I do not respond properly. Sometimes I do." And once he injected some drug because he was missing some confidence. But then I asked him, "So what happened?" And he said, "Well, with my wife I do not respond, but with my girlfriend I do." And I was like, "Well, so who are you injecting with?" "Well, just with my wife." "And with your boyfriend, with your girlfriend?" "No, not with my girlfriend." So there it works perfectly. So there possibly the cause was different. So it's really interesting, as I was saying. It's great to have a device with all the 3 things because of the shock waves and the pump and the radio frequency. With this, we can treat the 3 weaknesses that we have in the erectile dysfunction. So those patients that do not respond to the shock waves and bring it to the pump, or I go from the puncture shock waves, and we see how it evolves. So we can combine the technology. And for the bladder, the function for urination, this is complex. This is sensible area. So there's many things working at the same time. So normally we need to have, normally this is related to the sensitive part of the neurons, but often when there is a constant inflammation, bad habits, constipation, and exposition to caffeine and many other things, I don't want to limit people to consumption, but for example in Colombia we take so much coffee, and in the end I end up treating red wine or coffee here instead of the bladder. So these substances can irritate a lot, and then there is a mechanism of action here through nervous type C, and this is about inflammation, and this will create a hyperactive bladder. And also hypocontractile detrusor. When you operate a patient because of their bladder, because they cannot go to the toilet, some people do not realize after the operation, their brain doesn't know they've been operated. So they continue working against that. So those patients can be operated and they can urinate properly, but they can go to urinate like 20 times a day. So this has an impact on their life quality. And this is related to the C fiber with the inflammation that was left. So this is because of the hypocontractile detrusor, and this can be young people. So if you're so young, why do you get operated? So if you can avoid it with these devices or with other therapies, with other treatments, if we can do a better follow-up, if you can adjust it better, then we could do personalized medicine, but it's not always easy. And in the worst cases, they are operated, but then the bladder doesn't work anymore, and doesn't contract anymore, and there we don't have many treatments. And then of course we have urinary incontinence, we will see later. So here we have always mixed situations. There is bigger effort or pure urgency, frequency. And we always have habits, and our habits are related to different things. So the efforts always, there is some urgency because we have bad habits and we're exposed to some drugs or to some food. And even our position can alter our pelvic floor. We can have some dysfunctions of our pelvic floor. So that's why the bladders that do not improve, this is another pathology with the same symptoms as the ones we had before with incontinency, in terms of frequency, and this can impact our life quality. So for hypocontractile detrusor, what can we do? We cannot do much. Even the drugs can remove the little strength of the bladder. They may reduce their frequency, but they start having residues, so they do not urinate fully. So then they start to get chronic bladder pain, and they start thinking all the time, so where can I find a toilet? So what do we do to those patients? Well, you just need a catheter, and then you start also having a neuromodulation in the sacra or in the neurotibial posterior. But with this, we cannot improve 100%. And if we go into neuromodulation, like in the sacra, then this is a very invasive surgery. And you could do well, or you could do bad, or you could get many complications on surgery on the spine. So these patients need to be patient, and they could also have an intermittent catheter, which is not so good either. So neuromodulation, which is what we have right now with the tibial nerves or with the sacral nerve, this has proven that this mechanism of transduction on the pelvis floor will help us increase the capacity for the bladder, and this can inhibit the activities of the contraction, which we can link to explain when it's hyperactive. It is like a superfibrillation. So there's a constant contraction with symptoms, but they're not urinating completely. So then this leads to problems such as infections, pain, etc., and the urgency symptoms. So the best is not to have an activity constantly in the detrusor, but having a total evacuation and then total relaxation. So the electrical and magnetic exposure of the pelvic floor will build these responses with a total closure of the urethral sphincter. So with the diamagnetic treatment, with the tibial posterior nerve, this goes like the window, not to be so invasive, but this is too small. And then the effect, we can have an effect, but it's not as big. But here with the pump, we can increase the volume of stimulation up to 27 centimeters. And this is a bigger space. So if we get to the deep of the pelvic floor, we can have better results with the urinary symptoms. So this is the protocol. And I have a 47-year-old patient. I did I had an intervention with the patient, and he said, "Oh, so nobody wants to do a surgery here." But then he came back and said, "Hey, so I have no life. I cannot urinate properly." So in this uroflowmetry, this is an objective way of seeing how he can urinate, and we can say it's really bad. So normally it should go up to 20, and then have a Gauss curve. And then he had the operation, the surgery, and he achieved a Gauss shape, but only 20 millimeters. So normally it should be 300 or 400 millimeters, and he had 80 or 28, 25 sometimes, 25 times a day going to urinate, and 7 to 10 times during the night, so he could not sleep, but he was thankful because he could urinate after the surgery. So he was suggested to have the therapy, and then he managed to bring this down to 20 times during the day and 7 times in the night. So this was going to be his end, but then we treated him with the pump. So it was a very difficult case. And in the second case, after the second treatment, we had a frequency of 16 times a day. After 4 or 5 sessions, it was just 9 times a day, and he could sleep through the night. And now he's urinating 5 times a day and 1 to 0 times a night. So now he's saying, "Hey, now when I stop all the drugs, now I'm happy." So these are patients who are mentalized that they can have their symptoms, so they measure everything, they calculate when they urinate. So they have a urinating diary on their head. And then he told me very efficiently, so I wake up, and the first time I urinate, it used to be 80 cubic centimeters, and then as time goes by, then it goes bigger, and it can be up to 500. And after 4 months, he had urinations of up to 500 with no residues. So this is great, because in neurology, we had no treatment for this type of pathology. And I have another patient. He's 24 years old, and due to bad habits, because of a trauma he had when he was a kid, he has a very bad urination. It's not so often, but he feels he wants to urinate all the time. So he says this is limiting his life, and he prefers not to travel because he has to think constantly, where can I find a toilet? So he cannot go to public toilets. And after 16 sessions with a pump, now he's going to come to Spain as a tourist in 2 months. And urinary incontinency, this is mixed. So this is the protocol for effort and urgency, but I never had pure patients. I always do a mixed approach. And what I've seen is we have improvements in the women, especially with the irritation symptoms. So the pump has a lot of power with the neuromodulation and with the disinflammation. So if we eliminate the inflammation, then we're going to sort of reset the whole system, and then they start from a new baseline. And obviously, I was also very surprised because the magnetic stimulation, there is a pure contraction of the muscles of the pelvic floor. There you can feel it. But they feel comfortable during the treatment, and they had great results. So this patient, and this was a PADS test, he was doing an exercise and weighting the towel to see how wet it was. So at the beginning it was at 4 grams, and now it's totally dry with this exercise. But she had not realized that she was urinating very bad, and the frequency was very high. And now she has no symptoms at all for the urgency and for the effort, and she's very happy with the results. So these are the patients I worked with incontinency, and I can see that as a result from the questionnaires, we have very good responses in these type of patients. So I have no statistics significance yet, but I think we're on the right track. So now what happens with the pelvic pain, postpartum, and hypertonous pelvic floor, chronic pelvic pain, and dyspareunia? Also, we did very well here. This patient, 1.5 years ago, she had a cesarean, and she had complications. And since then, she could not have a penetration. It was a big pain, she was depressed. So she was always like in a bad mood when she came to our clinic. So it's normally always very difficult cases, and I understand, I know why they're in a bad mood, I know why they're depressed. So she was telling me she was gonna get married, but she didn't get married because she was terrified because of the honeymoon, because she didn't want to have sex. So I sent her to therapy with a pelvic floor, and the therapist sent her back to me. She told me, well, I think this is a problem, this is a psychological issue. So of course, we're body, mind and soul. So we need to work on also mental things, on mental health. But she helped me, and I made her understand that we need to have patience, and she needs to be patient at all, and not work against the world. So we started working with the pump, and after 6 sessions, we managed to have an EVA of 0 of permanent pain, and 1 EVA1 with sex, and then she got married, and luckily this already happens with 2 of my patients, and they come to me and say, hey doctor, when I'm in that moment, I always think of you when I'm in bed, when I come to the very point in sex. So it's very fulfilling to me, of course, as a urologist. So eliminating a kidney and operating, this is also always good if it's successful, but helping for the sex life of a person, this is also great, very fulfilling. So this was my experience, but obviously this sounds like we're mixing pears with apples. We can sort of comparing these. So these results we cannot extrapolate to the general population, but this is a good start. This is a good pathway. This will be the future of functional urology. And so these are some satisfaction questionnaires, and all the patients are very happy with the treatments, and we're avoiding surgery and having them depending on drugs. So yeah, I really want to share our science with you, so you can see that we can combine technologies. We cannot just use one single thing, and it is so great that Pariso and Fisaudi are starting to combine technologies here in one single team to have the best benefits for the patients. So the adverse effects, this could be because we're increasing vascularity, and this also happens with magnetic stimulation, so we can improve the blood flow. So I have 2 cases of metrorragious situation, increasing the period, but it's not a severe effect, but it is an effect that can happen, for example. So for the future, we're just learning and growing. So the best protocol, it will depend on the patient. Some patients say, so doctor, this is no urgency, or this is urgency, so then I can focus more on the effort, or if the pain is here or there. So we need to see if it's a neuroceptive case, or what it's like, to see what we can do. So you need to evolve and see how the patient evolves, and then you can change the protocols. So there's no one size fits all. So that we need to do personalized medicine, we need to individualize treatments, and we need to do more studies in the future, maybe sham as we grow with our cases. And of course, we really need to combine technologies to be stronger. Thank you so much. Thank you.
Muchas gracias. Gracias.
Thank you so much, Estefanía Torres, for your intervention. It was absolutely wonderful. It was very interesting and hopeful, I have to say. For men, but also for women. Okay, well, we're heading towards the end. We only have one more speaker. And this last one is a new vision about diamagnetic therapy in sport injuries. So, Orlando Angulo, please come over because we have the last speaker with us. Hello, how are you? I'm the last one then. Okay. Orlando Angulo, I'm a doctor. I'm federated in Colombia, that's where I'm from. But I also trained as research in Canada, in Montreal. And then I started working in the sports in Bogota. And then, well, I headed towards an HIV in Rey Juan Carlos, and I am applying for PhD. I'll try to be fast because I know this is over already. Right, so this is, I'm going to speak about this in a way, the same way my mind works. So Felipe already knows about it. First of all, thank you so much, Paris Academy. Thank you, Felipe. My wife, Karen, who was the one that got me involved little by little here. Every day that I apply this more and more in my patients, well, I fall more in love with it. So, well, I work in University of Colombia, and thank you because they made it possible that I am here. So, let's get started. What are sports injuries? Well, the name already says it itself. So it's the injuries we can see in the sports people, in athletes. But sports injury can happen to anyone who is physically active. And we all do physical activity because we move our muscles that, or at least of the people who rise their metabolic activities. So, for example, it could be with if I'm a receptionist, I can have a tendinitis, even if they do or not any sports. So I want to always emphasize on this, and I am telling you, exercise is for health. Sport is not necessarily for health. Sport is because you like it, because you enjoy it, you have fun, it reduces your stress, but it is sport. Your physiology, it goes to the extreme. So there are risks of injuries, and if you don't do things properly, you can have some illnesses. So it is important to know this, to know if I'm eligible to do sports or not. If I have these hidden illnesses. And here we have the acute illnesses that appear all of a sudden, and the one that are chronic that appear when there is an excessive use. So there are some injuries that I've never seen them in any text. I call them because of the lack of use, and it's these patients who are sedentary, or for example who are obese, and I say that a hippie's picture will have more energy than them, and that's horrible because we all need to move because that's good for our health. So more than 90% of the obese or overweighted patients have got a hidden injury. And from this, most of them, they have, for example, tendinitis. And that, when they have that, it is painful. But then they leave. For example, I've got a friend who started running. But he didn't know anything, he didn't take any measures, he wasn't careful. But if I had gone and if I had seen the problem before with the diamagnetic pump, there would be a lesser risk. So who can suffer these injuries? Well, any person, but because there's always a risk. If you do any exercise, you are at risk. There's some concepts that we speak in high performance sports, and where there are microcycles, macrocycles. Sometimes the coaches have to do these fluctuations to work certain biophysical characteristics in order to go to championship or whatever. So in these moments, the exercises change, and there could be a higher risk of injuries, even more if we didn't take the accurate measures. So sports doctors can control your load sport in blood. And are we all doing it? Well, the truth is that we aren't. And even more in the high performance sports or athletes. Other risks we can find, it's bad shoes, or not using them properly, or a high biometric component exercises like jumping, for example, and other, for example, use of antibiotics that could affect this as well. What type of injuries? Well, fractures, luxations, tendinitis, bursitis, sprains. The ones you see here are the most common ones, so we can see. We're going to speak about where I will present, which are two types of shoulder injuries, because they are very common, because we can injure the rotator or the golfer elbow, tennis player elbow, and tendinitis in the Achilles heel. So what do these injuries have in common? Well, there's pain, there's edema, there's swelling, and something that we don't think that is dysfunction. This is biomechanic dysfunction, because many times the first thing we see before feeling the pain or swelling, but we don't pay much attention to it, and in medical schools they don't really speak about it either, or at least not that much as they should. So they have got other things in common as well. And as you can see, is important in this diamagnetic pump. Let's see the video. So you can see how an injury can produce a mechanic dysfunction, but there are people who already have it without feeling the pain or having swelling, because they are already injured. Many of these people, most of it in football, they keep it quiet so they can still play, and they won't be sitting on the bench. And I always say that, but I'm a sports doctor, so but we have to kind of conquer those athletes so they can trust you. They have to know that they'll still be playing, but obviously I won't lie for them. But they must understand that the risks of the future life as a sports people. But I did have some cases that I saw cases in which there was a person who was not one of the main players anymore, and he had a lymphoma, and he was sent to his hometown, and the coach didn't want him anymore. He was a fantastic number 9, so it does make sense that they're scared of this. Well, biological effects, we have spoken about it. So when Karen started talking about this, Felipe as well, they told me, what is this? This is a bit weird, isn't it? So, but they were never skeptical, they were always happy to listen to me. So there is a paper that it was written by Pietro and Felipe, that about, if you want to talk about this, you need to read it, because I did that I read it and I was like, oh my God, what is this about? But they don't know what they're talking about. And that's what I thought, like they don't know what this is. Because as a doctor, for me as a sports doctor, I'm working with the bones, with the muscles. My duty is I need to take care of the athletes, but any person who would like to be active and have a healthy lifestyle. But not just that, is I need to accompany them in this interdisciplinary management regarding what I know. The best friend of your body is your muscles. I have patients who have sarcopenicas, who had, for example, kidney failure from 4 to 5, and we did everything. We did the exercise, proteins, management, creatine, but they never got to dialysis. They're stable, but because of their muscles, because their filtration improved thanks to the mass, so the muscle mass. So my duty is to help my colleagues help take care of the patients. So this was what I say to my students as well. I always tell them, the patients are not yours. You belong to the patient. And that's very different. Whenever we see that, that's going to be better for all of us as a society and as doctors. But it is difficult. So Felipe was talking about this, Karen speaking about this, so I started reading this and I was like, this is just amazing. I need to get to every system, to every organ, and kind of manipulate, regulate, searching for a target. As I said, I brought everything prepared as my brain works. Well, here I've got some clinic evidence. Felipe showed this already, and it's a study about fish where they wanted to see the regenerative effect, and they showed this comparing it as putting this PMF or not putting it. So 32 minutes there was already an answer, but nothing compared to the 64. Even better, with these colors you can see the difference between one and the other one. And I was like, this is working, because in the preclinic that's the starting point. And I like to see it this way. You can have evidence in the green part how there was regeneration versus the other one. But the other one also did, but obviously the zebrafish has this characteristic of the regeneration, but it is what we spoke about it the other day. We wanted to reach the potential. And if I am the best friend of the muscle, then for my muscle this is my best friend. So yes, our regeneration and need to improved the length as well as the area. So it was as it should be. This is from Chile, Hong Kong, and it was very interesting. 72 rats, and they reproduced an injury in the menisci. And they took this distribution, the control group, and they had the PMF, and the other one, the one you use. So this is how it was reproduced in the rats. They use protocols that are the protocols to show the vascular area, and that's where they cut the 2 millimeters. And on top of it, you can see 2 full 8 weeks. You can see the area of the injury that was reproduced. And in the second one, we have the intervention through PMF, that's classical. than the one of high intensity. So as you can see, both in the classic one as well as in the high intensity, from the 4th week it had already regenerated compared to the control group. So for the 8th week, look at that at the bottom right, how it was completely regenerated. This is the vasculature of the meniscal compared to the ones on top. And this has a great potential. So I'm not saying we have to redo the surgery, but it could be an option. Apart from it, we've got Serafín and then collagenotip type 2. As you can see, the score of reparation of the meniscus was way above in the high intensity intervention versus control. So it was as well in the LA1. The difference is quite big, if you see it. In other study, with patients, we studied low back pain. There's low back pain as a symptom, and this is one of the main reasons we see. And this is also for athletes. So we saw 2 groups of 25 people where in one part we did traditional physiotherapy with the simulations, that's normal. They put the apparatus but no intervention. And the other one, traditional plus PMF. I liked this because I'm no friend of absolutisms, but of integrities. And as we expected, there was an improvement in who combined PMF in terms of pain, disability, and ROM, ranges of mobility. In this study, that is I talked about it with Felipe, they wanted to see how it was affecting the shockwave therapy versus physiotherapy in a tendinopathy of the shoulder. So the same way they could bear in mind this quality, functionality, with the great improvement in the protocols they use with shock waves. So you could see that it was much better in the international groups. It did work, but it was better whenever they were doing it integratedly. And here we have an article where we did PMF, but they also got exercises involved for patients. So there is the PMF and then the placebo. 3 weeks later, they saw pain regarding the shoulder and with UCLA, but also escalating in the pain. On the 9th group, in the 9th week, they both started exercises to strengthen the shoulder, and in the 3rd one, they would complete. In 3 months, they would complete the study. In all the markers, there was an advantage since before the exercise in what had to do with this PMF. Same thing here. You can see it. It's a way of measuring what the shoulder was like afterwards, as well as the pain. So this is a case that we received that Karen managed, and it was the daughter of one of her friends. She had an injury in her left foot. She had the x-ray done, and the mum, she was also a doctor, she wasn't very happy in the way it was managed. So they brought it to Karen, and we applied the protocol you see here. This was on Wednesday. So Wednesday, Thursday, Friday, she rested Saturday and Sunday, and Monday and Tuesday we could see here the intervention. We started with obviously all the precaution you need to have when you're working with children, of course. You can tell she's happy, she was having fun. So Tuesday she was competing and she won her bronze medal. So the mom took her because the girl wanted to compete, obviously, and she wanted to do well. So those are goals, obviously, when you do sports. The way I see it, I always try to think about the prevention part. And I spoke about some aspects of participation to prevent injuries, but there are two crucial things. First is the physical condition and the muscles. And that's why I was saying before, the exercise for health, but not sport. Every athlete needs to do sport, of course, to prevent injuries and improve their performance. But there are still some sports, like football, where the coaches says, no, do not lift any weights because that's going to make you be slower. Well, that could be, but then they're going to be more powerful. So why are they going to be slow? So this is what an athlete in football teams. There was one football team asking me, and in this team, there was a Colombian football team. They had a fantastic gym there in situ. They are from Brasilia, from British, and they all used the gyms. But in Colombia, they wouldn't. Because they would get slow, they would be slow. But obviously we need to think about science and evidence. So these are athletes who need to work on the resistance, who want to do a microcycle in the heights. And they applied what they had planned is the different distances day by day. And some groups, 8 of them, they were 14 in total, so some of them, they applied PMF before and after. For the surprise, it's a sport that had aerobics. So they didn't show that they did this conditioning. They just did what they had planned. They're sports. So even if we didn't find the other things, there were some improvements in the peaks and when in their respiratory threshold. So the curve went to the right, we could say. So there was some mitochondrial function and the curve went to the right. So the conditioning was better and also at expense. And that's the difference from the control group, who didn't have that. So we can understand that complete adaptation in heights, and that's where we can find the mistake of this coach. The adaptation to heights, that takes 4 months. So the first 2 weeks you lose conditioning, but not afterwards. So what I'm saying is not even there. So analyze the results you can see, because you need to understand them. 4 months it takes. In 2 of them, they lose their conditions. So in here, it didn't happen. So this is wonderful in terms of injury prevention. Another important thing that I always like to speak about regarding prevention is the part of anti-aging. And this, we don't really bear this in mind, because you see on your left, on the left, on every right, the effects of aging. So it's a physiological drop. The important thing about this is that on the right, exercise, if it's well done, can counterbalance all of this. So I presented this in a conference, but when I got to know this diamagnetic, I started seeing this part here, and I said, if these are the anti-aging effects and these are the benefits of exercise, look at the potential synergy I have with PMF in order to improve this. And not just this performance, it's also to lower the temptation of consuming these doping substances because they're working in high performance. So a high performer athletes can only improve himself in already 5% because they are to their maximums. So it's just going to be 1-2%. Is Roger Federer going to win, or is it Rafa Nadal going to win? So it's just 1-2% that different. So if someone is an amateur, for example, it's cycling and they want to win a championship or something, then which one of all of those ones is the most important one? Not all of them. No, you can't. So as an athlete to the 100%, they can only get there in 7 days. Being to their 80% is already fantastic. So some of them do better in the Giro and some of them in the Tour de France. So because that's what they need to do, the competences. But here, I see a huge potential to avoid the temptation of doping usage. And I recover that. So even the urologist spoke about this because there's something that's called overreaching, which is the preamble to overtraining. And this overtraining is a fragile aspect of an athlete, and then it takes 6 months to go back. So this is why many of them come to doping substances, because even their families depend on them. They've got a commitment, they've got debts, and they won't have their car anymore. Their children are going to get kicked out of school. So this is happening, this is a reality. So in Diamagnetics, this is it. I saw all of this, I went to all of this, and I saw this. From the muscle, I can, we will all get old. That's going to affect all of us. No one's escaping that. But we all deserve to get old with dignity. And for me, it's important to have a good physical condition, regardless. I don't want to be a burden for my children or for my wife. My son asked me, why do you do exercise? Because I do exercise every day. And it was during the pandemic, so I did exercise at home, whatever I could do at home. And I thought, my son Lorenzo is going to be just to get strong and all that. But he said to take care of yourself. And I was shocked. I was even touched by that. This is why I wanted also to have a better muscle mass. Because that's my future. In 20 years old, I'm going to need to help him. So, is the physical condition. So this anti-aging is very important from the muscle with all these options to help all the colleagues and using this technology, because then I can have different ways and take and continue with my pension. So I need to find the protocol and publish it, and that's what I invite you to do. Then I publish things all the time. I've got so many reports, and we have to do it. We have to show this. We also spoke about epigenetic alterations in sports-related injuries. You all know the concept of epigenetic, the changes, ventilation, etc. These have some positive things and negative things, and this is why we want to show the preventive part. In the table 1, all of these are the epigenetic changes that are good, coming from a good shape. And all of these micro-ARN in epigenetics that I get if I have a good physical condition. However, there are other ones that if I get injured, in this case, is tendinopathies and injuries in the bones. What we manage in our muscles is we can have a risk because we'll have a next one, yeah? That's what we used to be told. But here's one of the reasons. If I have a tendinopathy or an injury in my bones, then these are the micro-ARNs that will be already there. Are you going to see them? But do not forget that we've got some of them that counterbalance them. So we need to choose which ones we want to be in. So even the more reason that in a tendinopathy, I've got the option of putting all of this and going back. It's not secret, the secret tone we have in our muscles. So we have to do it with resistance training. So we know that there are big dialogues from the muscle with the rest of the body. This is why I said the best friend of your body is your muscle. That's it. Because it's related to our bones, liver, blood vessels, cognitive functions. All of this is important. And when I have collaborations and investigations trying to find certain pathologies, either prevalence or factors, if they're chronic, I'd ask them, are you going to measure the physical condition? Because that's a risk factor. Or depression as well. We know that's a factor as well, so it is important to measure all of this as well as physical condition. It's not always possible to measure it direct or in an indirect way, but nowadays there are some formulas with a great focus on what's a direct option. And we can measure it, but it is important to have this relationship because the physical condition depends on the muscle and the muscle is related to all of this. So every time is more and more important to bear this in mind from the practical clinic. And these 2 days we have seen so many capacities for the instrument in order to improve the muscle, and they can go back to all of this. So that's why I asked, that was my question. So should they go to a preventive consultation and use this diamagnetic therapy? My opinion is yes, because there is a great potential here. Everything that we've been speaking about, and with my wife we've been showing it more, but in getting the doctor involved in the sports. And this inspired me to publish this. And an editorial contacted me and I said, Karim, let's write this, let's publish this. And this is where we showed the experiences up to the very moment of how the medicine can help sports and it can help all of you in your clinic. So from preparing respiratory volumes, less consumption of drugs, from the recovery after surgery, of the tissues, the intervention in an interdisciplinary way, because that's also, it's an interdisciplinary work. So I published this and we received rewards in Canada, and they actually liked this because we were speaking about a football team, a basketball team, and we could see the other part. But what is forgotten as well is either you're an athlete or not, but speaking about sports, is the human welfare. It's physical, biological, spiritual. So it's the 3 aspects. I'm not going to speak about religion, but I'm going to say spirituality. You need to have some spirituality. You need to have this. And this is also like your sport, where you have so many passions, and do not get lost by your passions. And at the end, a performance for an athlete is mind, body, and soul. This is what I had to tell you today. Thank you very much. Thank you so much. Thank you, Orlando Angulo. I'm an athlete, so I was really interested by what you said. Well, so we are done with all the presentations. I guess you have questions, you would like to go deeper in your knowledge, and I guess this is even more for you. So we've got a last opportunity to ask these speakers, and we will have this debate led by Felipe Torres. So now you can ask all the questions. So once again, we have here Roberto Cagnetta, Stephanie Duque, Orlando Angulo, and the moderator will be Felipe Torres. Thank you.
All right, so now let's have 90 minutes time for Q&A. No, I'm just joking because I don't want to make it too tired. So we're finishing this conference in the best way possible, analyzing in a beautiful way, seeing how we can enjoy these sessions. So let's start with some questions from the audience. Hi, I have a question for Dr. Stephanie. For chronic pelvic pain, what protocol do you use with the diamagnetic pump, and how long does it take to see the results? Well, we need to analyze the intensity, so most of the times it will be chronic, but what we use is a neuropathic and nociceptive. So we would use a high, other neuropathic, either M or H, so it will be a high level, depending on the intensity, and there we will focus a lot on that, 5 to 10 minutes, and then we can work on vascular, muscular, cell membrane, and there we can see how it can relax. So I check on the second session to see how, I've also learned a lot with Felipe, with Dr. Torres, because probably in the first session there's not so much improvement, but after the second session we start to see changes. If there's no changes, then we need to change the protocol. So we always need to do a follow-up, and then in the third session we need to change, definitely. Prolapse grade 1. And do you have any cases? Well, for prolapse grade 1, there is no symptoms. This is something visual that we can find. But we need to prevent there. So if it's moderate level, grade 1 or asymptomatic, we need to analyze the postures, life quality, lifestyle, so they can learn. And that's where we start working with mechanotransduction. So with the pump, so far, I didn't have any experience with prolapse, but it was magnetic laser and radiofrequency. So with all this together, we could improve the tissues, collagen and prolapso. So if it's a grade 2 symptomatics, then there, it's difficult to get tandem which elongated. That is difficult to recover without surgery, and sometimes we need to work with science. So grade 3 will become grade 4, so it's best to act as soon as possible before it goes into grade 4. Thank you. Any more questions? Yeah, here. For Dr. Estefanía and Dr. Roberta. So can you share why you place the devices for urology, for the pelvic floor, and for fibrosis, in the case of Roberta? Where do you place the RF? And because also you have the temperature control. So how do you do for the person not to feel the 37 degrees as too hot? Thank you. Right, so for pelvic pain, the best thing is to work with a pump just directly on the area with radiofrequency. We place the laterally, so depending on where it is, then we'll place it frontally. Also go down to the maybe to the point or trigger point. But if it was just the contrary, if it was like a posterior contracture, then I would maybe change the position. But for now, what I do is normally related. If it's after giving birth and pain at the front, then I work it like that. And most of the times I'm using radiofrequency because most of the ones I'm working with, it's chronicle. So normally, sometimes it's up to 5. So sometimes it's 3 or 2. So I work with 3 or 4 or 5 in radio frequency. I think I understood the question because the Spanish is quite similar to Italian. So I'll try to respond. When I treat a fibrosis, I use radio frequency, and I get to 37 degrees, and then I analyze the temperature with a laser thermometer. And when it gets to 37 degrees in fibrosis, then I stay there for a couple of minutes. And they can reach 40 degrees. If it gets to 40 degrees, then I reduce the magnetic density. And I stay there for some minutes, trying to cover the area which will be the double of the diameter of the electrode. Dr. Duque, for the patients you've been treating, we need to also think in the mid and long term, and also with the oldest patient, or the patient you've been treating more. Is there any relapse? Did you do any control on the patients to see if they need a continued treatment? Or maybe after 6 months or after 12 months? Well, when it comes to mechanotransduction, so in this case, obviously, we have the American Neurology Association giving us a lot of information, and the laser is becoming quite popular. So normally you say, well, it's 3 sessions as a global thing, and then they can focus on Diamagnetic. So then normally you do 3 sessions, and normally you need to do a retouch after 1 year of retreatment. So right now, in the last bulletin, there was a study published explaining lasers, CO2 laser with all the symptoms, and this still changes 24 months after. So that is to be discovered. This we do not know as of today, this mechanotransduction. So this is a technology which is a disruptive technology, and we'll be learning a lot there. And second, the shock waves, the patients here, erectile dysfunction. We need to repeat the sessions after 6 months, after 1 year. And we've been saying that this is also related to PRP injections. So we'll need to see in the future also with exosomes to see if we can promote the results of the shock waves to have longer lasting effects. So this has been proven that PRP can postpone the retreatment to up to 1 year. So for patients who doesn't want to take drugs or cannot take drugs, for example, with diabetes, they may not respond to these treatments. So this is a very new thing, and this helps them regain control of their life, and also to be spontaneous again. So this is really important for the lives of the people. So we'll see how often we'll be doing these treatments. Whereas with the pump, especially the patient, he said he needs to be injected only with his wife, but not with his girlfriend. So it depends how you deal with your personal life. So I'd like to congratulate the speakers of the last panel. Also to the speakers of the rest of the panel, I see that the knowledge shared and the experience here was amazing. So my question is for Felipe, because I didn't have time to ask you before. So first, I personally thanked Engineer Lagata for the creation of these machines. And I also want to thank Torizo, Felipe, and Fisaude, and everyone participating here with this technology, because most important, I also said this yesterday to Lagata, with this we bring hope to people. And you guys have created the technology, but also we have the whole team who now believe in the technology to help the patients. So we need to be very thankful for that, because this can be very useful for patients who had no treatment before. And now we see that it's hope for that, especially now also with the neuro treatments. So the question I would like to ask you is, well, maybe in the body, we need to give the option to the body to cure itself and to regenerate it alone with the anti-inflammatory processes alone. So I don't know if you have some data or a personal opinion, because also in the paper by Karen, we were asking, so where is the limit with the omega-20? Because we can see that we can treat maybe not everything, but almost everything. So where is the limit? So maybe you've seen with patients you've been treating for longer, in the future, at a metabolic, hormonal level, etc., will we see a difference in the own capacity of the body for regeneration? Because normally there's many things that the body should do alone if it's working properly. I don't know if you understand what I mean. Yeah, sure, I understand. So we now have a clear response. For now, we are not muting people. There's no mutation. We're not building superheroes. We would love to, but we're not building superheroes. I have some colleagues who do this doctorate with me in Germany, and they were saying, we're going to bring our patients up to 200 years old. At that point, it will be a mutation, because genetically we've been built to last for 125 years. So everything around us will bring us to how in the situations we are living. So we have a first phase until the age of 28. We should be the same from 30 to 60 years old. But now we can see that some people are different when they are 50-something or 70, or some people would look younger, and some people are 30 and they look very old, you know? So this very much depends on the body, and then we can modify, then we were 80, 90, 100. So it's quite natural and normal to have this therapy to help us improve the situation of our pathology and not alter the rest of the body. So here, as Orlando explained, we're improving our condition. That can help us if we require something. So if we use the technology, maybe in a muscle, and if we do not know an exercise and we expect for this to be stronger, this is not going to happen. We're not going to be the best athlete. But if Orlando stimulates his muscle, then his muscle may respond because it is stimulating. So it's the same example if we have a child with cognitive problems and a genius, and we place both in a room, a white room, and we only give him some food and bring him to the restroom, no communication, no television. And the kid with the cognitive problem, we stimulate him for 5 years. Then when they come out, the genius child will have a delay because he had no stimulation. So this leads to a change of life. So when you're sick, this leads you to changing. And when you improve something, you can notice the difference. And after, once you no longer have a pain, then you don't want to have the pain again. So this is always a subjective concept, a multidimensional concept. So if I break the arm of a little girl who is 7 years old, she'll be crying until she gets to the emergency room. But if I break the arm of an elite guy in the army, in the guerrilla, then he'll just come to the hospital with pain. So it's a cognitive phase. So it's the same thing we have here. So you can change your concept. So if you had a malfunction or dysfunction, and if the doctor says, well, stop drinking coffee, then it will depend who you want to have sex with. You'll need to see that, if it's with a girlfriend or with a wife. But, well, this is an example of one of her patients. So yeah, that's also important. I have 3 questions for each of you. First, Orlando, often after exercise with any regeneration, the process of having a sort of doping to alter the patient or the sports person, if you're doing something additional that you shouldn't, what do you think about this concept? Well, with doping, this we need to extrapolate to the general population. So once I was the Canadian Academy of Sports, and I explained an example of a top athlete with a change of hormones, and I applied, we were using testosterone. I asked, and they were saying, some were saying yes, and some were saying no, you're crazy. And I was like, well, he's not just a sports person, he's also a human being. So this controversy, I do not recommend doping in general terms, but if there's a good improvement, then yes. But I want to avoid temptation of doping because it helps us recover, has a big potential. So also we can see when we can have overtraining and overreaching. So we cannot bring doping to the general population, and you can have it for professional athletes, and there is an anti-doping agency. And also in Colombia we have a law regulating this, because in the past it was not so very well regulated. And also here they're very strict in sports. So this we should not use with everyone, because even anti-influenza drugs are doping. So sometimes people go and get drugs over the counter and just take it against influenza. And some sports professional teams in Colombia, maybe they took some of these, or they took some fat burners or so, and they were positive in doping. So that's a big problem, and the doctor of the team will go to prison. And now for neurology, no doping there, but there is an interesting study in the American Society of Transcranial Stimulation about erectile dysfunction of a psychological type, showing an interesting capacity of response with the transcranial stimulation. So do you think that in those patients who do not respond, if it's a psychological, if they have a psychological issue with the wife and the girlfriend, do you think that we could sort of have a restitution of functionality? Well, I already use it with a functional magnetical stimulation, which for me that's the exercise. So if you improve the pelvic floor and the muscles and the blood flow, so I tell them, hey, so I think you have something which is more psychological, even though it's always a multifactorial. And this is something new, so now we can see that some patients are young, maybe 28 years old, 30, 35. They may have some or a certain organic dysfunction, which can be the beginning of everything. So all these technologies can help a lot. We do an early diagnosis of this with early patients, compared to waiting for them to be older. And the findings so far in a big study in China that they're doing in young people, because they go to the doctors, because all people are not going to the doctors for this. So now these populations who are 30, 35 years old, and it's been detected that they're doing just something and not just talking, and this just helps. We don't know if it's a placebo effect or if it's a real effect, but they're improving. Maybe it's also something organic, but it's not so easy to know if it's 100% a psychological cause but it is working. So if it works with it, it should also work with the magnetic stimulation. Great, thank you. And finally, Dr. Roberta, in Colombia, there's also have plastic surgery, quite a lot. So there we see not just fibrosis, but often in liposuction or in lipomarking, the skin is too loose, quite a lot. So often the people may be thin, but their skin is too loose. Have you worked on this with the diamagnetic pump? Do you see any results? Well, you might also after liposuction, if we see any difference here in terms of the skin, well, yes, because in these type of interventions, as you all know, especially there, we're eliminating the layers of the deepest fat or deep fat, so the hypodermal changes. And the goal there in the surgery is to eliminate not just the fat tissue, but also having the muscle to be visible. So working there with a protocol on those people to gain better muscle tone, that's important. So with this, you can also improve the quality of the muscle so that it can be more visible thanks to the reduction of that layer. Great, so yeah, these three areas are really moving the world now. We have, one is a hidden area, but it's so important. This is a sex dysfunction, urinary dysfunction, and people is often quite a taboo. You see that a lot. Also, we have life quality with sports and exercise, but how do we do it? You're gonna just go there and do so much pain, do so much exercise, and then have a big pain. And obviously also the aesthetic part and the effective results, that there is no lesions and that they can recover quickly. So I want to thank you for this table. Thank you so much. We're only 12 minutes after the time. So thank you so much.
Quiero invitar a Antonio.
So now I would like to encourage Antonio Santoli and Pietro Romeo. And I want to invite you, Jose, to come to the stage. It's been very interesting. And something I've learned here in the conference with the talks on diamagnetic therapy is that nobody knows everything. The world is gigantic, so we're up in a very beautiful world. It's great to see the team we're working with in different situations with physiotherapy, dermatology, surgery, with all our experts, seeing all the support that we have, and so that we can see what you guys do every day. So really, there was so much work behind this conference with Periso and Fisaude. So it's been a great work so that we can achieve all this. And every slide, we had to adjust all the slides to the screen. Now I understand that we have this special screen. So this was all for you guys so that we can be a big family. So Pietro will tell you something that we did yesterday, but I think this is good for everyone. We need to do more research. And of course the diamagnetic miracle exists, but only with a scientific basis. So our Periso Academy, if there is something where it's not authorized, you can ask us anytime. So these conferences are really good to have a guideline and to know to what extent we can do things, so what the limits are and what we can do with patients. Or if there's some problem in the eye, shall we work on that with the diamagnetic pump or not? Well, if it's safe, then maybe you can just do a nice surgery. It depends. We need to analyze on case by case. So we need to always see the context, but this will also always help us. So we need to continue doing things. So thank you so much. I'm very proud to chair the conference of this year. So always we have the knowledge of the whole group. So especially I want to thank Antonio. This is the person who trusted in me to be the chair of the conference this year. Also Jose, since I knew him, he exploited my knowledge. No, he really trusted me. And also Pietro, he's my great friend, my professor, and my guide. When I have too many things in my head. So I really want to thank the whole team in Periso and Fisaude for this amazing conference. So I really can't wait to see you in Colombia. Do not be scared. Colombia is great. It's going to be amazing. You can enjoy the best beach in Latam, a great beach, sea, very nice, smiley people. And the party is last night. This we can also have in Colombia. So it's going to be 3 days of great information. Thank you so much and have a good evening. Thank you. Thank you so much. It's been an amazing conference. And it's gone beyond our expectations. It's been all beautiful in terms of organization. So thank you so much, Felipe. I want to thank all the speakers. So I want to thank everyone for the organization with Fisaude and everyone. So as I said at the beginning of the conference, so it's important to share always, and we're going to do this more and more. So it's been so interesting in terms of individual therapies for a therapy, and also in terms of a global treatment of a patient, and in terms of medicine and personalized medicine. So this very last one is the most relevant effect that we see here in this conference. So I really want to thank you all, guys. So we've seen all these aspects in the debates, and it's all been very interesting. And we've seen how you all and all the participants, you guys wanted to experiment new pathways, as Felipe was saying, because we are constantly evolving. So again, thank you, and I really encourage you to participate with Periso Academy to gather clinical data and to participate in different clinical studies to have the basis for our research, because obviously this is what we really need. We need to have a structural basis, especially in the case of innovative treatments. So there is also a lot of fantasy sometimes, and we need to have scientific fantasy. So those who develop new protocols are always based on science, and it's always our people who understand technology, so we can have the courage to explore new possibilities in the future. So I'll finish here, and I want to thank you by announcing that we are working to build the first international society on diamagnetic therapy, where we will have people using this technology. These will be physicians, physiotherapists, but also technicians and experts in physics, in mechanics, and everyone that can be related to the diamagnetic technology. And we'll have all the different applications that we cannot even think of as of today. So that's why we need the support of all of you, and also external professionals. So I thank you all. Right, thank you so much. It's been 2 very intense days with very special speakers, and we're learning a lot, and we have much more to learn. It's a great pride to see how the room was totally full yesterday, and still today we're finishing, and still the room is quite full. So this is very important for us, and it's a big dream for Paraiso. It's a great momentum. And I can just thank all the people yesterday and today. And a special thanks to Felipe for his great job, and Pedro Romero. I want to thank all the Fisaude and Paraiso team, because I cannot do everything alone. So I need to have my whole team to support my ideas. And I want to truly thank that, well, of course, Fernando. He did a great, very special job. So a big round of applause to him. Thank you. I see the counter is in red. I don't know if it's me. Great. So thank you so much. I want to thank all the speakers. It's been really amazing. It's been astonishing, with all the papers at the scientific level, and also it's been amazing to meet you guys as people, as persons. So it's been amazing days, of course, with a lot of stress to get everything perfect, but it's not a surprise, because I had already heard of this, and so I've met amazing people. So this makes me think that here we're starting a new pathway with new horizons, really important for all of us. And also want to thank the collaboration with Paraiso. It's been very easy from the very beginning. We understood each other very well. So people are in Switzerland, Brazil, Spain, and traveling all over. But the collaboration was very easy, and it was a great honor to organize this event. So I also want to thank all the Fisaude team. And also a big round of applause for Lola and Fernando. Thank you. Lolo, please, if you can come up. So, if you can come up. Great, thank you so much. I can only thank Fisaude and Paraiso for allowing me to be the master of ceremony in this conference. So it's been a great pleasure. So now we're going to finish our second International Congress on Diamagnetic Therapy. Thank you so much for your attention, and we'll see you guys in the third conference that we will have in Colombia. Thank you so much, and see you guys soon.